मैम अपन दो जन बोलते वक्त
Good morning to the esteemed gathering. I'm Ms. Dipali Gumrud, still privileged to welcome you all on behalf of Srimati Radhika Bai Mege Memorial College of Nursing to the National Virtual Conference on Integration of Nursing Education and Competency-Based Clinical Practices, Need of the Hour.
at last this beautiful day has arrived. I am sure all have eagerly waiting for this day. Behalf of Srimati Radhika Bai Mege Memorial College of Nursing,
I, Ms. Ruchira Ankar, take this opportunity to welcome all eminent speakers, Chairperson and Mrs. Ashwini Khope, Associate Professor, Srimati Subhadra Jindal College of Nursing, Pune, observer for today's conference, and all participants of this conference. I request all participants kindly submit your pre-test on given link. I request all participants kindly submit your pre-test on given link.
Dear participants, it is compulsory to all feed pre-test form.
मंदिरातून. रक्षा तुलीप जाशील इकडं होय. ते कुठं गेली इकडं. फोन लावला होता का? हा आजी फोन केला होता. फोन केला होता. हे मी नर्सिंगच्या याचं थोडस चालू आहे सांगा ना. हो रिन्युअलचं समजते का?
अजून हे बघ
तुझं पण आलं करून दे ना. Dear participants, it's kindly request to fill the pretest form. It is compulsory to all. Dear participant, it's compulsory to all to fill pretest form. Dear participant, it's compulsory to all feed pretest.
Nursing as a profession and discipline utilize knowledge derived from art, science, humanity, and human experience. The modern nursing curriculum is a combination of different disciplines that accelerate the patient return to health and to maintain it. Nursing science incorporates clinical competence, critical thinking, communication, teaching learning, professionalism, and cultural competency. Nursing competency includes core ability that are required for fulfill one's role as a nurse. Therefore, it is important to clearly define nursing competency. To establish a foundation for nursing education curriculum, having competency leads to an improved quality of patient care and increase patient satisfaction with the nurses and help promote nursing as a profession and improve nursing education and clinical nursing.
So let's start our today's session with full enthusiasm. The starting point of all achievement is desire. So our desire is to make you understand the whole topic in an effective manner. And for today's that speaker, Dr. Seema Singh, Principal Shri Radhika Pimge, College of Nursing, will introduce on overview of integration of nursing education and competency-based clinical practices. The chairperson for this session is Mrs. Indu Alvatkar, Principal Srimati Radhika Vai Mege Memorial School of Nursing, Savangi Mege Vardha. I request to Mrs. Indu Alvatkar, Principal Srimati Radhika Vai Mege Memorial School of Nursing, to introduce our Mrs. Indu Alvatkar is currently working as a principal at Srimati Radhika Vai Mege Memorial School of Nursing, Savangi Mege Vardha. She has obtained her master's degree from Datta Mege Institute of Medical Sciences, deemed to be University, Savangi Mege Vardha. She is gold medalist in MSc Nursing in Community Health Nursing. She has 30 plus years of professional experience in a variety of clinical teaching, research, administration, and management settings. She has attended, participated, organized, and conducted various workshops and conferences at state and national level. She is life member of TNA, NSS, NRSI, and many more nursing societies. She has presented number of paper and poster in various conferences. I request to Mrs. Indu Alvatkar, Principal, Srimati Radhika Vai Mege Memorial School of Nursing, to introduce our speaker of the day to our esteemed participants.
Thank you, Dipali. I am audible. Good morning, one and all present over here for this national conference. Now I am going to introduce today's first speaker, Dr. Seema Singh. Dr. Seema Singh is currently working as a principal at Srimati Radhika Bai Mege Memorial College of Nursing, Savangi Mege Vardha. She has 20 plus years of professional experience in a variety of clinical teaching, research, administration and management setting. She has obtained her PhD degree from DMIMSDU. She is recognized as a UG, PG, Fellowship and PhD supervisor. She is member of TNI NSS Society of Midwife in India. She is UG and PG examiners and evaluators. She has written books, published many research and review articles in various national and international poster in various conferences. Speaker as in Maharashtra Nursing Council and various national and international conferences, workshop, etc. I would like to request Dr. Seema Singh kindly proceed her presentation.
Thank you very much, Indu Madam. A very good morning to one and all. I take the privilege once again to welcome all for this 2 days national conference on the topic integration of nursing, education, and competency-based nursing practices. So today's our topic, overview of integration of nursing education and competency-based clinical practices. So if we actually see, we say it is new, but if we go to the history and we see it, it is not new, but it is something that we need to reorient ourselves once again. So we'll just see what it is in a brief way so we can understand the other session much more better in the 2 days conference. So with the introduction, I'll bring competency-based education, that is known as CBE, is also known as outcome-based education, has seen many phases in modern history: invention, implementation, rejection, and revival. Nursing education too had begun a shift towards a competency-based curricula. As we know, the Indian Nursing Council has made us also to follow this competency-based education. If we go to in 2007, 10 Kate and Checkley define competencies as a holistic term that refers to an overall capacity or ability to do something successfully. So it means anything that we are doing it with full mind, heart, and soul in the full holistic manner, that is termed as a competency. Henneman and McCoy in 2009 believes that successful CBE implementation an attitude to enter the workforce, as when we are preparing our students, they should have knowledge, they should have skill, and they should have a positive attitude before they're entering into the workforce or into their job area. So what is the meaning of integration? It is the action or process of combining 2 or more things in an effective way. As we have seen that it is integrating 2 or more things together to in an effective way to bring a better outcome. What is the meaning of competencies? Competency is a set of demonstrable characteristics and skills that enable and improve the efficiency of performance of a job. So we see it is not only the learning, it is not only the things that we are going to do it. It is the characteristic, it is a skill, it is the knowledge, and we can say the student should be overall from inside to outside will be able to perform his work in his job area with all the learning things that he needs to do it. When we say competencies are not skills, but they are similar to the skills. How? Their skills are learned, while competencies are inherited qualities in an individual possesses, like collaboration skill, knowledge, and ability. So we see that individuals have this difference. And when we are teaching our students these competencies, or when we are making them to learn what are these competencies, we are making them to learn these collaborative skills, their knowledge, and their ability to do their work in their work area efficiently. The difference between competency and outcome can be highlighted in the words need versus want. Competency says what is need and outcome says what we want. So it is need versus want. And an outcome is defined as a skill and qualities we want the student to have, whereas a competency is defined as a skill and qualities we need healthcare professionals to have to care for patients safely and effectively. So this is the difference between these two. Competencies are intended to help guide the educational preparation of nurse teacher, ensure educational qualities and accountability, and ultimately contribute to improving the provision of nursing care and outcome of health services. So this is overall, it is preparing the teacher nurses also, and they are making their students to improve the provision of nursing care and overall outcomes of the health services. Now we see if we have read the philosophies and the other things given by the INC, it is given by them that a nursing as a profession and a discipline utilizes knowledge derived from art, science, it is physical, biological, and behavioral, humanities, and human experience. Nursing science incorporates clinical competence, critical thinking, communication, teaching learning, professionalism, and caring and culture competency. So we see it consists of many things that a nurse should learn in his or her student period. Nurses collaborate with other health disciplines to solve individual and community health problems. So we need to gain the competency when we are talking with the things we are going to have in our health sectors. Nursing facilitates evidence-based practice, compensate caring among its practitioners in response to emerging issues in the healthcare and new discoveries and technologies in profession. Nursing practices require personal commitment to the professional development and lifelong learning, which we are very far away, but this is the fact. We are not seeing the professional or personal commitment to the professional development, and we just fix ourselves to put each other up and down. So we need to focus on that. Nurses collaborate with other health disciplines to solve individual and community health problems, as we have seen before. Nursing facilitates evidence-based practice, compassionate caring among the practitioner in response to emerging issues in healthcare and new discoveries and technologies in profession. Nursing practice requires personal commitment, as we have seen before, and long-time learning also. Undergraduate nursing program is a broad-based education with an academic curricular framework specifically directed to the development of critical thinking, skills, competencies appropriate to human and professional values. So when we are teaching or when we are giving our undergraduate nursing students, these things are very important. Along with this, blended learning approach comprises experimentation learning, reflective learning, scenario-based learning, and simulated learning is also inbuilt. So it is very important for our students to learn all these things. And this is not possible if we don't inbuild the competency within our students. Teaching learning process encourages mastery learning, modular, self-directed, and self-accountable in choice making in terms of elective courses. So if we have gone through our curriculum, which INC has given, we find this elective courses also. Now it depends on the students what course in this elective courses they select in which term. The program prepare its graduate to become exemplary citizen by adhering to the code of ethics and professional conduct at all times in fulfilling personal, social, and professional obligation so as to respond to national aspiration. Health and community orientations are provided with special emphasis on the national health programs. National health programs and national health policy directives to achieve the universal health care for all citizens of India and also abroad, because our nurses also focus on going abroad. The main goals of our graduates would be provider of a care with beginning proficiency in delivering safe care, coordinator, manager of the care by being active participants of interprofessional team and member of a profession, demonstrating self-responsibility and accountability for practice as well as to support the profession. So all these things our graduate needs to learn when they are in their training program. And when we are as a teacher, we need to teach them all these things. The faculty has the responsibility to be role models and create learning environment that facilitate cultivation of critical thinking, curiosity, creativity, and inquiry-driven self-directed learning and attitude of lifelong learning in students. Learners and educators interact in a process whereby students gain competencies required to function within their scope of practice. So when we are there as a teacher or we are the faculty who are responsible to be the role model for them and create the learning activities that will state how to create the student or how we develop them in the situation of critical thinking, curiosity, how they can be creative, how they can be self-directed by learning and gaining the knowledge. And they should have or they should develop an attitude of lifelong learning. So they can always go on learning. They should not stop at one place and they said, sorry for interruption. So we were looking at the aims that are given by the Indian Nursing Council. So first one was to produce the knowledgeable, competent nurses and midwives who have clear critical thinking skills, who can be caring, who are motivated, have assertive and well-disciplined, responding to the changing needs of the profession, healthcare delivery system, and society. This is the first aim given. Second aim, prepare them to assume responsibilities as professional, competent nurses and midwives in providing promotive, preventive, curative, and rehabilitative healthcare services in any healthcare setting. This is the second aim. Third aim says, prepare nurses and midwives who can make independent decision in nursing situation within the scope of practice, protect the rights of individual, and group and conduct research in the areas of nursing practice and apply evidence-based practice. Fourth aim, prepare them to assume role of practitioner, teacher, supervisor, and manager in all healthcare settings. So this is the fourth aim. Now, the objectives given by Indian Nursing Council for the competency-based nursing curriculum. The first is utilize critical thinking to synthesize knowledge derived from physical, biological, behavioral sciences, and humanities in the practice of professional nursing and midwifery. Second objective, practice professional nursing and midwifery competently and safely in diverse settings, utilizing caring, critical thinking, and therapeutic nursing interventions with individuals, families, populations, and communities at any developmental stage and with varied life health experiences. Third objective is provide promotive, preventive, restorative health services in line with national health policies and programs. Fourth is integrate professional caring into practice decision that encompasses the values, ethical and moral and legal aspects of nursing. Fifth objective says respect the dignity, worth, and uniqueness of self and others. Sixth, apply concept of leadership, autonomy, and management to practice of nursing, midwifery to enhance the quality and safety in the healthcare. Seventh objective says utilize the latest knowledge and skill related to information and technology to enhance the patient's outcome. Eighth, communicate effectively with patients, peers, and all healthcare providers. Ninth objective, utilize the requisite knowledge, skills, and technologies to practice independently and collaboratively with all health professionals, applying the principles of safety and equality improvement. 10th, integrate research finding and nursing theories and decision making in evidence-based practice, which is the need of the hour. Accept responsibility and accountability for the effectiveness of one's own nursing and midwifery practice and professional growth as a learner, clinician, and a leader. This is the 11th objective. 12th objective says that participate in the advancement of the profession to improve the healthcare for the betterment of global society. Now, these were the objectives that are given by the Indian Nursing Council. If we go to the each aim and each objective, that shows that there is a really need of integration with the competency-based education also. So when we are teaching our students, we have to be very effective and emphasize on their competencies so we can prepare our students for their future workforce. The core competencies for nursing and midwifery practices by BSc graduate or for BSc graduate that is given by the Indian Nursing Council, patient-centered care, provide holistic care recognizing individual patient preferences, values, and needs that is compassionate, coordinated, age, and culturally appropriate, safe, and effective in care. Second competency is professionalism. Demonstrate accountability for the delivery of standard-based nursing care as the council standards that is constant with moral, altruistic, legal, ethical, regulatory, and humanistic principles. Third, competencies, teaching and leadership. Influence the behavior of individuals and groups within their environment and facilitate establishment of shared goal through teaching and leadership. Fourth is system-based practice. Demonstrate awareness and responsiveness to the context of healthcare system and ability to manage resources essential to provide optimal quality of care. So this is the fourth competency that has been given. Fifth competency says health informatics and technology. Use of technology and synthesize information and collaborate to make critical decisions that optimize patient outcome. Sixth says communication. Communication is very important. It interacts effectively with patients, families, colleagues, fostering mutual respect and shared decision making to enhance the patient satisfaction and health outcomes. Seventh is teamwork and collaboration. Function effectively within nursing and interdisciplinary team, fostering open communication, mutual respect, sharing decision making, team learning, and development. The eighth competency says safety. Minimize the risk of harm to patient and providers through both system effectiveness and individual performance. 10th competency says quality improvement. Use data to monitor the outcomes of care processes and utilize improvement method to design and test changes to continuously improve the quality and safety of healthcare system. That can be done only if we look into the data which we are having in our hand and we can find out where we need to improve. 10th is evidence-based practice. Identify, evaluate, and use the best current evidence coupled with clinical expertise and consideration of patient preferences, experience, and values to make practical decisions. As we are in the modern era, evidence-based practice has led the world very high. So we need to update ourselves according to evidence-based practice. So these are the 10 competencies that are given by the Indian Nursing Council. First is, again, I will read out once again, patient-centered care. That means we have to emphasize the patient. We teach our student that patient is the first person or most important person in the hospital. So we have to focus on patient-centered care. Second is professionalism. In this, we have to respect our profession and we have to be a professionalist as the profession needs to go forward. Teaching and leadership. We have to teach our students to learn and take a leadership role in every steps when they are working in the clinical field. System-based practice. We have to follow the system-based practice as every hospital or institute have their own system. So we need to follow whatever the mandatory updates are given by them. Health informatics and technology. These are the things that we need in the current era because without these, we are nothing and we cannot move forward. Communication. The way of communication keep us connected or disconnected from our patient, our colleague, and our team members. So communication is the most important competencies of nursing practice. It is how we do with our patients and we can move forward. Next is the teamwork and collaboration. Without teamwork and collaboration, we cannot move forward. 24 hours, a single person cannot work. So therefore, we need the teamwork. A team in the healthcare sectors is a very big one. So when we are working together, we have to respect each other. We have to communicate properly. Then only we can move forward. Safety. Safety of the patient and individual is very important when we are working in the particular areas. Quality improvement. Quality improvement can be done only if we are doing the researches, we are finding out our pits and holes, where we are falling short, where we can do the improvement through researches, and we can find out the ways to overcome that barriers. So quality improvement is also important aspect. Next, and the most important one is evidence-based practice. As the world is moving forward, and I have told, we are working on evidence-based practice. As evidence-based practice is very important aspect when we are moving forward. So when I was doing my PhD, this was my major area in which I have done my PhD thesis. That was the evidence-based practice. And really, when we go into the clinical area, when we find out and we do the researches, we find a big gap between this. So we need to work on this. We have to learn about it, how to overcome it, and we have to generate the evidence and work and improve our nursing profession by the evidence that we have generated and making it into the practices. So as Datta Mege Institute of Medical Sciences, we have taken initiative. We have in hospital, Acharya Vinoba Bhave Rural Hospital, where our students are posted. We have converted all the procedures of nursing, and we have tried to do it or turn it into evidence-based practice. And we are not only teaching the students, but we are teaching our staff nurses also, because they are the one who helps the student to work in this clinical area. So this was a brief introduction about the integration of nursing education and competency-based education into the clinical practice. If any questions are there, most welcome. Sanjay sir, good morning. Sir, you're muted.
Yeah, good morning, Seema. How are you?
I'm fine, sir. How are you?
Yeah, I'm fine.
Nice to see you, sir.
Yeah, same here after a long time.
Yeah, sir. Almost 13 years.
Right, correct.
If you have got any question, please drop into the chat box. It can be cleared later on. Thank you.
For BSc nursing graduates. She also focused on the faculty has the responsibility to be role model for the students. She also emphasized on the competency-based nursing education helps and guide the students to become a competent nurse. Thank you, Dr. Seema Singh. Thank you once more.
Thank you, madam, for sharing your deep knowledge with us. Your session was full of motivation and valuable knowledge. I hope all the participants had enjoyed this session.
Principal, Gokhale Medical. Dr. Mohammed Hussain, Vice Principal at Gokhale Medical Society. He has 15 years of professional experience in variety of nursing setting. Currently working as a BOS chairperson at Maharashtra University of Health Sciences, BOS member at DY Patil University of Navi Mumbai. He is member of Finance and Account Committee, Maharashtra University of Health Sciences, member of Student Welfare for North Maharashtra, member of BOR, and PhD guide in Rajasthan. He has worked as a examiner, evaluator, curriculum consultant, and developer. So I request Dr. Mohammed Hussain sir to introduce our today's speaker, Dr. Sanjay Pirapurkar sir.
Network problem వస్తుందా?
मोहम्मद सर आपका माइक ऑफ है सर, योर माइक इज म्यूट. Hello Mohammed sir, your mic is mute, please on it. Mohammed sir, please unmute yourself. Unmute yourself, sir.
ಕೊಡು
Mohammed sir. Mohammed sir, you can start now.
मिस्टरांना मोजून द्यायचं जुने नाहीये 10 ते होतेच नाही ते 2-3
Then YouTube only. Mute ಮಾಡ್ತಾರೆ ಮತ್ತೆ ಮಾಡಕ್ಕೆ ಮತ್ತೆ ಲೇಟ್ ಮಾಡ್ತಾರೆ.
Principal, KLE Society Institute of Nursing Sciences, Hubli. He has obtained his PhD degree from KLE University, Belgaum. He is having 20 plus years of professional experience in a variety of clinical teaching, research, administration, and management setting. His involvement in the university activity, which include the BOS, AC, examiner, evaluator, observer, and other committees, formally serve as member of Academic Council, Board of Studies for UG and PG Nursing, member for selection of inspector, National Editorial Board member, Professional Advisory Board and Extension. He is PhD and PG Nursing Guide. He has published 30 research paper in referred journal in addition to textbook of cumulative record book for GNM, BSc Nursing, Post BSc Nursing, and BSc Nursing. So now I would like to request Dr. Sanjay sir to please start with section.
ಇದು ಮಂಜು ಹೆಂಗೈತ್ಲ ಹದಿನೈದು ಇಶ್ಯೂ ಅದು ನಮ್ಮ ಕಡೆ ಹ್ಮ್ ಬರ್ತಾನೆ. ಓಕೆ ಓಕೆ ಸ್ಟಾರ್ಟ್ ಮಾಡಿ ಓಕೆ.
Sanjay sir, please start your session.
Yeah, 1 second. Hello, good morning to one and all. Anyhow, I take this opportunity to thank the organizers of the National Virtual Conference, Srimati Radhika Bai Mege Memorial Nursing College, Varda, and the Nursing Scholars Society for giving me opportunity to be a part of this conference as a resource person. And my topic which is given to me is the implementation of the integration of the nursing education and competency-based clinical practice. So already in the first sessions, we have heard about the basic overview about the competency-based clinical practice. The slide change. Introduction, then concepts of integration, and we'll be seeing the core competencies of the nursing and the competency domains, and implementation of the integrated of nursing education and competency-based clinical practice, and dealing with the resistance and gaining support, and the implementations of CP in the nursing education, and lastly, we'll be concluding it. And the objectives of my sessions will be, at the end of the session, all the delegates will be able to understand the concept of integration, describe the core competencies of nursing and competency domains, and understand how to create awareness and commitment, and demonstrate how to integrate nursing education and competency-based clinical practice, and deal with resistance and gaining support, and implement the CBCP in the nursing education. So coming to the introduction, there has been considerable progress in the nursing. Yeah, there has been considerable progress in the nursing over the past decades, especially in the areas Yeah, so we have seen that there is considerable changes in the nursing education and the service, There's a number of nursing colleges has been increased, and the GNM syllabus has been revised, which was from the 3 years to the 3.5 years. And the BSc curriculum, which was a yearly basing system, has been changed to the semester system. And many of the mandatory and the elective modules has been adopted over there. So there is a drastic changes which has taken place into the nursing education. And we know that the nursing is a vital service provided to the mankind by the dedicated nurses. So hence the nurses should be at the front line to review and optimize the healthcare delivery. So today we know that among all the health professionals, 51% of the health professionals are only the nurses. But it is a very sad part to say that the nurses are involved very less in case of the policy making decisions. And the second thing is the nurses should be promoting the higher quality of care. And this higher quality of care can be provided by the nurses should get updated after their graduation through the conferences and all those things, and they should implement those things, knowledge and skill in improving the quality care. And the nurses should develop a new roles. So always working as a staff nurse or a senior nurse. Apart from that, there are a new roles needs to be developed, like the nurse practitioners, nurse educators, and nowadays we have come with the wellness clinics, that is a community health officers are going to come up. Like that, the new roles has to come up, like a diabetic nurse. So the new roles has to be evolved and take up the leadership qualities more intensively. The major issue what we find into the nursing is the leadership crisis. We have n number of associations, we now have a n number of this, but the leadership qualities lacks in any of the nursing profession, either into the education or into the clinical sector. That's the reason today we see that the major, all the decisions related to the nursing policies, nursing rules and regulations are made by the non-nursing professionals. We all know the COVID pandemic which took place either at the central level or at the respective state level. Hardly a very few nursing professionals were involved in the policy making, rules and regulation framing related to the prevention and the curative for the COVID care. So hence the leadership qualities is most important. And these all qualities, what the nurse requires, this can be effectively managed by the integration between the nursing education and the clinical practice. So today we find that there is no integration between the nursing education and the clinical practice. In the education side, we have a teachers who train the students and then they graduate and then they go into the clinical area. And at the clinical area, the nursing supervisors, the nursing students again train them. So there is no correlation or the integration between the education and the clinical practice. What we teach at the education sector, whether the same is practiced into the clinical area or no. If any new innovative things has taken place into the clinical practice, again, it should be brought back into the nursing education side and again, it should be taught so that the integration is mandatory. And in practice, we can adopt the competency-based clinical practice, CBCP, for the effective services to the client. In my next coming slides, I'll be telling in detail about the competency-based clinical practice. And so now we shall begin with the implementation of the integration of the nursing education and competency-based clinical practice. The basic domains, that is the implementation. All of us know that the implementation is the process of putting a decision or a plan into the action. Any plan we make it and what we execute, that is the implementation. And integration is the way of uniting a part to find a whole. As I said, that nursing education is at one sector and the nursing practice is at the one sector. So we have to integrate both the nursing education and the practice. The teacher should be involved into the clinicals also, and the clinical nursing supervisor should be also involved into the teaching sector also, so that there will be integration between the education and into the clinicals. And the nursing education, it refers to the formal learning and the training in the science of nursing, either it may be a diploma, graduation, or a post-graduation, or the doctorate level. That is the integration of the nursing. So integration, that is a process by which the members of a discipline share their knowledge, experience in achieving a common goals, such as the student learning, a patient care, and the scientific advancement. So the teacher teaches, the students learns and delivers the same care over there. And as per the changing scientific advancements, again, it needs to be adopted into the care activities. So that's the integration. Next is a competency-based clinical practice. So this competency-based clinical practice is the mix of skills, knowledge, attitudes, and abilities. Mainly the four things, that is the skills, knowledge, attitudes, and the abilities that each nurse must possess to perform acceptably those duties directly related to the patient care in the specific clinical context and in the given circumstances in order to promote, maintain, and restore the care. So we can say in a few and the short words is it is a mix of skills, knowledge, attitudes, and abilities to give a better patient care for the better outcome. The examples is like the history collection is there, physical examination, administration of medications is there, providing of care, and the health education. So the same thing we shall see here, the skills. So all of us know that the skills means it is the ability to perform an action with the determined results. So we know that for example, if you take as IV cannulations, there will be few nurses or a nursing students who will give the IV cannulation with only one prick, and there might be few students or the few nurses may be there who will take a multiple pricks to give the IV cannulations. So that is the skill. The repeated practice and will increase their skills and they can be proficient. And in the competency, always there is a mixer. They will be thinking that the skills and competency both are same. Actually, the competency, that is a skill, is a part of this competency. So in a competency, we have the knowledge, attitude, skills, and the abilities. So the knowledge, we even though he has the best skills over there, if he doesn't have the knowledge about the procedure, how to do a IV cannulation, if he doesn't have the knowledge about the anatomy of the artery and the physiology of the artery, then the skill cannot be in a proper. Then the next is the attitude. So if he has the best knowledge about the IV cannulations, he knows every skill over there and directly go to the patients and takes his hand and start doing the IV cannulation, the patients will go into the stress, or he will be thinking that what the nurse is going to for my hand. So that's the attitude. So means what you think, what you feel, and what you behave. So when you want to do a IV cannulations, you can go to the patient over there, you can smile at the patient, talk freely and tell about the procedure. So that is your right attitude and behavior makes your skill proper. And the next is the ability. So the ability is nothing but the mental or the physical power that makes it possible for any activities. So you should have a positive thinking that whatever the procedure I'm going to do it, I will be successful and I will be doing the best for that. So are you able to do those activities or no? So if you have these knowledge, attitude, and skills and the abilities, then we are able to give a better comprehensive nursing care. So let's see what is this integration. So integration involves the unification of the clinical practice and nursing education to improve the quality of care. That is unification. Unification is nothing but the bringing together. So bringing together the clinical practice and nursing educations, then we can give the quality care. So we have many of the core qualities which can make the integration successful. That is a strategic thinking. So it is a common thinking applied to the individual to achieve the resulted goal. So you have to think on the first phase. If I do it, what will happen to the next? Then what is the next step? So the continuous thinking has to be there till your desired goal is met over there. Then you should have the emotional intelligence. That is the ability to understand, use, and manage your own emotions in a positive ways. Sometimes the patient may say one or the other things, or the students may say one or the other things. So you should not get angry or upset or sad, so that mood swings should not happen. You should have a control over your emotions and you should be used in a proper way. The hospital industry and the sector expertise. That is, many of the patients will be coming. You should be knowing about the healthcare schemes also, pharmaceutical industries also, so that you will be able to explain to the patient under which scheme you can admit it, so that it will be beneficial for you. And the relationship building. So always a nurse or a nursing student should have a proper building relationship, whether with the patients or a co-workers or the healthcare team members and the family members. And the global and the cultural competencies. So it is a multi-dimensional view, knowing about the combination of the knowledge, skill, and attitude, and the present issues which is going on into the global, and the cultural differences what the people are having. These all competencies the nurse or a student should have it. Then the business and the financial acumen. So even the nurse or a nursing student should be knowing about the basic financial and the accounting principles. As we know, the nurses are responsible for making the budget of the hospital or the nursing services or the nursing care, what they are going to do. In the same way, the faculties also will be responsible for preparing the budget of the nursing colleges. And the next is the quality, it should be a leadership qualities. Means it is a process of directing, guiding, and influencing the behavior of the workers. So many of the nursing professionals, because of their attitude and because of their behavior and because of their power, we can recognize them as a leader. So they influence the students, they influence the nurses, and they are called as the role models, and they become as a leaderships. And the integration and the professionals. So the main core principle of our nursing is the integrity, that is being honest and have the strong moral values. And to maintain the professionals, that is the morals has to be followed, and the code of conduct of the nursing professions needs to be followed. So these are the objectives. That is, if we correlate with all these integrations, we can achieve the optimal patient care and the sound education for the students through the qualified faculties, and we can create a very healthy learning environment, and we can bridge the gap between the nursing education and the clinical practice, which is more there existing into our education and clinical practice. And we can foster the commitment and accountability of the student also, as a nurses also, and even the teaching faculties, and to evaluate the quality of nursing education and the practice, and to promote the spirit of inquiry and the research into the nursing. So in nursing, the clinical competencies is a central issue for the patient care, and a clear understanding of the concept is the critical for the nursing education and the clinical practice. So these are the nursing core competencies which we are going to say. So already Dr. Seema in the first session, she has said elaborately about the core competencies which are there, which is given by the Indian Nursing Council. And this is the best syllabus of the nursing we have found, in which the core competencies has been included, especially these 10. So I will not go in detail about these core competencies, because already Dr. Seema has dealt about it. That is a patient-centered care. That is a holistic care has to be given based on the patient's preferences, values, and the needs. And the professionals, we should maintain the morals and the code of conduct, ethics, and the legal according to the humanistic principles, and the teaching and the leadership. So our behavior should influence the individual or a group, so that we can meet to the individual goals. And system-based practice. Every hospital, corporate sector, or it's a government hospital sector, we have a different context of giving the healthcare, and different sources will be there. So we have to manage with the system-based practices, and the health informatics and the technologies. So we should use the technology and synthesize the informations, and which can be used for a critical decision makings. And the communications, we should interact everybody with the mutual respect. It may be patient or the colleagues or maybe the other team members. And we should work with the teamwork and the collaboration. So if you work with the team, then only any goal you want to achieve it will be successfully achievable with the teamwork. And you should take care of the safety of the patient and the providers. It may be the nurses or the any other persons. And the quality improvement, use these data to monitor the continuous quality improvement is taking place in this. And the evidence-based practice. So continuous research has to be done, and based on the research and based on to the evidences, again, the practice has to be continued. So next we shall see with the competency domains of the learning. All of us know this KAP, and majority of our PG students do with this knowledge and attitude practice studies. That's a knowledge is the cognitive, that is a cognitive domain. So we say it is a process of just understanding or developing the intellectual skills is nothing but the knowledge. And the affective, that is the attitudes and the behaviors. So whatever the feelings we have, whatever the emotions we have, that comes as an affective domain. And next is a psychomotor. It includes the physical movement and the coordination and the use of the motor skills. We call it as the skills or the continuous practice. Then the main three elements of these competencies is The first element is the ability to understand the people. So it may be a nurse or a student. We should have the ability to understand the people. That is, we need to apply our knowledge, what we have learned it over here, or it may be the in case of history collections or whatever the things is there, and in case of the building the interpersonal relationship. And the next element is the ability to provide the people centered care. So we have understood the people, we have got all the informations, we have done a physical assessment, we have done the history collections, everything. And based on that, now we are going to give a centralized center care and the individual care to the patient. And this we have to practice ethically and morally under our profession's code of conduct. And we have to collaborate with the other professionals. And the next element is the ability to improve the nursing quality. So expanding our professional roles, we can be as a nurse educator, we can be as a nurse advocate, and we can do all those under this capacity and build our knowledge and improve the next quality care. Then the next is we have the competency domains. It is expected that the integrating the competency domains and core competencies within the domains will help. That's the number one is facilitating the development of comprehensive educational programs, and it is for the better assessment methods and reducing the competition of the learning outcomes. So this is the concept, that is a nursing education and a competency-based clinical practice. If both these things are followed, then we can give the quality nursing care. So hence we require a sensitization and the training of the clinical nurses and the faculty regarding to the competency-based clinical practice. And for this, the first and the foremost is the creating awareness and commitment to introduce the integrated model. The administrators and the faculty should understand the concept implementation process of integration, and the heads of the institution should become committed to the integration and its benefits and outcomes. So usually we see that the heads of the institution or the heads of the nursing hospitals, usually they, whenever any new change takes place over there, they feel hesitant to integrate those things and adopt the new things. So they like to follow the old, whatever the things is to be followed for all these years. So first they should committed for the change and the integration, and communicate the advantages and challenges to all the involved into the integrations. And lastly, we have to prepare a team for holding the meetings, discussions, and the implementations. So now coming towards the implementations of competency-based clinical practice, there are mainly the 3 steps to be followed. That is, the first one is identification of the competencies and the contents. Second is the program organization and the assessment planning. And the third is the program evaluation. So coming to the first one, that is the identification of the competencies and the contents. So here we should ask ourselves that what competencies we want to evaluate, which competencies we want that the student or the nurse should be capable, and why these competencies is needed for those persons, and who are the persons who are going to deliver these competencies, either the teaching faculties or the nursing supervisors or with the nursing students, and where it has to be done, either into the teaching sector or into the clinical sector or into the simulations lab, and what is the actual time and the locations when it has to be done, and on whom it has to be done, whether it is to be used as a mannequins or it has to be used as simulators or it has to be used onto the patients. So these all, first we have to do the identification of the competencies and what contents needs to be prepared. So I have previously said it, these are the core competencies which we are going to identify, and based on that we are going to. And the second thing is the curriculum map. That is in identification of competence and the constituencies. That is the first we have is the core competencies, and the second is the curriculum map. And the best example for the curriculum map is our Indian Nursing Council syllabus, in which all the core competencies has been specified over there. And when we go into the syllabus also, it is clearly mentioned over there what is the learning outcomes are there, and which are the teaching learning methods are there, and how the assessment has to be used over there, and how it has to be evaluated. So those all things are there. So a sample curriculum plan has to be prepared, that which competencies and which learning has to be adopted. So for examples, we have the education strategies, course contents will be there, and assessment will be there, educational environmental will be there, and individual student and personal timetable progress also can be mentioned into the curriculum plans. And the second part of the implementation is the program organization and the assessment planning. So here in terms of the planning, the steps involved in the process, that's the first is a decision need to be taken to explore the possibility of integration. So first you need to speak with the hospital, need to speak with the management, and need to speak with the nursing colleges, whether it is capable to be implementation. The committee needs to be constituted. So the committee can be the chief of the medical services, the principals of the educational institutions, nursing superintendents, professors of the College of Nursing, and assistant nursing superintendents, and the associate professor. Usually when the integration plan takes place, usually the nursing teachers involve only the teachings of the nursing people, but it should not be done in that way. It should be always utilized from the hospital sectors also, so that the equal contribution is there. Then the integration between the education sector and the clinical sector will be good. And then you have to prepare the orgogram. So these are the steps to be followed over there into the planning. That is, study the process, that how the process has to be done, who are the people should be involved over there, and assess that whether the feasibility of integration is possible at your setup of the hospital, and lay down the process to achieve the integration, and identify which are the possible hurdles which are taking place between the integrations between the education and into the practice. These are the activities of the committees which involved, that is a series of meetings has to be take place with all the members, and the brainstorming has to take place, that which are the competencies which we have to select it. Initially you can select with only few competencies, or only with a few ward or the few specialty, that it may be a medical surgical nursing. So only think about those things. Later on, once this competency based practice is adopted into one sector or a one specialty, then it can be gone to the others. Then discuss about these possible benefits, and the thoughts of concerns can be exchanged with each other, and the final it can be finalized. So that is, first is the identify the subject experts, that is from the teaching sector and into the clinical sectors, and recognize who are the persons who are going to supervise it, either from the teaching sector or the clinical sector, who are going to supervise it into the clinical sector, and categorize the clinical areas as per the size of the hospitals. So many hospitals, some will be 100 bedded, some will be 2000 bedded. In all and use flexible training approaches. So always you should have a flexibility in the time and the location, so that it will be helpful for both the nursing people who are working into the shift wise. And next is a create a learning environment to be a self-paced. A wonderful learning atmosphere should be created, as it may be a seminar hall, it may be the classroom, and based upon their paces also, that is the duty rotations will be there. So based on that, it has to be done. Then the third, in case of the implementation, is the program evaluation. So all of us know that we have a formatic evaluations, we have a summative evaluation. The same way, those all evaluation methods can be adopted over here. That is a periodical assess the learner's knowledge and the skills, and we have to obtain the feedback from the different categories of the healthcare professionals. So when we are doing the demonstration and to the college, the teaching faculty can see the feedback or see the skills, or whether they are presenting it demonstration properly. And once they go into the clinical area and they do those skill activities over there, we can collect the feedback from the nursing supervisor or the nursing officer who are working over there into that unit. And the meetings and discussions with the clinical and the teaching faculty has to be done, whether these competencies which has been trained into the education sector have been practiced properly into the clinical area or no. And the next is the measurement of the outcome. So in case of evaluations, we can do a periodical audit. So audit of any procedure also can be done, or audit of the patient satisfaction also can be done. So we have to do a periodical audits to identify whether the outcome is effective, that is a competency based practice is going on properly or no. Then the research can be conducted to identify any short terms or long terms, any issues are there. And interdisciplinary collaborations can also be assessed. And satisfactory completion is based on the achievements of all the specified competencies. So whichever the competencies we have specified and trained, so ultimately at the last moment, we are going to say that whether those all competencies has been fulfilled or it has been satisfactorily completed. So next we shall see with the implementations of the competency-based clinical practice into the nursing education. So in the nursing education, if you want to implement these things, the mainly we should have that is a setting up of the clinical, that is a skill lab, and identification of the skills, which all the skill competencies has to be trained. In the Indian Nursing Council syllabus, it has been clearly mentioned that there are many skills are there which has to be trained into the skill labs. That I will deal it in the next coming PPTs. Then the preparation of the checklist, skill demonstration, skill practice and skill drills, skill evaluation, and the problem-based learning, scenario-based learning, simulation, experiential learning, and OSCE. So coming to the first one, that is the skill labs. So all of us know the skill labs. It is a specially equipped practice rooms functioning as a training facility offering the skill-based training. So all of us know that in our colleges, we'll be having the nursing foundation lab. We have many mannequins over there. So in this skills lab, we can train the students related to the comfort devices, therapeutic positions, moving and turning of the patients, sponge bath, and we have a IV arm trainers. So these all can be kept into the skill labs and the students can be trained for all these competencies and the skills. And the next is identifying the skills. So our INC syllabus has already identified that which are the skills are mandatory required for our students and which have to be learned. For examples, when we see into the syllabus, we have is the mandatory skill they have to learn is a nasogastric aspiration or NG tube insertion, surgical dressing, colostomy care, and crutch walking, scrubbing and gowning and gloving. So these are the skills which needs to be identified so that these skills has to be trained up. Then prepare a checklist for the skills which you are going to train it. So whichever these competencies you are going to check it, so you have to prepare a checklist. So any procedure, if you make it, that is a colostomy care is there. So whole colostomy care procedure has to be written down into the paper, and in front of that, it can be ticked that whichever the procedure the student or a nurse is doing, whether they are doing it properly or no. That's a checklist. That is a preparation things. And the next, once the checklist is ready, all it is prepared, then we can go with the skill demonstration. That is the ability to demonstrate the skill and the procedure on any of the mannequins. It can be done. For example, it is a nasogastric aspiration or a nasogastric feeding or NG tube feeding. So the demonstrations can be taught, and this skill practice and the drills has to be taken. So continuous practice of these skills. Once you teach to the students has to sit into the skill lab and they have to continuously do all these activities. And if they are doing for more than 2 or 3 times, then they will be having these competencies and the skills will be developed and they can do it in a proper way. So, and based on this checklist, we can evaluate that whether they are doing the proper skill or practice procedure or no. Then the next is the skill evaluation. That is we have the evaluation form. When the skill is going on done by the student or a nurse, we can evaluate it that the individual is performing rightly or any deviations from the what we have been taught. And the next one is the problem-based learning. So nowadays we are using this problem-based learning many times into the clinical setup also and into the teaching. This problem-based learning is the teaching style that pushes the students to become drivers of their own learning education. So this is used in the real world issues. So that is before we used to have a traditional learning That is, we were told what we need to do. For example, I will give the pandemic situation is the COVID situations. So we teach to the student and to the nurses that the COVID has come as a pandemic, and the prevention part is wearing of the mask, social distancing, sanitization, and the vaccination. So our nurses or a nursing student memorize these things, and whenever the COVID patients comes, then they provide a health education related to the same. But in case of a problem-based learning, we can give them the problem and tell the student, let them identify what are the solutions they need to know about it. For example, we give a problem to them is the COVID cases have been increasing more into the hostels. If you give this is a problem to the student that in the hostel COVID cases are increased, then the student will start exploring that why the COVID cases are increasing more into the hostels. Whether the students are not wearing the mask, or whether they are not wearing the sanitization, or they are not maintaining the social distances, whether the room is overcrowded, or they are using any common facilities like a washrooms, corridors, or a dining halls. So they come with all other ideas. Then the lastly, common for everyone, but based on the problem this now they understand that it is mainly because of it may be the common washrooms, or the common corridors, or the common kitchen is used over there, or the common dining hall is there, and the sanitization is not done on a daily basis. These all things is a problem based learning. So we give them the problem and we tell the students to explore what are the different other ways to solve these issues. So in this way the students comes out with a creativity and comes out with a solution by himself, and he starts thinking about solving any problem. So that is about the problem based learning. Then the next is scenario based learning. So it uses the interactive scenarios to support the active learning strategies such as the problem based and the case based learning. A simple one, what we call it as a scenario based learning, is nowadays because the more number of COVID cases are increased in the initial first phase. At that time, it was difficult for the nursing students to send for the practical examination into the clinical area. So we used to give one case to the student over there and tell them to, based on this case, you can write the nursing year plan. It is a case based learning what we give it. Otherwise, we can give a big scenario also. For example, if you give as a scenario, the first learning phases we have to say is engage in a scenario. I will give just an example of a scenario is like a 28 years old woman attends to the coloscopic clinic after the abdominal smear test, and she is very anxious to know that what has happened to her, whether she is having a cervical cancer or no. So this is a scenario over there, and the smear test when it comes over there, she has a severe dyskaryosis, and his age is only 25 years. So in our first phase, we have to see that engage with the scenario. So we have to ask a mini history about her, when she has got married, and when she had the first relationship, and whether she is married, and whether she has a multiple partners. So these are all the questions you are going to ask us in the first scenario, that is engaging into the scenario. And the second is we are going to analyze with the situation, whatever the information, history collections, we have done it. And in analysis, we collect with the data of the investigations and all those things. And then we come to a conclusion that what is the actual diagnosis she has come to case. It may be a CNA3 neoplasm or whatever is there. Then the third phase, identify the learning needs. So already the student has learned the anatomy and physiology of the cervix, and she has learned about all the details about the physiology of the cervix. And next she has to see that which are the other causes for this severe dyskaryosis, if the history what she has collected, among that these causes are not there, and whether she is taking any current treatment for these things, and what is the cost of all those things. She has to identify those all needs, and based on those nursing needs, she has to construct her knowledge, and she has to speak with the client that the cost effectiveness, duration of this cost is like this, and these are the treatment modalities, and she has to go with these treatment modalities, and this is how she has to come up. And next is the reflection and apply learning. So she has got all the knowledge, she has heard from the patient, she has seen into the investigations, she has learned into textbooks. Now she is going to reflect all those things into the real situations if anything is there. So by this reflection and apply learning, by all these things in future, based on this scenario, if any time she come across with the 25 years old with these of the signs and symptoms, then she will adopt into the real situations. That is called as a scenario based learning. And the next is the simulation. So all of us know very well this about the simulations, because majority of the nursing institutions and the medical colleges and the deemed university, we have a separate simulation labs for it. So this is simulation lab is nothing but the giving a clinical education, is a use of approach to provide nursing students with the opportunity to practice their clinicals and decision making skills as a real life situational experiences. For example, if you want to give a IV cannulation over there, directly you cannot go and learn onto the patient. So we will be having a simulation lab in which we have a IV arm over there in which we can give the IV cannulations. If you want to give a CPR over there, directly you cannot go into the patient who is collapsing and can't give the CPR. So into the simulation lab, we'll be having a CPR mannequin in which we are going to learn about the CPR and correct compressions and the correct things we are giving it. Then afterwards, we'll learn these skills and the competencies, and later on we'll be going to the clinical area. So that is about the simulations. And the next is the experiential learning. So this experiential learning, in the common words, we call it as a field trips. So whenever we go into the field trips, we have a lot of the things to remember, and once we come back, and then we conceptualize all those things and then we present it. So experiential learning involves a direct experience which can be planned or spontaneous. We send our students for the water purification centers. We send our students to the different cancer hospitals. We send it to the CSD unit and to see all those things. So it is experience is backed up with the focus of the reflection, and the past knowledge and the experience is used in case of this experiential learning, and it encourages the students to collaborate between the students and exchange the ideas and the perspective thinking. For example, if I say that the students will be sent to the water purification center for as a field trip for 3 hours, they visit over there and they come to the college. So once they come to the college, they think that whatever they have learned into the textbook and whatever they went into the field trip and visited this water purification center, they correlate both of the things over there, and they make it a note over there, whatever the things they have learned, that the purification center setup is like that, the purification was done. So based on the reflection observations, what they have observed it, and then they start thinking, and then they start acting about the thinking what they have done it, and lastly they write a note about it. So that is called as a experiential learning. And the next we have is a reflex learning. That is, a reflex learning is a form of education in which the student reflects upon their learning experiences, and it is in simple words, it is called as thinking about what happened and what didn't work and what you think about it. So this is the cycle which explains about the Gibbs reflective cycle, and nowadays more they are involving is the experiential learning and the reflection learning and the simulation. So that is any incidents is there, so we are going to describe it, what has happened, and then we have to think about it, what we are thinking, whether it is right or wrong, and any good points are included over there or any bad points were there into that experience. We are going to analyze that situation, and lastly we are going to come with the conclusion that prepared for this. So this is called as a reflective learning. And the last one is the OSCE. So this is the common things which we are adopting now, and as per the Indian Nursing Council syllabus, this OSCE also has been made as a mandatory. Like nowadays for the practical examinations, we have only the two examiners, In case of the new syllabus, we are going to have the 5 examiners and 3 from the internal, and the main emphasis is given onto the OSCE examinations. So it is a multi-purpose evaluative tool that can be utilized to access healthcare professionals in clinical setting. And it is a competency based on the objective testing of through the observation, direct observation. So any assignment is given to them. So for example, you create an OSCE, that is a BP apparatus will be kept over there and the student will be made as a patient over there. And here our task will be that the student will be going and measuring the BP of the student. So we'll be assessing there, we'll be having a structured tool with us to, that is a checklist to evaluate that whatever the student is doing, whether they are following all the procedures and correctly they are following or no. So that is called as a OSCE. And this OSCE is a very helpful tool to assess the students' competencies based on specific objectives. So as I said, one tool we can make it and the specific objectives can be met. And it is designed to measure the knowledge and skills required for competency domain. And it is helpful to assess the broad sample of the knowledge and skill that are logically linked with the competencies. So any procedure, for example, the delivery model can be kept over there and the student is set to conduct the delivery using that module. So, and then we are going to evaluate, we'll be having the evaluation form, whether the procedure is properly carried out by the student or no. So lastly, we are going to have this competency certification logbook. That is whatever the competency skills which is prescribed into the Indian Nursing Council syllabus, we are going to have the logbook over there, that whether the required knowledge, skill and attitude and the competencies has been gained by the student or no. If it is not gained, again the repetition of those activities has to be done, and until and unless the student is perfect with the knowledge and the skill and the competencies, the logbook should not be signed. And once it is completed, then it should be certified and the student is allowed for the next class. So I would like to conclude my presentation with the saying that integration with a perfect blend of practice with teaching applied in the primary, secondary and tertiary care setting lifts the standard of the patient care. And this competency-based clinical practice empowers the leadership role and motivates in translating the plans into the action. And it is instrumental in building the positive work culture, both in educators and the practitioners, because we have a lot of gap between the educators and the practitioners, and this gap can be reduced and the leadership can be developed in the teaching sector also and into the clinical sectors also. And integration helps in preparing the committed, competent, compassionate nurses with the professional excellence. So I would like to end my presentation with the fact saying that education, practice and hard work, honesty and the team spirit are the ingredients of implementation of the integration process of the nursing education and the practice. So I thank all the organizers for giving me the opportunity to be as a resource person to this topic. Thank you one and all. If any questions are there, you are free to ask.
Sir, a very good morning to one and all. And thank you so much, Dr. Sanjay Pirapur, sir. Sir has beautifully presented the topic and it was very informative. And sir has beautifully correlated the new syllabus with the topic. So sir has given the real picture, so how it will be important in our nursing profession. And really there is a need of good leaders in our nursing profession. And sir has rightly said and given a beautiful Sir has said about competency-based clinical practices. It's a mix of skill, knowledge, attitude, and abilities. And sir has given the importance to competency domain, that is a knowledge, attitude, and practices. And sir has said about the integration model also, and how to prepare the team for the better education, like it is a need of clinical side as well as nursing education side. So we have to take care of both the teams and we have to prepare the topics for them, and then implementation, how to implement the competency-based nursing practices, and there is a and how to implement competency-based clinical practices. So there is a need of skill labs, problem-based learning, scenario-based learning, simulation, experiential learning, reflective learning, and OSCE. So all these are with the new syllabus, and beautifully it was presented. And thank you so much, sir. And now I request to all the delegates, if you have any query related to this, you can ask to sir. You are welcome. Delegates are requested to ask if they have any query. They can ask to sir, please. Okay, thank you so much, organizers, for giving this responsibility. And thank you so much, sir.
Thank you. Thank you so much.
Madam, over to you, please.
Thank you so much for your words of wisdom. It will be great pleasure for us to listen you again in our future events. Thank you, sir. Thank you, Mohammed sir. Thank you, Sanjay sir.
Thank you.
And I hope all have enjoyed this new topic sir has introduced very nicely. Thank you, sir.
I welcome all the participants for the today's function. I am glad to introduce Dr. Shobha Gaikwad Madam, Assistant Professor, LT College of Nursing, SNDT Women's University, Mumbai. Madam has completed her PhD Nursing, MSc Nursing in CBTS, MA in Sociology and Post-Graduation Diploma in Education Management. Madam has a fellowship in ISQUA in Ireland. Madam has a professional experience, 31 years of professional experience, as well as clinical, as well as the teaching experience. Madam has a Madam has published 33 publications in peer-reviewed and impact factor of UGC recognized journal, as well as national and international conferences. Madam has authored book Nursing Care of Reproductive Disorder, and Madam has a member of Presidents of NSS Maharashtra Chapter, Vice President Tarangana Alumni LT College of Nursing, trainer of COVID pediatric, trainer of COVID-19 mental health NIMHANS, and trainer of HAI for MNC. And today we are having the dynamic personality Dr. Shobha Gaikwad Madam, and the Madam topic is advantages of integration of nursing education and competency-based clinical practices. I welcome Madam.
Thank you, Ms. Pratibha. Nice to meet you again on this virtual platform. Okay, so good afternoon to one and all present here. I'm sure you are enjoying the sessions which are going on. Very expert speakers are speaking on the sessions, and I'm sure all of you are getting the best from it. Let me just share my screen. Pratibha, just tell if my screen is, you are able to see the slide share, okay? Is it slide share, Pratibha?
Yes, Madam.
Is it moving ahead? The next slide.
Yes, Madam.
Okay, fine. So once again, good afternoon to everyone. We have seen now various sessions which were there prior. So what we are going to see is one step ahead. That is, how do you, when we talk about, when I speak the same competency-based clinical practices, what we have seen now, the previous speaker has spoken so well. What are the different competency-based clinical practices with various examples? How do we integrate all this with nursing education when we speak about? So is it important, as we have seen the new education policy has, where you are building up your competency-based clinical practices when we talk about nursing also, and then general education, which the government also has prepared right from your KG till your higher education when we talk about in the different ways. And same, we have seen how well we have incorporated when we are talking about nursing also in the new education policy. What are we going to see? What is the competency-based education when we talk about nursing education? Because that is linked with our advantages, the characteristic. Is there a need to have competency-based education in nursing? What are certain competencies, core competencies required? You have heard the previous speaker telling there are very good competencies and how we need to incorporate. Those are given in our new syllabus also. But along with that, there are certain hidden core competencies also which we need to develop. And that is all going to help us in our nursing education when we talk about integration of this particular syllabus, your education, your competencies, and then how well you develop this particular student when she or he goes for working in an area. When I talk about clinical practice, not only when you are as a student, but also when you go in the education side, and now from here you are becoming a newly joined nurse, we talk about, or a novice nurse. So is my education helping me to build and be very easy and easygoing, and my newly joined, when I join in a hospital or a clinical area, am I able to adapt or I get scared? That is what is important when we talk about competency-based education. What is competency-based education? As we all know, it is not a novel, it's not a novel educational model. Is the slide going in front, this one? Pratibha? Ranjana,
Yes,
is the
yes, madam.
slide
Yes,
moving? Okay,
yes,
very
yes, yes,
good.
madam.
Okay, fine. Now, when we talk about competency-based education, it is not a new model. We have got in our syllabus after 50 years now, but it is a very old model, right from 1960. When we talk about our Bloom's taxonomy, the taxonomy itself prepares us by developing of various skills, whether we speak about an old taxonomy or a new taxonomy. So your objectives, when you frame the instructional objective, that is what we talk about the new syllabus. It is learning by doing. That can you apply this in your real setting? What you learn, can you go ahead and when you start working, can you apply? When you go in the society, can you apply? Okay, when you go globally to work somewhere, are you able to apply your knowledge which is here in your own country, global, in the global scenario, transcultural when we talk about? That is what is when we talk about advantages when nursing education with your latest competency-based education. So let us see a bit of history when we talk about. So you can see from this that competency-based education is not very new. Okay, it started right from the time of John Dewey. We have learned various educational strategies. So pragmatism, when we talked about, so that was what was started in 1903. So you see, it is not a new thing. From that time, we are talking the real life scenario is what is important when we talk about. So John Dewey itself, when you see, he believed that human being learns through various hands-on approach. That is, you work with the environment. You put the student in the environment, let him learn there. Like a Guru Pili, when we talk about Guru School, okay, where it is open environment, you go in the environment, you learn the plants, okay. So that was what we did started. Carlton then in 1990 started the Winnetka plan. What was Winnetka plan? Here it believed that you do the real life on situation, but along with that have a common assessment system. Do not have one assessment for someone, one for someone, and that is what has come now again into the being. Ralph Tyler, I'm sure all of you know him. He was the one who started with your curriculum instruction when we talk about, okay. Just give me 1 minute. Just give me 2 minutes. We will break down and have our welcome, and then we will start with our slide. So I'll just stop the share. We'll be having the inaugural function, and then we'll restart the session from where we left. Thank you.
Good morning, ma'am. Please kindly stop this session because now we start the inaugural function. Good morning, all. Just we are start our inaugural function. After inauguration, we continue with this session. After inauguration, we continue with previous session.
तो मैडम सर ज्वाइन कर लिया। हाँ क्या रहे लगा किसी नजर को तेरा नहीं हूँ क्या? बेचारे 11-1 घंटे से तो परेशान है।
ये जो नोटिफिकेशन है इसमें फ्रॉम इमीडिएट इफेक्ट से डाला है, लाइक चेंज ऑफ नोटिस।
Now, we start our inaugural function with Saraswati Vandana. Now, I request Dr. Seema Singh, Principal, Srimati Radhika Bai Mege Memorial College of Nursing, to kindly give welcome address.
Good morning to all. Sorry for that. Sorry, there was a net network issue. Good morning all. Thank you everyone who joined us this morning. On that note, let me introduce, first of all, and welcome the President of the Starlink Beautiful Morning, Dr. Ved Prakash Mishra sir, who is a renowned academician in the medical field and has made the country round with his work. He is an illustrious member of medical fraternity, well known not only in India but and chief advisor at the University, Savangi Mekevarta. He is a dynamic orator. He is a keen academician and astute administrator. He is a chairman of Academic Committee of Medical Council of India, New Delhi, and its members. He is a national head of academic program of Indian program UNESCO. He is an advisor, Human Ethics Association, Bangalore. He is a dean, academician, accreditation board, National Indian Medical Association, New Delhi. If we start adding to his profile, he is a director professor in advanced physiology and chairman, National Medical Education Board, IMA headquarters, academic head and convener, Academic Council, SARC Medical Association. He is president, Management Committee, Education Promotion Society of India, New Delhi. He is a member, Advisory Board, Manipal Academy of Higher Education. He is a member, Board of Management, Sri Ramachandra Institute of Medical Sciences, Chennai. He is a member, Board of Management, D.Y. Patil University, Pune and Kolhapur. To add his membership, Court of Sharda University, Noida, Uttar Pradesh. Convener, expert group of National Board of Examination, New Delhi. Life member, B.C. Roy Memorial National Awardee Fund, New Delhi. If we go on adding, it will be never ending to highlight the sir. He himself is a prestigious and we are blessed to have him as our guide, motivator, and his guidance with us is always there for all the activities we do. Welcome, sir. I also take privilege to introduce and welcome our chief guest of this function, Dr. Rajiv Pole, sir. But due to his meeting, he is not able to be with us. He is a Vice Chancellor, Datta Mege Institute of Medical Sciences, deemed to be University Varda. He is a director, Smile Train Project, Acharya Vinoba Bhave Rural Hospital, former member of BOS, Faculty of Medicine and Board of Examination, Sant Gai Maharaj, Amravati University, former member BOS, Faculty of Dentistry, Maharashtra University of Health Sciences, Nasik, from year 2019 to 2007. Former member 31, Committee Maharashtra University of Health Sciences, Nasik. Former member of Faculty of Dentistry, D.Y. Patil University, Pune. MP State University of Medical Sciences, Jabalpur. Lifetime Achievement Award by DDI Foundation at the hands of Honorable Governor of Maharashtra, July 2021. I also take privilege to welcome Dr. Sanjay Pirapur, Principal, KLE Society of Nursing Sciences, Hubli, as a speaker. Dr. Shobha Gaikwad, Assistant Professor, LT College of Nursing, SRMMCON, Mumbai. Dr. Vasant Salah Sadan, Dean, College of Nursing, CMC, Vellore. Dr. Ima Sakya, Lecturer, Regional College of Nursing, Assam. Sister Tessie Sebastian, Director of Nursing, ABVRS Savangi. Mrs. Sindhu Advalkar, Principal, SRMM School of Nursing, Vice Principal, Gokhale Medical Society, NISAC. Dr. Professor Vaishali Taksande, Vice Principal, SRM College of Nursing, Savangi Mekevarta. Professor Jaya Kawai, Dean Academic, SRM College of Nursing, Savangi Mekevarta. Professor Ashna Maurya, SRM College of Nursing, Savangi Meghewanta. Dr. Alka Tajne, Principal, Vibrant College of Nursing, Surat. Judges for poster and paper, Dr. Sudha Singh, Associate Professor, Mansoor Nursing College, Bhopal. Dr. Benu Jose, Principal, Christ College of Nursing, Rajkot. Dr. Rahul Pandit, Nursing Officer, PJMC and SGH, Pune. Ms. Shweta Sandhu, Assistant Professor, Government College of Nursing, Rajnandgaon. Ms. Ashwini Kuppe, Associate Professor, and Mrs. Subhatra K. Jandal, College of Nursing, as an observer for this CAB from the Maharashtra Nursing Council. I take the privilege as we move and carry on this event, I would give my regard and appreciation to all the people who have made this occasion reality and successful. This could not have been possible without the shared contribution of you all. We are all a part of this institution due to our shared passion for the vision of the institution. Our passion unites us and our hard work strengthens the institutes. Without further delay, I would like to start the events and we would be delighted to have your suggestions and questions at the end of the event. Have a nice day. Thank you very much.
Thank you, Seema ma'am.
Our today's chief guest, Dr. Rajiv Borle, Vice Chancellor, Datta Mekhe Institute of Medical Sciences, not able to join with us due to emergency meeting, but he is Vishesh with us. As an inspirational leader in the campus, pillar of the university, and the big supporter for us, I request Dr. Ved Prakash Mishra, sir, Pro-Chancellor and Chief Advisor, Datta Mekhe Institute of Medical Sciences, deemed to be university, to enlighten us with his words of wisdom.
Thank you very much, Dr. Seema Singh, for your kind good words. Learned chief guest of the function, esteemed Vice Chancellor of the university, my esteemed colleague, Dr. Rajiv Borle, learned honorable dignitaries, members of the organizing committee for this notable conference, faculty resource persons who shall be deliberating in this conference in terms of their expertise, delegates, participants, invitees, ladies and gentlemen. At the outset, I deem it my duty to record my appreciation for Dr. Seema Singh and all the members of her team for taking on their shoulder this mantle of responsibility of organizing this national conference, and also the theme that they have picked up for this notable conference. I'm sure that the deliberations, the discussions on this vital, significant, important theme definitely would go a long way in bringing out that which is desired the most, not only for the emancipation of the nursing profession and nursing care, but what we classically intend to have for this world in the interest of optimal nursing care or optimization of nursing care, which has been abbreviated as evidence-based nursing care. Let me put it across very candidly at the outset. It's not a handy affair that we will be in a position to work out what we are contemplating and desiring. Invocation of evidence-based nursing care for the core objective of ensuring that the patient's benefit, the patient's care, it stands not only augmented, but it is optimized in every respect. That turns out to be the keystone, and that turns out to be the cornerstone for the purposes of achievement and attainment. But then, if we are wanting this to be achieved, we need to decipher very clearly as to what are the cornerstones which are mandated for ushering this desired era. To my understanding, I will put the three important cornerstones for this particular parable to be achieved are: 1, nursing education; 2, then nursing care and practice, germane out of the education; and 3, important aspect is research, which is going to be the hallmark of it. Therefore, the trinity of generation of evidence-based nursing care is having an education which is competency-based, having the entire system of education getting structured up into what is classically called as competency-based nursing education. Competency-based nursing education in terms of training, orientation, and inculcation now. Transformation of the abilities incorporated for the care, nursing care, getting converted and transformed into competencies which are not only doable, deliverable, but also demonstrable in nature and character. The moment we talk about the competencies, ladies and gentlemen, having the fortune of structuring the competency-based medical education as the chairman of the then Medical Council of India, I can tell you with whatever little understanding and authority, and that is, finally, what you aim at is conversion of the ability of the learner into competencies. Those competencies which are required to be practiced, those competencies which are doable, those competencies whereby the results out of the doability are delivered, and that deliverability which also is demonstrable in character. Therefore, the importance for the purposes of generation of evidence-based nursing care, the primary requirement is efficiency and efficacious development of competencies in terms of deliverability and doability, resulting in demonstrability of the same, which turns out to be the first important aspect. But then only competency-based education on its own does not result in evidence-based nursing care. It may result in efficient nursing care. It may result in efficacious nursing care. It may result in meaningful nursing care. But to say that it has resulted in evidence-based nursing care cannot take place automatically. Therefore, those who think that competency-based nursing education on its own will result and generate in evidence-based nursing care perhaps is oversimplification of the entire issue. It is the research which is going to be the real hallmark of it. It is working out the required evidence which is going to be a real issue. And therefore, ladies and gentlemen, evidence-based nursing is therefore a tripartite conglomerate of competency-based nursing education blended with research inculcations resulting in generation of the evidence, and based on those evidence, competencies getting channelized for the transformation of those evidences into evidence-based nursing practices. This is the entire dimension which has to be borne in mind. And therefore, when I say evidence-based nursing practice, we have to look deep into the literature as to what is the present situation of the same. I would like to recall a systematic review which virtually has been undertaken during the period lasting from 2007 to 2017, virtually a conglomerate in terms of the Prisma chart where 7,186 studies were looked into, but finally it was narrowed down to only 16 studies on which the systematic review was possible in terms of the core objective of evidence-based nursing practice. And let me put it across very candidly. Out of all these studies which were taken up for the authentic systematic review, which is in vogue, put across in 2017, published by Cochrane analysis, let me put it across, Dr. Seema, none of the studies were from Asia, Southeast Asia, including India. Now, this is the pathetic picture which I'm wanting to put across. The only systematic review, to my understanding, which has been generated on this count. Imagine, with so much of proliferation of nursing education in our country, but now competency-based nursing education having been notified by the Indian Nursing Council and having been put into operation in all the nursing colleges. What is the real malady? The real malady is our contribution, Indian contribution, Southeast Asian contribution till date in the domain of that systematic review, which is the most authoritative and authentic systematic review. We have no contribution in terms of any scientific study and any scientific publication there too. Therefore, it means the matter is all the more need-based and all the more significant for us. And it is in that context I am attaching significance to this conference, this deliberation. Let this deliberation be focused. Let this deliberation decipher the problem in its real magnitude. Let it be undertaken that it cannot be a cosmetic affair, that people will be generating evidence for us and we will be wanting to be availing out of that evidence and carrying out our evidence-based nursing practices. No, ladies and gentlemen. Whenever you look into the international scenario, we have to make one admittance very clear. Having worked practically in all the international organizations, I know it for certain that any and every recommendation which is invoked at the global level, there is one clause which is absolutely germane to it, that these recommendations will be effected by the country specific, taking into consideration the needs and requirements of that country and tailor making the recommendations in accordance with the same. When we contemplate evidence-based nursing practice, when we contemplate Indian nursing practice, when we contemplate Indian competency-based system of medical education, I will not say that we are talking of Indian evidence-based nursing practice, but then our onus of generating evidence on that particular count cannot be transferred to anybody else, because we are one of the largest producers of trained nursing woman power or manpower in the entire world. Our onus is more. Our contribution has to be more. Our contribution has to be in terms of the population, in terms of the numbers, in terms of the admittance number, and in terms of the certified manpower that we are generating. It is that which is required to be collaged. It is for this very reason I am advocating that we have to take initiative. We have to contribute our might. We have to take it with all seriousness. And educational institutions, in my humble opinion, can turn out to be the real repository on that particular count. With pride and humility, I'm happy to share that Datta Institute of Medical Sciences, under the previous leadership of Dr. Tessie Sebastian, and now in the present leadership of Dr. Seema Singh, we have a center of excellence on evidence-based nursing. And really, I can say with all pride at my disposal that the center is doing a real excellent work in catering and contributing to the cause of evidence generation, facilitating evidence-based nursing practice. And equally, I would like to recall that our association with Culture University, which had cooperation and mutual memorandum of study, and I'm just wanting to put it across. Am I audible?
Yes, sir.
taken to be the best. And includes that we will have to be working out in terms of a definite bridging the gap. And what is that gap, ladies and gentlemen? The gap is between the education and nursing practice. The gap is to fill by research. That research, which will be generating evidence for the nursing practices, and therefore by bridging that particular gap, ladies and gentlemen, we will be in a position to cater to the cause of evidence and in evidence-based nurse practice, ultimately optimization of the nursing care in the real sense. In terms of the approach and methodology, I can jolly well put it across that ultimately the 5 cardinal steps for the purpose of orientation program of the educators on this count is vital. An experimentation which has worked out in sorry, there is a huge interruption, technical glitch, and as I was saying, gentlemen, we need to train and orient educators in regard to what we classically called as educators training purposes of invocation of generation of evidence towards virtually and realistically creating the evidence-based nursing practice. It has to be worked out in terms of step 1, a focused question. You will have to have a I'm sorry, I'm facing n number of technical glitches here because of the connectivity problems. And therefore, I regrettingly, I would like to conclude because I do not know when again I will be facing a technical glitch. My main purport of this entire disposition for all of you, ladies and gentlemen, is that this is something which is warranted in the interest of the patient care. This is warranted in the larger interest of the people at stake. And therefore, it is the duty of the academic institutions and the conferences that we are presently hosting to be taking the challenge seriously, grappling with the challenge, putting all our might for the purposes of 5-step approach towards what is classically called as evidence generation for the purposes of evidence-based nursing practice. The first important step that you are required to be undertaken is translation of an uncertainty into an appropriate answerable question. That turns out to be, friends, step number 1. The moment you have worked out that as a step number 1, the second step which you are required to be working out is searching of evidence on that particular count. And upon searching of evidence, a critical appraisal of the evidence is required to be undertaken. And once you have done the critical appraisal resulting in generation of the best evidence, it is the application of the evidence which is warranted. And finally, upon the application of the evidence, evaluation of the performance or outcome which is generated out of that application of evidence. These are the 5 cardinal steps which mandate genesis of what is called as evidence-based nursing practice. Ladies and gentlemen, I'm sure that the experts, the deliberations which will be put across by resource people, definitely it will be paving a way, and definitely it will be charting out an action plan and a blueprint in that particular direction. Whatever little I was in a position to stray my thoughts on, I trust and believe that ultimately the real show window for the classical improvisation and deserving improvisation of the nursing care lies in evidence-based, efficacious nursing care. Let us cater to that particular cause. Let us rise to the occasion in unison to ensure that that larger cause is really worked up and we take that onus on our shoulders. And I'm sure this conference definitely will best generations of in time I'm grateful to all of you for having acknowledged the recognition of the university and are participating in this present venture. I'm sure that this conference and the deliberations definitely will open a new vista, a new path, a new vision, a new direction, and absolutely a new dimension for the purposes of final invocation of evidence-based nursing care in terms of its alignment with competency-based nursing education, vis-a-vis bridging this gap through evidence generation in the form of design research. Thank you very much, ladies and gentlemen, for patiently listening. I definitely wish a very best to this conference for its outcome, recording my sense of thankfulness and gratitude to Dr. Seema and her entire team, and thanks and gratitude to all the faculty, resource persons, and the participants alike. Thank you very much. God bless you all.
Thank you, sir, for sharing your view. Now, I request Dr. P.T. Desai Madam to file state Dr. Ved Prakash Mishra, sir. Thank you, madam. Thank you, sir.
Now it's time for deliver thanks to all. May I request Dr. Ranjana Sharma, Organizing Secretary of this National Virtual Conference and HOD, Department of Medical Surgical Nursing, to propose the vote of thanks.
Thank you, Deepali Madam. Good afternoon to all. Honorable Pro Chancellor Dr. Ved Prakash Mishra sir, Honorable Vice Chancellor Dr. Rajiv Gorle sir, Honorable Registrar sir,
all the dignitaries, respected teachers, my colleagues and dear participants. On behalf of the Srimati Radhika Bai Meghe Memorial College of Nursing, and on my behalf, extend a very heartfelt thanks and gratitude to all dignitaries of today's conference. The entire onset, we would like to express our gratitude to our management who always support us in all our activities. Thank you everyone for joining with us for the inauguration session. Thank you.
Thank you, Ranjana ma'am. Now we continue our previous session. Dr. Shobha Gaikwad ma'am, are you there?
Yes, I'm here.
Yes, ma'am, you can continue your session.
Okay, I'll just share my PPT.
Yes, ma'am. Share PPT. Yes.
Is the slideshow visible? Ranjana, is the slide?
Yes, ma'am. Yes, ma'am.
Fine. We were just seeing before the inaugural the history of competency-based education, because that is linked with the advantages when we talk about why nursing education it's required. So we had seen John Dewey was the pragmatism type, what we thought about real life behavior, learn the things in the real life setting. Then comes Carlton in 1919, which we had seen the Winnetka plan. Carlton believed that whatever you do, okay, it has to be as per the assessment. And that was the time that the universal assessment system was started by Carlton. Then we came to Ralph Tyler. I'm sure all of you know Tyler is the father of curriculum when we talk about. So curriculum instruction started that had its own objective. So that started with the outcome-based education when we talk about intended outcome, and then competency-based education was also included when we talked about. And then in 1970, we have seen what we are now immersive, that is competency-based education. In 1970 was direct competency-based education. Now, what is the difference between direct and when we talk about your immerse? Direct is when you demonstrate your capabilities, like when we just now we have seen Mr. Ved Prakash talking about doable, demonstrable. Okay, so it's can you develop your competency in the form of knowledge, skill, ability? So that is your direct CB when we talked about. And now we can see with the coming new education policy, it is immersive. Just now we again heard the importance of evidence-based research. So critical thinking is what is the new education policy is focusing on. Are we preparing our students to integrate with the environment, integrate with the society? We have seen now, sir mentioned about a systematic review where Southeast Asia didn't have any role to play. So are we preparing our students for the forthcoming when we talk about the nation development? Can we think of evidence-based research, why it is done, how it is done? Can every work when we do, can we think of the questions when we talk what, why, when, how, and then apply what we are doing? Or are we doing only rote learning? So that is what is the present immerse CBE when we talk about. To see what is competence-based education, we all know it is development of your specific competencies or skill, but not alone. Before we had rote learning, the teacher-centric education. Now when we talk about the latest education system, it is more of student-centric. It is not more of student-centric. It is the student learning outcome when we talk about. So no more we write now objectives. We write objective in the form of learning outcome. What is a student going to learn? So here we need to be as a facilitator, as a guide, as a mentor, and not as a teacher. So you be along with the students, you develop their skills at their own pace, they will learn. You identify the higher ability student, the lower difficulty level student, and then now you give your education in that form. So it's more of a mentor, a preceptor, a guide, or a facilitator when we talk about. So you're learning alongside the students, you're helping him to develop further. Simple nutrition, you give you teach nutrition in college. So is the student able to incorporate the nutrition of the first year into the second year, learning the various disease conditions? So is the teacher able to incorporate that particular aspect into the student, and then the student learn to prepare that particular diet plan or incorporate it as per each individual who is there in the ward, not as per a common diabetic patient. I have a person who's 60 weight and I have a person who's 110. So am I able to prepare a diet plan accordingly? That is what is we mean by competency-based education. It also is a system when we talk about learning. Okay, education we have seen prior. Now, when what do you learn? Okay, so when we talk about competency-based learning, it is a system of instruction. What instruction are you giving? Is it at the level of the student? Is it student-centric? Is the assessment or the grading not only to mark the student, but it will help the students further when we talk about applying that education into further your real life situation? Is the academic reporting only to give a degree, or is it preparing you for a novice nurse, okay, or a beginning skill nurse? That is what is you are expected to learn as you progress through the education. You can see the child, a simple 2 years written and the smile on the face. Okay, so that is what is important, that each thing what your student does, he or she enjoys doing it. Okay, so that interest has to be garnered by whom? It is the faculty or the facilitator who is there. When we talk about competency-based learning, your competency-based education is development of your knowledge, skill, your abilities with your evidence-based research. When we talk about competency-based learning, it is development of the abilities with or without supervision. That is, whatever you teach, whatever you do, is it lawful? Is it safe? Is it effective? How can this be done? That even if the teacher is not there, even if the educator is not there, is the student able to practice it? Three different types of approaches are there. Behavioristic, you are developing only certain behavior in the students. Okay. Second is attribution or generic. When we talk about here, it is more of a cause effect relationship. When I am doing a mitered corner, why do I require a mitered corner? Why there should be no bed creases on a bed? Why the bed should be without crease free? So, okay, are you showing it with example? Okay, so that is what is you mean by attribution or generic. When you teach the cause and you teach the effect. When I talk about the COPD patient not getting more than 2 liters of oxygen, so are you trying? Do you take the patient to the student to the clinical area and explain what happens if more oxygen is given? Okay, do you show the various signs and symptoms when you talk? Show the patient with various breathing difficulty. How does it sternocleidomastoid muscle looks when the patient breathes heavily? Okay, so that is what is important when you talk about. And the last, when you see, it is your integration. Integration is what is very important, that you teach knowledge, the child is able to apply the skill, at the same time develop its attitude. We have seen in the present pandemic, all of us have used holistic or integrated when we talk about. So not only using the technology, along with the teaching, learning the technology, and seeing that the students also learn and incorporate it in a particular way. So that is what you mean by instructional or integrated thing, and that is the whole something when we talk about students' progression. At the end of the attainment, that is at the end of the education or whatever you're planning to give to the student, has the student developed the skill, the competency? How do you check this? Okay, this is done by your, when we talk about certain batches being given, okay, you give the degree in the hand, you give certain certificate in hand. So is that only what is competency-based learning? No, this is necessity for a skill-based outcome. But then how do I develop this particular student? That is what is important. So that's the education system. You can see in the diagram, are we only targeting only for exams? Okay, at the first semester. Now also we have semester system included. So are we going to only finish our portion? We have a lot of elective courses, a lot of modules which we have to take compulsory. Okay, some we have to take from the other university. So are we preparing our students only to complete that particular thing? This particular education system of elective, okay, these modules are given so that we prepare the student to face the real life scenario when she passes after 4 years. So are we going to be exam oriented, or is it going to be where we try to enhance the student's skill, competency, and all that we talk about? So here what we require to do is that ability, skill, knowledge, attitude, all this you holistically develop. How do you do it? Not by teaching. Here it is learning. The child learns. Okay. So you are trying to, that's why we talk about learning outcome nowadays. We do not anymore tell that we are going to make the child do this, make it is learning, whether the child is able to learn to prepare a concept map. Okay, the child is able to learn to do a miter corner. Okay, so simple competencies also you're going to build. Okay, so it's learning. What are you learning? Your knowledge. Are you developing the skill along with that, the beginning skill and the actual skill? Is the child able to perform after this? Okay, I am teaching. I am teaching the student how to give a high bubble wash. But is the child able, though we have done it on the mannequin, we have demonstrated, when the child goes to the clinical area, is he able to perform it? If he is scared, why he or she is scared? Is the teacher there along with the child, okay, helping the child to give the bubble wash? That is what is important. So the child develops the task, learns the task, and enjoys. Okay, I should enjoy what I am learning. So if I don't enjoy that, competencies will not be built. How will this be built? The child will ask certain questions. That is the critical thinking. Why this has to be done like that? Why can't I do it in this particular way? Can I turn the patient in this way? Is it going to affect the patient? So that is the joy of learning when we talk about. So according to Robinson, when we talk about children's competency building, as we have seen just now, how much importance is given for evidence-based research. A total new education policy is building the students to develop a researchable activity, that is critical thinking, problem solving approach. So is the child able to make clinical decision? What I study in the school or the college of nursing, am I able to apply when I see different patients, same condition, but different individual, one with a less weight, one with more weight, okay, body weight. Am I able to apply that? Okay, or I am a rote learner. Okay, so that is what is important. And nowadays, a lot of importance is given on international patient safety goal. At last, everything is done for the patient. Okay, so the patient is the person whom we are doing all this competency building for. So that is what is your importance when we talk about, and that is what is a total education system in the new curriculum based on when we talk about the new educational policy. What does it offer? When we see it offers you a degree at a cost effective or time saving, okay, I can learn it at my own pace. It also helps you to attain certain things at your own pace. Now the new education policy is you earn and you learn. Okay, so I can break my study in between, I can master my skill, then I can go ahead. We just heard by this previous speaker that he mentioned about OSCE in every semester, in every subject, at every time. Okay, the number of OSCEs that we have. OSCEs are one of the example that you learn your skill properly, then you move ahead from your simple to complex. Okay, so each OSCE when you're building up, you're moving further to the higher level of OSCE. So that is what, so all students may not face at the same time. You're spending time with those who have not acquired it. So that is what is your attainment that you're going to do here. And it also helps you in a higher education when we talk about I may work and I may earn. Okay, and with my own time, I may do my study. Abroad, it has started long time back. India, it has started now, where you can earn, learn, take a break. You can study. Okay, you can work with that. You can do 2 degrees at a time, dual degree when we talk about. So that is all what is competency-based education. What does it offer? In the prior, we have seen the degree and all. Now, whether the child is able to apply this, what we have taught in the present scenario. Okay, his or her career is developed with this, and at the same time, the career advancement is done. So when we talk about CBE, it does not only allow authentic learning, but liberal education. Liberal education, I can question. Okay, I can do my own clinical based evidence research, and I can put forth. So that it's a big challenge when we talk about the present education system or competency building for both educator and administrator also. Because if it is not given properly, it will not be, and it will be the same old education which you are going to. Some questions that you need to answer. Okay, so what level should the competencies be introduced? Just now I mentioned to you the maxims of teaching, simple to complex. Okay, where you need to give general to specific, where you need to be specific to general. Okay, so that is what is the importance when we talk about how will the attainment be assessed. What is that you're going to use for it? Nowadays, is everything the summative evaluation only or the formative evaluation? Nowadays, we have a lot of other systems of evaluation. In the present pandemic also you have seen, okay, a simple CNE also you have certain quizzes put in that. So are we using those different form of play game therapy, okay, sending a child to field work and then making a report on it? So these are also various ways of your competency assessment. What content does this competency logically fit with? With my content, what is the assessment system I'm using or the skill I'm using? Is it matching, or just because I have to give, I'm giving? That is what you need to check in. Who is the best facilitator for this competency? Have people as per their expertise. Before we were having people teaching multiple education system, now it is not so. Very clearly mentioned in the new education policy, medical surgical nursing will be taught by a medical surgical nursing expert only. So that is what you mean by the facilitator has to have the competency, should learn it, not because just I have a PhD in medical surgical, but if I don't have a bedside nursing experience, will I be able to incorporate? So learn it prior. Okay. What is the plan? Is the benchmark for the competency? Not a thing. Simple OSCE, I'm telling you, the OSCE, I'm not able to develop my skill. Am I giving extra time for that particular student to develop that particular thing and then come back to you? Am I giving extra time for mentoring that student? That is the benchmark which we are trying to attain. When we talk about need, okay, nursing education institution, we all need to have evidence base. When we talk about every education system wants 100% passing, but how does that 100% passing comes from? Are you giving time for your students? Are you developing them, or it's only the result? So result is not what is important now. Now every education system should think of a lot of activities which are research oriented. Accreditation, regulatory bodies, this is what is important nowadays. So now we see how much importance is given. Every college, school of nursing is going for NAC. Every hospital is going for NABH. So where there is dual, they have to go for NABH, and this. There are inspections. So this standards of quality when we talk about has to be measured, and the same should be done for our students also. That should be rubrics for every skill. And this rubrics should be, you see to it that it is checked out from expert, and then it is applied when we talk about students. Every one of us is accountable, whether we talk about the cost, the time, the educational endeavors, or the outcome that we are going to bring. So accountability is what is important when we talk about this particular thing. When we talk about this, we also tell these students are going to work in the hospital as an educator, maybe as a bedside nurse, a staff nurse. Okay. Nowadays, there are a lot of companies, there are entrepreneurs. Okay. So when we talk about all this, is an entry-level nurse prepared for this? We have a lot of entry exam. Do we have an exit exam? Maharashtra Nursing Council is planning for an exit exam nowadays. Okay. So when we talk about this, with your registration every 5 years, are you giving certain exam? So that is also in the planning with the Maharashtra Nursing Council now. So this all is going to help us when we talk about, and education will not be stagnant. This all is there abroad. As I told you, we are starting it now, and it's a good change. Change should be accepted by everyone. Does the employer also invest in the extensive nursing training program? We see nowadays a lot of hospitals when the student comes new, a very good orientation program. Some hospitals give for 3 months, some give for 1 month, some continue it for 6 months. There is very good practice that the students work in all the areas when they join. So they learn every area for 1 or 2 months, and then you post them as per their needs for what they like. So that is what is important when we talk about competency-based education. And every employer, every person who is from a new nurse, from a student nurse to a new nurse, especially during the internship period, are you developing their personal and professional quality? This we built up throughout, but in the internship period, we are going to see what are the various skills we need to develop. So competency-based education is not only student learning, but measure the student learning along with the time. Okay, with the time, are you developing competency or it is stagnant? How do I, so here the teacher has to be very excellent in seeing that various types of activities are involved, which the student enjoys. I told you one of the purpose we have seen is enjoyment. So child should enjoy this particular thing. With the latest knowledge, are you incorporating? Our books are old, our books are copy paste. Okay, so no new knowledge is put into the books. But nowadays we have a lot of technology. You know, we have Google, we have Wikipedia, we have PubMed. we have Google Scholars. Are the teachers going through this? Are they developing their own knowledge with various evidence-based research and teaching them apart from the book, what is there in the present scenario? So we have a lot of technology. Are we using it? Fundamentally, here the very important role is of the faculty, where the faculty develops herself first, then only the students will be developed. So if I have the research ability in me, the clinical-based, evidence-based qualities, I can teach my students to develop the same competencies, valid competencies, and assessment will be reliable when we talk about. Very important advantage when we talk about integrating nursing education with clinical-based practice is learning is self-paced. We have seen a simple demo when we talk about, okay, a labor, when we talk about operation theater technique also, in your college, are you teaching the students all the technique prior? A simple BP handle on that, how to fix the blade. So do we make the students practice it in the college? Then the child goes in OT, so she will be able to put the BP handle in the blade without any problem. Are you able to teach the child how to hold a needle holder, where to hold anterior 2/3, posterior 1/3? Is the child able to hold the needle holder? Then in OT, he or she will be very comfortable holding it. So this is what is important when we talk about learning should be self-paced. Okay, let the child master the skill at its own time. Here, when we talk about competency-based education, this self-paced is as they master the skill. When you master the skill, you move ahead. Okay, that is what is important. Flexible training approaches. When I talk about flexible training approaches, it is this when you whether you give the training in a small group, a large group. Okay, a child should be able to adapt to all individual studies, group studies, small group studies, large group studies, and all these are important when we talk about. Now, I teach a demo in class, students watch it. Now, when you go to the clinical area, okay, is the theory integrated with the skill practice there? Because when you teach on a mannequin and when you teach on an actual patient, it is different. So if I'm giving an injection on a mannequin or you teach on an orange, okay, then you go to the clinical area. Now the student has to give on patient. Are you there with the student? Can you hold the student's hand when he or she is giving it for the first time? She's scared. So the student develops the confidence. So this is what we mean by theory. You integrate with skill practice. So the child will remember and do it without any issue. And the knowledge gets enhanced and is supported by your performance of skill. And it should be a questionable thing, a doable thing. Okay, that the student needs to question. That is how in our nursing process they're able to formulate their subjective data, objective data. Subjective is what the patient tells. Are they able to incorporate? Objective, when they see the patient, okay, are they able to understand the signs and symptoms? So there is a tachycardia. So with the respiratory rate, are they able to identify, report it, and do the necessary care prior? That is what is important when we talk about the participants' knowledge and skills. As we all know, we have now the new education policy also has made it that at your entry level you have to have an entrance exam. Some colleges already have it. Exit also nowadays they are planning that you have an exit exam. That is not your final exam, but just before you join an institution, there's an exit exam. So what are the competencies required here, which will be used in the hospital? Those are carefully selected. A simple competency like your communication, which is very important because we teach the patient to do the demo. The child does the demo in the demonstration room on the mannequin. Here, are you teaching communication also? So this communication, when the child will be able to do in the hospital also. And all the method of instruction should involve mastery. That I keep doing the procedure 1, 2, 3, 4 times. Okay, so at the time master, and then only you see. And for this, you need to give appropriate time also and plan it accordingly. Now, there are certain principles which we need to remember. Okay, like when I talk about clarity of focus, this focus is not of the student, the focus is of the teacher. Okay, whether the teacher has developed the knowledge, the skill, and the personality which we talk about to achieve the intended outcome in the student. We are talking about learning outcome nowadays. So, are we able to do this? Designing down. Okay, this is the curriculum design when we talk about which already has learning outcome or the intended outcome, the goal which is there. So are this all inculcated into your instructional design when we talk about high expectations? Okay, here it is The teacher established certain high challenging standards for herself. Nowadays, it is a Google world. Students are much more clever than us. So are we able to go one step higher than the student so that we learn and then we can teach the student, or any question we can answer it? That is what is important. That is the high expectation when we talk about nowadays. Students have very high expectations from the teacher. So are you able to update your knowledge, adapt to the new education system, expanded opportunities? Teachers should strive here to have an expanded opportunity when we talk for all students. So this is based not on the idea that all learner can learn the thing at a time. There are different level of students. Are you able to adjust to each level of student and then develop each student at the same level when we talk about, and give each everyone equal opportunity? Okay. Based on this only, we have certain criterions also which we need to remember, like the curricular criterion. This gives learner, the curriculum gives the learner certain indication of what you need to learn in forms of performance. Now we have seen in the new education system, the previous speaker has given you very good example. Okay, like in the first semester, what you need to do, and with that, what you need to develop. Okay, same with second semester, the curriculum has very well put it. So are we able to inculcate that and develop the skill in each semester or yearly end when we talk about? Is there certain enhancement done for this particular thing? On the job training is done for this. Okay. Second is your delivery criterion. Is it flexible? The delivery, the education system, is it flexible? Yes, we all agree it is flexible. As the new education policy, it is very flexible nowadays because it is self-paced. Okay. And has the learning provided certain learner-centered approaches when we talk about? Then we come to assessment. What is our assessment? Is it only subjective and your formulative and summative when we talk about? No, it has to develop the overall assessment when we talk about attitude, okay, your skills, performance. So is our performance demonstrating that particular thing? All the competencies, are they built? Does it include also for placement of a job? So are you preparing a child to write a CV also? So that though it is not there in your syllabus, so but in your fourth year in your internship, teach the child how to write a CV. So he or she can get a job. So that is also a part of your assessment criterion when we talk about reporting and recording criterion. So reports are one which the child develops the gains in your writing work when we talk about, because we have a lot of recordings and all. So are you preparing with the latest standards, or is it still the old book system that you're following? So this is what is important when we talk about. And last is your certificate criterion. That is, a person demonstrate all the capabilities which is there in an accredited course when we talk about, and he or she attains the degree as per the accreditation. Now I just mentioned to you the last slide, there are certain skills which we need to develop. So what are the skills? Okay. So competency that are required is, first and foremost, we all know it's your cognitive, your psychomotor, that is your performance, and your affective, that is your attitude. Cognitive is your knowledge. All these skills has to be equally developed and continuous development. I cannot partially teach first year and forget. That same knowledge has to be expanded over all the semester, because the same knowledge is there in your on-the-job training also. Broadly, you also have to develop professionally, which we'll see further based on the current standard, the regulation. Your assessment system should be flexible, reliable, and valid. And you should develop an adult. We have just seen in individual learning style with different levels of students who come to you. So all the students, we have to see that the basic skills are developed, like your reading, writing. So when we see, like in Maharashtra, where we have our particular college, we used to have a lot of students coming from Kerala, where Marathi is not their language. So then we teach them Marathi, because they have to go to the ward and give health talk in Marathi. Okay, so that is what is important. Are you developing the basic skill on admission? The thinking skill, creative thinking, give a lot of case scenarios, problem solving cases. Okay, so the child develops thinking creatively. Nowadays, a lot of simulations are there. So are you putting in the simulation, the live simulation, the plant simulation? Okay, this is there in our OSCEs nowadays. So those are your thinking skills. Personal quality. It is not only individual development, but your self-esteem, your social skill, your self-integrity. All this has to be developed, and for this, you need to be with the students and understand them. Basic competency when we talk about, I mentioned to you communication, patient safety goal are very important nowadays. Innovation. Now, due to the pandemic, all worked into the innovation of learning through various platforms. Now also we are using Zoom, how to use the Zoom. So all this is innovation when we talk about, and innovation with your other education system. That is also what is the new education policy, which is pushing on to, and we need to all inculcate. So are we able to manage the change and adapt to the change? Professionally, when we talk about our education system, nursing, we have our procedures, our skills. Each one of us has to develop that, because that is what we are going to use further, keeping in mind all the accreditation, standard, legal requirement, ethical requirement, okay? And it should be relevant to your clinical practice, the registration, your board of nursing. Are you able to do the certificate requirement based on what is taught? Okay, so have you completed all your course? There are many school colleges of nursing where they don't do the demonstration. Okay, so this all is very important, whether the child does demonstration, re-demonstration, and then goes and does in the ward. So these are certain things when we talk about professional development. So in the whole, if you see the program, when we talk about nursing education integration with all the thing and what are the advantages, it is based on the council. We have an INC, you may be in your state. So your state council, what has it? Okay, you may be under university. Okay, so the university has certain protocols, so you're following that also. So with that, you have to develop your competencies. There's an academic team which is involved, which is multidisciplinary. The topics then you deliver, the program is developed, and you're following the particular program based on the curriculum or the course plan, the syllabus plan, the unit plan, the lesson plan. So each breakdown you're following based on the learning objective. As I told you, now it is student-centric learning, and the assessment is involved, and this makes your program a fulfilled program when we talk about. When we talk about nursing education and curriculum, it is giving a lot of enhancement is given on health attention, decision making, communication, development of your leadership, permanent education and management. That you don't forget what you learned in first semester and move forward. Whatever you learn in each semester, it is carried forward. Each semester has a takeaway message which you carry on lifelong. Okay, that's why we have certain elective courses, certain compulsory courses. So these are certain things which will help you to develop when we talk about your future too. So the core competencies include, when we talk about your knowledge, attitude, skill, or your cognitive, psychomotor, and your affective domain. Along with that, it also helps you in having your ethical, legal practice, critical thinking, your professional development. We have seen all the skills which were the interpersonal relationship, okay, with your colleagues, your peers, okay, your friends, okay, your patient's relative, your co-workers who are there with you. Building up leadership quality, which comes through a lot of questioning, okay, your ethical based research when we talk about, and with this comes your clinical care, which is a problem solving approach when we talk about. So with this, the advantages or the skills can be developed. Now, when we talk about certain, the previous session, the speaker mentioned to you that nursing education policy has certain competencies given, okay, and those competencies you have to achieve. So this is based broadly on when we talk about assessment and interventional skill, that is safety and protection. That's why I told you a lot of importance is given now on international patient safety goal. That is patient safety, your safety, and the family safety. Communication skill, as I mentioned to you, your writing skill, that is recording, reporting here. Nowadays we have technology, so your computing skill, your communication skill with your patient, your family, the documenting care when we talk about, all based on certain evidence-based guidelines. And you need to be very careful because nowadays a lot of legal and ethical concerns are there. Critical thinking skill. In everything you ask a question, there is a cause and effect relationship because there are variables. There is a patient, there is your performance which you are doing. So is it applicable when I talk about an ABG? The PCO2 level is high. So am I able to know what I have to do to my clinical decision making, or I wait for the doctor to come and then I will do it? So certain things you can do as a nurse. The nursing diagnosis is there, nursing prescription is there. So are you following it? Human caring and relationship skill. That is your legal and ethical consideration. Are you taking the cultural and ethical background into mind of the patient, the family? Nowadays, we believe in advocacy. So are you an advocate for your patient, your family, patient's family, yourself, the caregivers? Okay. Management skill. That is, you prioritize what care you require. Now, simple, a new nurse, she decides which procedure I need to do first for the patient. Okay, patient is going into cardiac arrest. So am I going to sponge back to the patient if I was doing that? Or I'll stop and help for the cardiac CPR. Okay, so that is what is prioritization for a new nurse also, or a student nurse also. So this habit a teacher while teaching should inculcate in the student. Okay, delegation, accountability, every work you are accountable for. So are you able to do it properly? Leadership skill, that's your planning, assertiveness, where you need to tell yes, where you need to put your foot down. Creativity, are you able to get the best in your performance or skill when we talk about teaching skill, that is health promotion, restoration. Okay, and last is your interpersonal or your collaboration or integration, which is overall involved with everything. Then as per appetite, the same thing we are divided into behavioral competency, which we have seen one of the characteristics starting, added competency, integrated, holistic. All this four comes in your holistic. When we talk about behavior is achieving the performance which will help me in my workplace when I pass out. Added is to improve the work environment, which is based on each competency which they have to develop with the knowledge. So my questioning attitude, my evidence-based research, my clinical thinking, my critical thinking, my problem-solving approach. Integrated is all the knowledge, performance, attitude, can I get it together and then transfer my knowledge from one situation to another. When I'm talking about a simple diet in the first year nutrition, have I taught there only integration? So when a child goes to a medical surgical ward, he or she learns to incorporate the same diet with a diabetic patient, with a heart patient. So that is what is your holistic competency when we talk about transferring knowledge to a new situation. All these pedagogies or education system will only be done if it is student-centered and not teacher-centered. Okay, you involve students in a lot of activity. Make them do the diet plan. Take them to the community and let them give health talk on diet. Let them prepare the diet. Okay, so that is how they are going to learn. Inclusive learning. Inclusive is everything. Knowledge. You join with your skills, your attitude, your performance building, all the skills you involve. Interdisciplinary. Okay, if I am studying today a particular thing related to exercises, am I able to understand that when a physiotherapist comes to the ward and incorporate the same things which he is thinking? And we always talk about the previous knowledge or the assumed knowledge. Okay, so am I linking that with my previous class? Am I linking it with the society? Okay, so is the sociology, applied pharmacology, all that. See now in new education policy, the terms also have changed that way. Applied sociology, applied pharmacology. So it becomes an interdisciplinary approach when we talk about cooperative learning with in cooperation with number of association, with number of groups when we talk about. So that is what we talk about. Collaborative learning with your peers, with peers from other college. Okay, similar group from the other institute. Are you involved in that? International students, blended learning. Blended is not only giving education. Now also we see we are using PPT. We are using PPT with videos, PPT with diagrams. So this is your blended learning when we talk about. Give the child learning material prior. Then call the children to class and then you have a discussion over it. Let the child prepare concept maps. Okay, so he or she is able to apply that particular thing. Give case scenario. Let them enact it. Okay, reciprocal teaching. That you teach and let the students give their own point of view, their discussion related to it. How can this be done? This topic is discussed with them prior or given in the form of PDF prior. Okay, so they learn and they come. So it's learn and we join together and we do it. A lot of group activities, peer teaching. Even the assessment system, it should be critical thinking wise. Don't give a simple question and let the child answer. Give a lot of case-based scenario and let the child work on it. Okay, so that is what we talk about. The principles here are whatever degree we give, it should be a robust degree. The education should be integrated with competency-based, valid competency when we talk about practical. Robust means your practical aspect that you're building about. The students are able to learn at their own pace and supported. The effective learning resources are available at any time, and the child is able to develop the learning outcome. And the assessment is not for the sake of assessment, but it is explicit and it is reliable when we talk about. So That is what we mean that competency-based education is learning at your own pace. That is, it has a unique approach to education. The student learning outcomes are well mentioned. So I need that the student master those things. The student is able to apply those things when he or she goes to the society. It is not that he or she does it, only learn it in the class and he or she forgets it. I'm able to rationally apply it. So that is what all this competency-based education is. And the advantage of competency-based is in the hand of the teachers. If the faculty develops it well, the child will be well prepared to work in the environment. When we talk about clinical, either she goes to a clinical area or she becomes a teacher and she is going to teach students. So she or he should be prepared to be critically thinking or rationally thinking or a scientific inquiry when we talk about. Students under competency-based education can progress at their own pace. As I told you, there's no need to hurry. There is a particular stipulated time given. Let them master the skill. Let them do the skill number of times. So that this is also with the teacher who does it. It believes that student progress happens when the competencies are proven. My skill is enhanced, so this skill will remain with me throughout. And then each time you give certain reassertion session. Every 3 months, repeat the skill. So the child keeps reminding and remembering the skill, and he or she is able to retain what is taught. An outcome-based approach that clubs different mode of delivery, not only a teaching delivery, as I told, a lot of group activity, large group activities, small group activity, individual activities, okay, give field trip, case scenarios, blended learning, ICT learning, that is what all we have seen in the previous pedagogy, involve all these modes of delivery. And same way when we talk about assessment, criterion reference, nowadays we have a lot of objective assessment which are game form. Okay, if you have seen latest technology helps you with when we talk about Kahoot using, word wall using, use all those forms of assessment so that the child develops a mastery, enjoys the learning, enjoys the assessment, and then develops a skill, knowledge, attitude, and values to attain the degree. So this can be, these are the various advantages when we talk about a competency-based education. And how does it well prepare a student? If it is done excellently, explicitly with everyone joining hands together, performing the OSCEs all very well, giving individual care to each student, I'm sure the competency-based education is going to go a long way in developing our students. And I'm sure each one of you agree that the new education policy is helping in this particular way. So as I would like to conclude this session, okay, competency-based education is here to stay, though it was there from prior. Now, a lot of enhancement is given that you have to do OSCE, you have to develop, even when they go in hospital, we have seen there are a lot of criteria, a lot of rubrics they have to follow in hospital also, that is performance appraisal, okay? So develop your students in that particular way. So to just sum up the topic, learning is anytime, anywhere, in any way, okay? But it should be authentic, it should be connected with your previous knowledge, present knowledge, prior knowledge, worldly knowledge. When we talk about holistic, learning is student-centric, it is student-owned. So do not make your lessons or your this that it is only a teacher-centered. I should help the students. So let a lot of activities with the students are involved and they enjoy doing it. And learning is community supported. End of it, these students are going to go and work in the outside environment. Are you preparing them to go and work as a novice nurse, to work in a hospital, to meet the society need, okay, to meet the global need? That is what is important. So that this is what, when we talk about an education system, these are certain references which I have taken from, which if you, in case you want, you can write to me personally also, I can help you out. And thank you.
Thank you so much, madam, for your informative session. Madam has explained very nicely with an example, basic example by the nursing students, and madam has completed the history of competency-based nursing education, need as well as the purposes, characters, principal functions, and advantages with a very nice example. I request anyone is having any doubts, they can ask. So as a INC has taken the very nice initiative INC has taken the initiative by giving the CBNE curriculum to us. So this is our responsibility as a teacher, as a college. We have to take the initiative, and whatever the implementation, how you are going for the implementation planning and all these things, this is our responsibility, and make sure that we are making our nurses or nursing students more competent, and they can work in the world very nicely. Thank you so much, madam, for your speech.
Thank you to the organizers for inviting me for the session. I'm sure all are enjoying the session. So thank you and hope to see you again.
Thank you, madam. Thank you.
Thank you, madam, for sharing your deep knowledge with us. Your session was full of valuable knowledge. Now, 1 to 2 p.m. time is for lunch break. 2 p.m. onward, we will start a scientific paper presentation. It's kindly request all the participants be ready for scientific paper presentation. If presentators having any issue regarding PPT sharing, please message us. So let's enjoy the food. Thank you.
Okay.
Good afternoon, everyone. Now, this time is for scientific paper presentation. Before that, I'm introducing today's judge for paper presentation. Our judge is Dr. Sudha Singh, currently working as Associate Professor in Mansarovar Nursing College, Bhopal. She has obtained her PhD degree from Sri Jagdish Prasad Jabramal Tibrewala University, Rajasthan. She has 11 years of professional experience in a variety of clinical teaching, examiner, inspector of nursing institution, research, administration, and management settings. She is member and reviewer of various national and international journals. She has awarded with Best Teacher in Academic and Research on August 25, 2021 by UIGR Academic Research Foundation. She has awarded by Nursing Scholars Society for achievement in working elegantly, creatively, and with team spirit. She is member of PNI, Universe, International Journal of Interdisciplinary Research, Nursing Scholars Society of India, Nursing Honor Society of India. She has published many articles in national and international journals. Working on published a textbook of pediatric nursing. She has attended national, international conferences, state conferences, theory and workshop. Our today's next judge for paper presentation, Dr. Binu Joy, is currently working as a principal at this College of Nursing in Rajkot. He is the founding president who is working diligently and enthusiastically to enhance the mission of our society. He is gold medalist in MSc Nursing and got distinction in the research presentation. He has published 20 research papers in referred journals and have authored one textbook of child health nursing. He has participated, organized, and conducted many workshops and conferences at national and international level. He has received first prize in poster session. He is life member of PNI, NSS, NTI, NHS, and many more nursing societies. Now, I will request all the participants be ready for their paper presentation. Guideline for paper presentations are the time limit for oral paper presentation is 5 minutes and for presentation and 2 minutes for discussion. So I request all the participants be ready for their paper presentation. Let's start our today's first paper presentation. So I call upon Miss Monica Unada to present her paper presentation. Monica, madam, are you there? Monica, madam, am I audible?
Yes, ma'am, yes. Hello. Am I audible?
Yes, yes, you are audible.
Okay. Okay, good afternoon, ma'am, and good afternoon, sir. Today, I'm going to present my research paper presentation. So, problem statement of my research, a study to assess the effectiveness of structured teaching program on knowledge regarding Janni Suraksha Yojana among the antenatal mother attending the MCH clinic at the selected community health center, Surat, Gujarat.
Miss Monica, madam.
Yes, ma'am. Yes, ma'am. Then introduction of introduction. So Janani Suraksha Yojana under the overall number of National Rural Health Mission has been invited by modifying the existing National Maternity Benefit Scheme. While National Maternity Benefit Scheme is linked to provision of better diet for the pregnant woman from the BPL families, Janani Suraksha Yojana integrate the financial cash assistance with the antenatal care during the pregnancy period, then institutional delivery and immediate postpartum period in the health center by establishing a system of coordinate care by the ASHA and the field level workers. Next, please. The need for the study. So researcher observed in community that the antenatal mother is not having the knowledge regarding the maternal health benefits provided by the government. So the personal experience of researcher motivated to conduct a study regarding maternal health benefit scheme, which are provided from the government, and also provide the knowledge and awareness to rural mothers regarding the health schemes and encourage mother to get the benefits available and thereby promote the health status by choosing the institutional deliveries. Then objectives. So first objective is to assess the knowledge regarding Janani Suraksha Yojana among the antenatal mothers before and after structured teaching program. Then second objective, to compare the pre-test and post-test knowledge score regarding Janani Suraksha Yojana among the antenatal mother attending MCH clinic at the selected community health center. Then third objective, to find out the association between the post-test knowledge score with the selected demographic variables. Then methodology. So research approach, quantitative research approach, research design, pre-experimental research design, research method, one group, pre-test, post-test method, then research setting, community health center, Bardoli, Surat. Then research population, antenatal mother who attending the MCH clinic at the selected community health center, Surat. Then sample. The sample of the study were antenatal mother attending MCH clinic at the selected community health centers who fulfill the inclusion criteria. Then sample size, 60 antenatal mothers. Then sample technique, convenient sample technique. Then variable. So in that dependent variable, knowledge of antenatal mother, and independent variable, structured teaching program. Then result. So in that 5% mother were having average knowledge and 95% mother were having adequate knowledge regarding Janani Suraksha Yojana. There is a significant difference between the pre-test and post-test mean score, and it is a statistically significant at the 0.05 level. And the knowledge score statistically significant association with the education of the antenatal mother. Next. Then conclusion. So the finding of the study shows that the structured teaching program was effective in improving the level of knowledge among the antenatal mothers. Thank you.
Yes, hello, Monica. Can you hear me?
Yes, sir.
Yes, Monica, thank you. Very good presented. Monica, I have some few clarifications only. What was the whether it was what was the study design?
So pre-experimental research design.
Okay, what was the findings of the pre-test knowledge? What was the findings of pre-test knowledge score?
So, sir, in pre-test, 85% mother having average knowledge, and 15% having a poor knowledge in pre-test.
And after your teaching program, because it was not in the slide, that's why just for clarification. And what was after your teaching program?
So 95% having a good knowledge and 5% having an average knowledge.
Okay, so which you have shown in slide, it is a post-test knowledge score.
Yes, sir.
Achha, pre-test you have not shown it, no? Right. Okay, what were the demographic characteristics included?
in that education status, then types of family, then occupation of mother, then number of children.
So whether there was any association with the demographic and this?
Yes, sir. Education is associate with the social associate with the knowledge score.
When you have conducted this study and for related to your educational purpose, or when it was conducted?
Sir, I was conducted in an MSc.
It was conducted in PG. Okay.
Yes, PG. Yes.
Okay. So just doing a pre-experimental research design, how is it beneficial? What are the recommendations you want to tell to us?
By this study, we can improve the knowledge of mothers. Then in community, so many antenatal mothers is not aware regarding the that Janya Suraksha Yojana. During my clinical posting, I just came to know that the mother is not having the enough knowledge regarding MCH Janya Suraksha Yojana. That's why I conducted this research.
Okay, good. Do you want to put any recommendations? Anything recommendations based on the study?
Yes, sir. We can use this study in for the large population also. Then we can use other research design also, like a comparative research design.
Okay, thank you.
Thank you, sir. Thank you, ma'am.
Sudha, ma'am.
Monica, madam, how many samples you have taken in the pre-test?
Ma'am, 60 sample.
60 sample. Okay. How much of the percentage you are covered like uneducated criteria? Did you find out the uneducated ladies?
Yes, ma'am. Around in social demographic variables, already I categorized the education level also.
Okay.
So in that up to 12th class, many women are there in education.
Madam, what is the difference time duration between the pre-test and the post-test, madam?
Ma'am, 1 week duration.
1 week. How much time you are taking for one sample, madam?
15 minutes.
15 minutes?
Yes.
Okay. Thank you.
Thank you, ma'am.
Binu sir, any other questions we have to ask, sir?
Thank you, Monica. Now our next presenter is Naina Kite. Please be ready for your presentation.
Yes, sorry.
Next presenter is Naina Kite. Are you there? Naina, please unmute yourself. Okay. Then our next presenter is Jamal Fatima.
Jamal Fatima, are you there? Jamal Fatima, ma'am. Are you ready for presentation, ma'am?
Yes, hello, madam. What happened?
Our next presenter is Mr. Swapnil Rane. Sir, are you ready for this paper presentation? Jamal
Swapnil, you
Fatima,
are
ma'am.
muted. Swapnil, you are muted. You can unmute and then talk.
Yes, sir. Yes, sir.
Okay, okay, good. Swapnil.
Can I share my screen, ma'am?
Ah, yes, yes. Yes, sir.
Okay.
You can share.
Is my screen is visible to all?
Yes, it is visible.
Okay. Very good afternoon, respected juries, respected Binu Joy sir and Sudha ma'am. First of all, I would like to congratulate to Seva Gram Wardha College of Nursing organizing such national conference on such nice topics. And again, I would like to congratulate, as well as I am really thankful to them. They have given chance to present our scientific paper at national level. Myself, Mr. Swapnil Rane, I am working as an assistant professor at Parul Institute of Nursing, Parul University. I will proceed with my problem title first. The research title is Glycemic Alteration, Awareness, Prevention, and its Management among the Diabetic Patients. Research problem statement is a study to assess the awareness, prevention, and management about glycemic alterations among the diabetic patients visiting outpatient department at tertiary care hospital. The introduction, as we know, the diabetes is a group of the metabolic disease, and nowadays it is a vast issue as well as the physical health problem in our medical health care system, and that is a leading disease which is responsible for the deaths in the hospital. But along with the diabetes, those people have the diabetes, so many people are there, they have lack of knowledge as well as the awareness about the management as well as the prevention of the glycemic alteration. If we look on the glycemic alteration, there are the two types. Especially we should look on this hypoglycemia and hyperglycemia. But there are also some of the signs and symptoms as well as the problems occurs along with the glycemic alteration, and that problems need to focus at the healthcare delivery system as well as the under the hospitals as well as the by the healthcare professionals. Another one thing, the why this study is needed to conduct at the tertiary care hospital. I would like to mention over here, there are the 4-6 million people with the diabetes across the world. The data has given by the World Diabetic Federation in the year 2019. But what about India? All data, all the history incidences are created by the international level. But the situation in the India, there are the 69 people with affected with the diabetes, that is a metabolic disorders, and the number of people will be there around 1.23 million by the year of 2040. So that is a main issue and we should look on this. Another one thing I would like to mention over here, after joining the Parul Institute, I was visiting to the Parul hospital and I was interacting with the diabetes people. That time I came to know, while treating to the diabetes patients, so many doctor professionals are there, medical professionals, physicians are there. They are not able to give the guidance as well as they don't have that much time to guide, counsel, as well as educate, aware the patients regarding the alteration, complication, and various problems regarding diabetic mellitus. But being a nursing professionals as well as the teaching faculty, that time one point came into mind, being a nursing faculty, I should do one thing for the diabetes patient regarding the glycemic control. The management had asked me what you can do. Then that recommendation about my research study, I will tell you at the end of my presentation. But first we will proceed towards our objective. Assess the awareness regarding glycemic alteration among the diabetic patients. Then assess the awareness regarding the prevention of glycemic alteration and glycemic management in the diabetes patient. And third objective I have formulated about the association of findings along with their selected demographic variables. Then assumption I was kept for my study, there is a lack of awareness among the diabetes patients about the diabetes management as well as the glycemic control prevention also. Everybody know nurses as well as the doctors are responsible to the management, but who will take care of the prevention? Who will aware the patients as well as their relative? So that's why I have kept my assumption like this way. And I did study on the awareness, prevention management, as well as the managerial part on the diabetic patient. The research methodology I was implemented, a quantitative descriptive research design was used to carry out this research study in the tertiary care hospital. Population for my study was those patients are with the diabetes mellitus, and sample of the diabetic patient visiting to the medicine outpatient department at tertiary care hospital. Here I have not mentioned the hospital name due to the ethical consideration, but there is no any point. I have clear and cut information as well as the permission from Parul Sevasram Hospital, Parul University, Vadodara. This study I have conducted in PSH Hospital, Parul University. The total 100 population of diabetes, 100 samples I have selected through non-probability purposive sampling techniques. Each day, the census we have at least 10 people are visiting to the medicine OPD per day. But this study I carried out from the July month to the December month 2021. The approximately 5 to 6 months I have collected data from the 100 patients, and the reliability also was checked through the test retest methods, and the criteria of the inclusion and exclusion was the diabetic patients were visiting to the outpatient only. I have not chosen the patient those are admitted in the hospital. I have done study on only the outpatient patients. Why? Because those patients are the going to the home after the discharge. I want to focus on that patient. Hospital mein jo bhi patient hai, everybody is taking care of that patients. Everybody is giving the knowledge. Everybody is giving the counseling. But what about those patients are getting the discharge? Those patients are doing the regular follow-up. That's why I have selected only the outpatient as well as the discharge patients along with the diabetes mellitus. And exclusion criteria I have mentioned over you. The critically ill as well as the admitted patient in the hospital, those excluded from my study. Then the tool for the data collection. There are the two sections I have used. The demographic questionnaire structure checklist I have prepared in the first section, and section tool structure questionnaire on the 3 component. First component was there the awareness about the glycemic alteration. Then second component was the management of the diabetic patient on the glycemic alteration. Then preventive component. These 3 main areas I have focused. One is awareness, second one is a prevention, and third one is a ये सब होने के बाद what managerial things you will do at home as well as that hospital side. That only depends on these 3 components. I have prepared the self-structure knowledge questionnaire and I have prepared my tool. Then plan for a data collection. Formal permission was obtained from the hospital authority as well as the medical superintendent of the Parul University. Then the prior permission was taken from the patients before collection of the data. Then analysis purpose of you in the descriptive data, I have used frequency and percentage, mean, median, and standard deviation by using the SPSS software. And for the qualitative association finding revelation, I have used the chi-square t-test. Then if we will focus on the research finding in the frequency and percentage of the demographic data, here you can see the maximum population was from the male category, 60% population from the 100 people, age between 36 to 45 years, means all adulthood population was there in the diabetic category. Education, so many people are there, those have secondary education. There is also lack of knowledge I was found. That is a very biggest problem in our Indian city. I found occupation, so many people are there in the patients, those are the about 40 majority in the self-employed. Then duration of MI, those people I found, those people have the diabetes mellitus around since 1 to 3 years duration. Hypoglycemic agents, so many people are taking the oral hypoglycemic agent rather than the insulin. And I found one thing another than those people are taking the yes ma'am. Then most important thing I would like to mention over here, there was the effectiveness, there was a poor knowledge about the awareness as well as the management as well as the prevention practices I found in the my study findings and result. Only the gender, age, education, occupation, duration, and the hypoglycemic agents are found associated with the prevention of glycemic management. And there is a conclusion. And one thing, please give me half minute. One thing I would like to mention over here. I am the first person in the Gujarat state. I have started diabetes educator counseling session unit at Parul Sevasram Hospital, as well as we have started diabetic educator postgraduate diploma program for the nursing healthcare professionals on the base of this study. And I am very happy with my management. They have permitted to me to run this program. And recently that program was passed in the Academic Council of Parul University. And on the base of this recommendation of my study, my management has promoted as well as given permission to start the diabetic educator program. So this was about my study. I would like to conclude over here. Over to you, respected juries.
Very good, Swapnil.
Thank you so much, sir.
Very good. You have presented and great initiatives and great work you are doing to the society. Very
Yes, sir.
happy to know that. So that was also very good part. So some of the queries which you have, which I have, can you operationalize some of the keywords which you have used in your study?
Sir, actually these keywords assess awareness, glycemic alteration, diabetes patient, and tertiary care hospitals.
Okay, what was the glycemic alterations?
Sir, actually glycemic alteration, this terminology is used by the medical professionals. In the nursing professionals, we are using the complications as well as the side effects of the diabetes. But I took this terminology from the medical book, and they have mentioned glycemic alteration which occurs due to the extra side effects as well as the side effects of the medications as well as the insulin medications. So they are using the side effects of the medication as well as the insulin side effects, glycemic alteration. And glycemic alteration such as hypoglycemia, HbA1c level low ho jata hai, then hyperglycemia.
I want to ask you, in your study, what was the part? In your study, how you have operationalized? I don't want the literature meaning.
Yes, sir. Yes, sir.
What was your operationalized? We have just
same thing, sir. I have consider as a hypoglycemia and hyperglycemia management, sir.
Okay, and you have mentioned two objectives in your research study.
Yes,
right?
sir. Let me go.
You mentioned two objectives.
Yes, sir.
Yes.
Yes, sir.
Yeah. So how you assess the first objective, and what was the tool used for first and second?
Sir, awareness knowledge questionnaire.
Both, or you have used knowledge questionnaire only?
Yes, sir. Awareness about the glycemic alteration on the awareness, prevention, and the management knowledge. What are the preventive factors should be there? What are the managerial factors should be there?
So this knowledge questionnaire, so which two areas only you have taken, but how many number of questions?
25 questions were there, sir.
Okay, whether any validity was done?
Yes, sir. I have done the tool validation from my respective department of head as well as from my principal, and one endocrinologist from Parul Hospital, and reliability also was checked in same hospital only, because this study it was as like pilot study. That's why I have not selected another setting for my pilot study.
With the reliability, how you have done?
Test retest method, sir.
Okay. So what was the only knowledge study you went for? For what purpose it was? What need?
Yes, sir. Actually, exactly. So many people had asked same question to me, but I found we are not focusing the problems of the patients. That's why I want to check their knowledge, whether they are awareness, whether they are aware about the prevention practices as well as the managerial practices. And because of the only knowledgeable things ke behalf we can give the education them, we can start the OPD from the nursing healthcare professional. That's why I went for the knowledge part only.
So what were the findings of your knowledge? Nowhere was mentioned.
Yes, sir. Yes, sir. It is there, but due to the lack of time. Yes, sir. Sir, this is a awareness score. This awareness score is, as you are saying, this is knowledge score only, but I have mentioned over here awareness score. And I have categorized in the 3 sections. First section is awareness regarding the glycemic alteration. 78 people ka awareness was 78 people were aware about the glycemic alteration. उनको पता था कि ये डायबिटीज के कॉम्प्लिकेशन है, and 22 were there the poor awareness. Then second section में I have calculated the management awareness about the people. Then 54 people I found along with the poor management awareness. Then
okay, good. Do you want to recommend, means what you will recommend is further study for this? Some for what people, those who are not aware, what you have done for them? Sudha ma'am? Swapnil?
Yes, sir.
Yes, sir.
It's not visible, sir, on screen.
Swapnil, are you there? And I think he has lost connection.
Yes, sir. Yeah.
Swapnil, are you there?
Swapnil, unmute yourself.
hello.
Yes, Swapnil.
Yes, ma'am. Yes, ma'am. I am here.
Yeah. Swapnil, you had mentioned in your that study part that you had taken the male glycemic that ratio. Did you focus on the females also?
No, ma'am. This is a finding of my study. I got maximum male population. That are the major findings I have included in my PPT.
Okay.
Okay.
That's why you don't focus on the females.
No. It is not like that, ma'am. In the PPT,
No,
I have
females
mentioned.
are there. I think females are there. 40% of the population is female. No, Swapnil, you want to tell
Yes,
like
sir.
that?
60% male and remaining 40% were from the female
Yes.
category. It's
Yes,
okay, you
Swapnil.
put it. Okay.
Yes, ma'am.
You have put it only the highest percentage
Yes,
which
sir.
is there in the
Major findings I have included in my PPT.
So we can predict the others are.
Sir, actually organizer has given the.
When participants are more, no, some participants may get confused. Like in age, you have mentioned a big age group. The other which all age group are there, it gets little confusion.
Yes, sir.
Swapnil, in part of like insulin, what kind of education you had given to them?
Ma'am, in part of the education, sites of the insulin administration as well as the time duration. So many people are there ki time duration between meal and insulin. These two things I have observed. So many people are lack of awareness about the sites of insulin as well as the meal pattern duration in between the insulin administration, as well as the insulin storage at home.
Okay. Yeah, it is also important.
Yes, ma'am. Yes, ma'am.
Yeah. Okay. Nice presentation.
So much. Thank you so much.
Thank you, Swapnil sir.
Thank you, ma'am.
Then next presenter is Jamal Fatima ma'am. Jamal Fatima ma'am, are you ready for presentation?
Yes. Yeah, good afternoon, ma'am. I'm ready. I'm just sharing my screen.
Yes. Okay, ma'am.
Is it visible, ma'am?
Yes, ma'am. You can continue.
So a very warm good afternoon to everyone. So I'm going to present the study, a cross-sectional study to assess the psychological impact of COVID-19 pandemic on nursing students in selected nursing college of New Delhi. Introduction. The 2019 coronavirus outbreak has become an international concern since the first case occurred in Wuhan, Hubei province, China at the end of December 2019. The number surpassed the SARS case in 2003. The number of instances then increased exponentially to spread throughout the world. COVID-19 is impacting almost every sector of the economy, and the education sector is no exception. The schools, colleges, and institutions are closed. Everything is virtual with no physical movement. The continuous spread of the epidemic is strict isolation, measures and delays in starting schools, colleges, and universities across the country is expected to influence the college students. Now, need of the study, the COVID-19 pandemic. The COVID-19 pandemic heavily influenced emotional well-being and consequently mental health of the people around the globe, either directly connected with health issues or indirectly, in relation with its economic and social consequences. Crises like these can harm the academic functioning and psychosocial health of nursing students also. To date, in India, information available of the new coronavirus on nursing students. However, it is expected that the need for psychological intervention will gradually increase and prompt rapid and urgent research on the associated psychological impact. Therefore, the present researcher thought to assess the psychological impact of COVID-19 pandemic on nursing students in selected nursing college of New Delhi. So this is the statement of the problem, a cross-sectional study to assess the psychological impact of COVID-19 pandemic on nursing students. And the objectives of the study are, first, to assess the psychological impact of COVID-19 pandemic on nursing students. And second objective is to find out the association of the psychological impact of COVID-19 pandemic with selected demographic variables. Now coming to the methodology. So research approach used was quantitative approach. Research design was non-experimental cross-sectional survey design. Setting was Rufaida College of Nursing, New Delhi, and population was nursing students. Sample was 100 undergraduate nursing students, and sampling technique was convenient sampling technique. The data collection tool included the online questionnaire, and it was divided into two parts. Part A, the demographic data of the subject, and it consisted of 10 items pertaining to age, gender, education, religion, place of residence, type of family, parent occupation, family income, relative or acquaintances, COVID-19, and source of information. And part B, we used a standardized tool, that is depression, anxiety, stress scale, or DAS-42, and it consisted of 42 items. The validity and reliability was well established as it was a standardized tool. Now, the data collection technique, online survey through Google form was conducted, and data was analyzed using descriptive and inferential statistics. Now coming to the results, so the section 1, which include the demographic profile of the subjects or the students, so we can see that 68% of the students were in the age group of 17 to 18, and 32% of the students were 19 years and above. 68% of the students were female and 32 students were male. 44% of the students were from BSc nursing program, and 56% of the students were from BGNM program. 81% of the students belong to urban place of residence, and 19% of the students belong to rural place of residence. Now, with regard to the type of family, 74% of the students were from nuclear family, and with regard to relative or acquaintances got COVID-19, so we can see that 82% of the students said no, that their relatives or acquaintances did not get COVID-19 infection. And 66% of the students reported the source of information from internet, and 29% reported television was the source of information for COVID-19. So this was the demographic profile. Now coming to the section 2, that is findings related to the psychological impact of COVID-19 pandemic on nursing students. So you can see that the frequency and percentage was given as psychological impact was assessed in terms of depression, anxiety, and stress. So it was categorized into normal depression or mild depression, moderate, severe, and extremely severe. So we can see here that 53% of the students reported normally, means they did not have any sign of depression. And 16% reported severe level of depression, and 6% reported extremely severe level of depression. With regard to anxiety, again 41% of the students were normal, and 24% of the students reported extreme level of anxiety, and 10% reported severe level of anxiety. And when we see the stress level of the student, again 49% of the students were normal, and 19% reported moderate level of anxiety, moderate level of stress, and 6% reported severe level of stress. So this is all about the psychological impact in terms of depression, anxiety, and stress. Then section 3. Section 3, we calculated the association of the psychological impact of COVID-19 pandemic with the selected demographic variables. So due to the time constraint, I have not shown the tables because there were around 8 or 9 tables. So I have tried to write the whole inference in the paragraph form. So association was, means we checked the association between the psychological impact of COVID-19 pandemic in terms of depression, anxiety, and stress with selected demographic variables like age, gender, place of residence, relative or acquaintances got COVID-19, and source of information using Fisher-Exec test. And we did not find any significant association with the any demographic variable at 0.05 level of significance. Now the conclusion. So in the present study, the student showed more symptoms of anxiety rather than depression and stress. So the researcher felt that the administrative staff in the college should regularly carry out some mental health education activities to reduce the anxiety of the student as possible and avoid the negative result caused by mental health problems, specifically during this COVID era. So thank you so much. This is all about my presentation.
Yes, ma'am. Good afternoon. Ma'am, where are you working and where the study was done?
Actually, sir, study was done in Rufaida College of Nursing, Jamia Hamdard, New Delhi.
Okay. And where are you working now?
I'm working in the same institution, sir.
I think you're working in same institute. Actually, I thought you were working in Jammu. So I got confused when the study was done. Okay.
Okay.
Okay. So if you trust how was this? What was the psychological impact of the nursing students? What was the tool used for that? This same one, to standardized tool only?
Yeah. It was a standardized tool only, sir. And we have done the extensive review. So we find that psychological impact was studied by 2 or 3, because when we started this study, so at that time only 2 or 3 studies, the foreign studies were available on the impact of COVID-19 on students. So either they have studied through DAS, that is in terms of depression, anxiety, and stress, or they have studied the psychological impact in terms of post-traumatic stress disorder. So we chose the this particular depression, stress, and anxiety scale.
So you have only assessed these factors only: depression, anxiety, and stress only. Any other factors?
No other factors because
need for study. Anything you have found out? Any other factors which is affecting psychologically?
Sir, actually, we have not studied. We have only focused on these 3 factors.
Okay, that was my concept with it. So I was trying to look out what was it, how was the psychology. So this was the standardized scale only you have used it. Okay.
Yes.
Then what was the sampling technique for the use? And how
actually,
the data was
collected? Data, because students were usually, they were not in the college. So we have used the convenient sampling because various other students were busy with their clinical postings and all. So 2 batches of BSc and GNM were available. They were in the study block. So we conducted data from the GNM, 1 GNM batch and 1 BSc batch.
So it was through online or whether?
No, it was through online.
Through Google Forms, you have created Google Forms.
Use the Google Form.
Okay.
Yes.
Then what was the findings and any association was there? Which factor of psychological impact was more?
No, sir, anxiety was means more common among the students.
Okay, very good, ma'am. Very good.
Thank you, sir.
Okay. Sudha, ma'am.
I think the majority of the parts you had asked, sir. No need to ask questions.
Thank you, ma'am. Thank you so much.
Thank you, madam. Our next presenter is Naina Kite, madam. Naina, madam, are you ready for presentation?
If anyone else is ready, you can do it.
Yes, next. Naina, madam, are you ready? Ma'am, please unmute yourself. Ma'am, your PPT is visible. Please you mute.
Sorry, ma'am, for inconvenience. Can you show my PPT? Okay, so good afternoon to everyone. So my study statement is a pre-experimental study to assess the effectiveness of plant teaching about knowledge regarding initial drug use in myocardial infarction among staff nurses working in selected hospitals. Next, introduction of my study is coronary heart disease, accounting, coronary heart disease accounting for 17.3 million per year, 3.8 million male and 3.4 million females are affected with cardiovascular diseases. It is a major public health problem in developing countries. According to the statistic on myocardial infarction 2016 report, almost 27,000 cases of acute myocardial infarction occurred and nearly 6,300 people died. As compared with Western country, in Western population, only 23% of cardiovascular diseases that occur before 17 years of age, and in India, this number is 52%. Next slide. Next slide, please. Emergency management and immediate treatment of myocardial infarction will help to avoid heart attack and associated complications. Treatment of myocardial infarction is critical. When the patient reaches the hospital, the first goal is to minimize the size of infarction or infarct. Next slide, please. The objective of my study was to assess the existing knowledge of staff nurses about initial drug use in myocardial infarction. Second objective is to determine the effectiveness of plant teaching about initial drug use in myocardial infarction among staff nurses working in selected hospitals. And third objective was to associate the knowledge of staff nurses about initial drug use in myocardial infarction with selected demographical variables. Next slide, ma'am. Research methodology. Quantitative research approach was used. Research design is one group, pre-test and post-test result design was used. Sampling technique was used, that is the non-probability convenience sampling technique. Samples are staff nurses, those who are working in selected hospitals. Sample size was 60. Setting of the study was selected hospitals, and tool was structured knowledge questionnaire used to gain the knowledge of the staff nurses. Next slide. The inclusion criteria: staff nurses who are willing to participate in the study, the staff nurses who are available at the time of data collection, staff nurses who are able to read and write English. In exclusive criteria for the study was staff nurses who suffered from myocardial infarction, those who attend similar type of teaching program regarding initial drug use in myocardial infarction. Next slide, please, ma'am. Result of the study was in pre-test 7, that is 11.66% of staff nurse were having poor level of knowledge score. 43, that is 71.60% of staff nurses were having average level of knowledge score, and 10, that is 16.66% of staff nurses were having good level of knowledge score, and none of the staff nurses were having very good and excellent level of knowledge score. Result of the post-test was the knowledge score indicate none of the subjects were having poor and average level of knowledge score. 9, that is 15% subjects were having good level of knowledge score. 19, that is 31.66% subjects were having very good level of knowledge score, and majority, that is the 32, that is 53.33% subjects were having the excellent level of knowledge score regarding initial drug use in myocardial infarction. Next slide. This table shows the comparison between the pre-test and the post-test level of knowledge score, which I already explained. That is the in pre-test 7 subjects having the poor level of knowledge score, as compared in post-test none of the subjects having the poor level of knowledge score, and in pre-test 43 subjects having the average level of knowledge score, but in the post-test none of the subjects, means after intervention none of the subjects having the average level of knowledge score as compared to pre-test. Okay, this is the significance. This table shows the significance of the difference between the knowledge. Okay, ma'am, can you show slide? So my study shows that there is an association of year of experience with the pre-test knowledge score. In this study, for the detailed analysis, it shows that the post-test mean score is 26.61 and the pre-test mean score was 15.28. The hypothesis is tested statistically with distribution of pre-test and the post-test mean, standard deviation and the mean difference. It is interpreted that selected demographical variables, that is age, sex, professional qualification and area of work, is significantly not associated with their pre-test knowledge score, but the year of experience is significantly associated with the pre-test knowledge score. Thank you so much.
Good afternoon, Naina.
Good afternoon, sir. Sorry for inconvenience.
Okay.
Sorry, ma'am.
Your health is okay? You are having some fever or anything?
Yes, I have some problem.
Okay. Hope you will recover best. Okay. A few only clarifications. What was the need for doing a study? What was the need you find it out to do this study?
According to the CDC Center for Disease and Prevention 2016 report, in India, there is 7.3 million people die due to the myocardial infarction or the coronary heart disease. And in India, some events are occurred during that period. In one hospital, one doctor is died due to the sudden myocardial infarction. So there are some nurses was present, but they can't provide the immediate treatment to that person. So I thought it is necessary to provide the knowledge to the nurses regarding the initial treatment of myocardial infarction.
And when was the study done? Whether it's your PG study?
Yes, sir, it is
your PG study. So you were working in the same. How many hospitals you have selected?
I was selected 2 hospitals in the Nagpur city. My sample size was 16, so I divide that 13 from both hospitals.
Total 30 samples.
No, sir. Total 16 samples, but I categorized 30 in 2 hospitals, from the 2 hospitals.
Were there any control group was kept only, except pre-experimental only one group? What was the method?
Yes, it's only pre-experimental study.
Pre-experimental study. Okay, good. Okay.
Thank you, sir.
Naina, what kind of drugs in particular cardiac medications you had explained to the staff nurses?
That is the oxygen, and second is the nitrate, that is the nitroglycerin, and thrombolytic agents, and morphine. That is the main thing which I was explained to the in the initial drug used.
Okay, how much time duration you are taking for this for one sample for explaining this questionnaire?
Actually, I gathered some 15 samples at a time, and I explained that in a teaching room for the 45 minutes. I explained to them. Then I take the before the treatment, I take from their staff nurses from there the pre-test for the 13 minutes for pre-test and 45 minutes for the treatment.
Okay, good. Thank you.
Thank you, madam.
What was the reason select staff nurse group?
Because staff nurses are working 24 hours in the hospital. So sometimes what happens is doctors are not present due to some issue. So staff nurses have to assess the minute points which leads to the myocardial infarction or the sudden heart attack. So they have to know what are the minute points and what initial treatment have to provide to the patient in that initial period. So I feel it.
Okay. 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 Thank you.
Thank you.
Thank you, madam. Now, our next presenter is Arti Praveen Dange, madam. Are you there, ma'am?
Yes, ma'am.
Yes, yes. You can start your presentation, ma'am.
Yes, ma'am. So, good afternoon to all. Respected sir and ma'am. Good afternoon to all and all participants. So, I want to start with the introduction. As we all know that environment is a big important health determinant, as most of our health is due to only environment. As health of individual, family, and community at large. Health of people is affected by the quality of place where we live, okay, where we live, where we work, and which air we breathe, which water we breathe, drink, and which food we consume. So environment is very important health determinant. So I have next slide, please, ma'am. So I have selected this statement for my research study, that is a comparative study to assess the environmental sanitation practices and its effect on health among the people residing at selected rural and urban area of Rahata Taluka. So I have selected urban and rural place which is situated under the Rahata Taluka district, Ahmednagar. So objective for my study was to assess the environmental sanitation practices and its effect on health among the selected urban population. Second objective was to assess the environmental sanitation practices and its effect on health among the selected rural population. First was for the urban people, next was rural people. Then last one is to find out the relationship between the health effect of environmental sanitation practices with selected socio-demographical variables. Next slide. So materials and methods used for this study. I have followed non-experimental descriptive design with cross-sectional study. Then setting of study, as I have already conducted comparative study, so I have selected two places. That is one is the Rahata and next one is the Astagav, that is situated under the Rahata Taluka district of Ahmednagar. Rahata was taken as a urban place while Astagav was taken as a rural place. Then sample I have selected that people in the age group of above 18 years who are residing at Rahata Taluka and available during the data collection period. Then sample size for this research study was 100. The total number of sample were 100. That is 50 from the urban place, Rahata, and 50 from the rural place, that is the Astaka. Then sampling technique that I have used for this study purpose, that is a systemic random sampling technique. Then conceptual framework that already we all know, that Lawrence Nightingale environmental theory, which I have used for this study purpose. Next slide, please, ma'am. Then inclusion criteria for this study: the person above the 18 years of age, then who are residing in urban and rural area and able to speak and understand Marathi, then present during the data collection period, and those who are willing to participate in study. So method of data collection for this study, I have used self-structured questionnaire were used to collect the data from participant. Then construction of tool, I have made 3 sections. First section A, which consists of demographic data of sample. Section B, which consists of questionnaire to assess the environmental sanitation practices, which contains the about 28 items. Under that, this B section, I have included various items, for example, housing quality, water facilities, electricity, toilet facility, hand hygiene, cooking practices, and farming practices. Then other section C, I have used Performa for assessing the physical health status, which included the presence of illness, 7 item, and systemic examination. I have done systemic examination format. Then next is the validity. The content validity was done from the 10 experts. Then reliability of tool was tested with the inter-rated reliability method by implementing the tool on 10 samples who were other than the sample of study. And split half method was used to test the reliability of questionnaire, and R value was 0.8. So next slide. So this is regarding the result. So as I have completed with this result, that I have studied housing quality. Under the housing quality, I have made the most first focus on the ventilation. That is the most common
Aarti, you are muted. Please unmute.
Okay. Sorry, sir. Sorry, sir. So, as a housing quality, I have studied under housing quality various types of house and numbers of room, and finally the adequate ventilation. As I have concluded about that, most of rural people have the good ventilation, while in urban area, most of people are facing with the ventilation problem. Then, next slide.
Ma'am, please conclude your topic.
Yes. Okay. As per, I have studied various factors like water facility, housing facility, waste management facility, and I have concluded about that most of people having the waste problem. That is, most of rural people having they are disposing waste by burning. But while in a rural place, I am concluded that most of people are using the community dustbin. So regarding the discussion, ma'am, next slide. Then next is about the toilet facility. That is most of means toilet facility. Most of people are in urban area. There are the 100% of toilet facility. While in rural area, 90% of facilities are available. Still 10% of people are practicing open defecation. So regarding the conclusion or discussion, so highest percentage of presence of illness in urban area where 20% of them had other illnesses such as dengue, typhoid, malaria, rickettsial fever, skin infection, and 18% of them having the case of anemia, 14% were diabetes mellitus, 12% were hypertension, and 4% were CCM, that is congestive cardiac failure. The average mean was for the presence of illness in urban area was 4.25, while in a rural area, most of people had the problems, that is the 80% of hypertension, then 18% of anemia, 16% of other illnesses, for example, dengue, malaria, typhoid, rickettsial fever, and skin infection. And 12% were diabetes mellitus and 2% were CCM. And average mean presence of illness in rural area was 4.71. So correlation between environmental sanitation practices effect on health with selected socio-demographic variables shows that there was a positive relationship between the environmental sanitation practices and its effect on health in both urban and rural area. There was a positive relationship between the physical health status of people with their socio-demographic background. Next slide, please, ma'am. Then a recommendation, as I have made some recommendation that based on the study findings, that a similar study can be taken for the large samples, then similar study can be conducted in tribal area, then also similar study can be done for the hygienic practices also in tribal and rural area. Thank you. Thank you, sir. Thank you, ma'am.
Yes, thank you, Aarti. A wonderful presentation. Aarti, what was the reason? How you have clarified this is urban area and rural area? What was the criteria used to differentiate urban and rural?
Yes, sir. As we have community posting, as I have done my specialization in community health nursing, so I coming across with daily such events that
you have taken permission from who? From the which authority you have taken permission for conducting the study?
I have taken permission from here, that ethical authority here, PIMS, Pravara Institute of Medical Sciences, and also I have taken permission from the Taluka Health Officer.
Okay, Taluka Health Officer, they have given you, no?
Yes, sir.
Whether it's Pravara Institute is a medical college?
Yes, sir. Yes, sir. Pravara
Whether,
Institute of Medical.
so whether they have any adopted rural and urban village?
Yes, sir. Yes, sir.
So why Taluka officer was taken permission or from the medical college department, concerned HOD?
No, sir. I have taken
And both.
permission from here. And also I have taken permission from Sarpans of respected village and TH also.
Now these samples you got in urban and rural area, where they got? How you went roam home to home? Yeah, how data collection?
Yes, home to home, sir. Home visiting was done under our community posting only.
Okay, good.
Aarti madam, which language you are preferred for asking the questionnaire from the samples?
As ma'am, I have made tool in English and I have translated it in Marathi, ma'am.
Okay, is that the questionnaire you prepared in the Marathi language, local language, right?
Yes, yes, ma'am. Yes, ma'am.
Madam, in part of that questionnaire content, which kind of questions you had asked from the samples? What are the things you kept in your content?
Yes, ma'am. I have made some section like housing quality. Under housing quality, I have made some objective type question and yes, no type question also, ma'am. For example, if they are living in the types of house, kacha, pakka, or then whenever I am calculating about ventilation, I use that counting the doors and windows like that.
Okay. Okay. Thank you.
Thank you, ma'am. Thank you, sir.
Thank you, Aarti madam, for this presentation. Now, our next presenter is Bala Sonal Behan Madhubai. Ma'am, are you ready for presentation?
Hello. Yes, ma'am.
Yes, yes. You can start, ma'am.
Can I share, ma'am?
Yes,
Hello.
yes.
Okay. Hello. Am I audible, ma'am? Hello.
Yes, ma'am. Yes, yes.
You are audible.
Good afternoon, ma'am. Good afternoon, sir. First of all, thank you so much for giving me this opportunity. Now I am going to start my presentation. Myself, Sonal Wala from Vibrant Nursing College, Surat. My problem statement is a study to assess the effectiveness of plant teaching program regarding awareness of blood donation among non-medical students in selected College of Surat City, Gujarat. Introduction. Blood has always held mysterious fascination for all and is considered of our body. Ancient Egyptians recognized the life-giving properties of blood and they used it for the baths to resuscitate the sick, rejuvenate the old and infirm, and as a tonic for the treatment of various disorders. Blood is a scarce and precious resource. A blood donation truly is a gift of life that a healthy individual can give to others in their community who are sick and injured. We have one life. Let us make our life more meaningful by donating blood. Blood donation is the mother of all donations. It directly gives life to another human being. It is not only saves one individual, but also the entire family of that individual. Increase in the level of awareness and positive attitude towards blood donation is the highest priority of all blood transfusion centers. The initial step for achieving this goal is to perform comprehensive studies measuring the current situations of awareness, knowledge, beliefs, and both positive and negative attitudes of the population towards the blood donation. So objectives of the studies are to assess the knowledge regarding awareness of blood donation among non-medical students before and after administration of plant teaching program in selected colleges of Surat, Gujarat. So what is the research methodology? In that research approach was quantitative pre-experimental research approach. One group pre-test, post-test research design was selected and sample was 30 non-medical students.
Sonal, please share that slide.
Yes.
Because of some electrical current issue, so she is not able to join us. So can we move to our next presenter, sir?
Yes, yes, ma'am. Yes.
Okay, ma'am. Okay. Our next presenter is Sonal Mayank.
Yes, ma'am, I am ready. Yes, ma'am.
Yes, ma'am.
So can you share, madam, my PPT?
Yes, you can share, madam. You can start.
Madam, you have to share. Already I have submitted. Good afternoon to sir and madam. Myself Sonal Pandya from Government Nursing College, Surat. And today I am going to present one problem statement and study on that. So statement of the study is a study to assess the effectiveness of skin-to-skin contact by father and its impact on physiological parameters among newborn admitted in New Civil Hospital, Surat. Next, introduction. So as we all know, so child health, it is the foundation of the family and wealth of the nation. And among the major child health challenges facing the world at the turn of the new millennium is the problem with high neonatal mortality rate. And we all know that first 28 days of the life, the neonatal period, it is the most vulnerable time for child survival. A nurse has to provide the education and support fatherhood. As we all know, we are always focusing on for mother, but nowadays father also, it's same importance we have to give for care of the newborn. So here nurse has to give support fatherhood and encourage positive father involvement from the earliest hours of the child's life. Many conditions resulting in newborn death can either be prevented or treated using low-cost intervention. So here we all know skin-to-skin contact, it is low-cost intervention. There is no cost behind it. So the skin-to-skin contact ensures people from all economic standards to give the needed care for the newborn. The newborn can prevent hypothermia, and it also helps the baby to conserve energy and bring the organs to normal functioning. So skin-to-skin contact, it is provided mostly by the mother rather than father, but over the last few decades, father have played a greater role in the newborn care. Next, need of the study. So as we all know, neonatal mortality rate, it is high, but in last few decades, so it is less. It is reduced because of cost-effective care such as essential care during childbirth and in the postnatal period for every mother and baby. So exact need for this study for so if the mother is not in a condition to give kangaroo mother care at that time, it's the responsibility of the father to give skin-to-skin contact to newborn to prevent hypothermia and stabilize newborn. It will be wonderful bonding time for both father and baby. So as we all know, father can hold baby, change nappy, carry, talk, and sing. And there is only one thing father cannot do, it is breastfeed. So skin-to-skin contact has many advantages over the conventional incubator care, and it improves the health of the newborn. Next, objectives of the study. So here I have prepared two objectives. So to assess the physiological parameter of newborn before skin-to-skin contact by the father, and to assess the physiological parameter of newborn after skin-to-skin contact by the father. And hypothesis, it is there will be significant association between before and after skin-to-skin contact by the father. Next, research methodology. So research approach, here I have used, it is a quantitative approach. Design, it is pre-experimental research design. Research setting, it is NICU, New Civil Hospital, Surat. Sample fathers and their newborn. Sample size I have taken, it is 30. And sampling technique I have used, it is non-probability convenience method. Next. So inclusion criteria, newborn, those who are admitted in NICU. And second, it is newborns, father, those who are willing to provide skin-to-skin contact. And exclusion criteria in that newborns, father, those who are not willing to provide skin-to-skin contact, newborn with some infection, severe respiratory distress, newborn on ventilator, newborn on oxygen therapy, and newborn with congenital anomalies. Next. Development and description of tool. So here I have prepared in two sections. So section 1, it has like demographic profile, like newborn age, sex, birth weight, mode of feeding, duration of hospital stay, then type of delivery, gestational age, and birth order. And for father, mainly age, religion for all, education level, occupation, and monthly income. And section B, in that assessment of the level of physiological parameters of newborn, that is this parameter I have checked, it is temperature, heart rate, respiratory rate, weight, skin color, crying, and sleep of the baby. So data collection procedure, how I have done, so it is like done pre-assessment of the physiological parameter of newborn before skin-to-skin contact by the father on first day, then provide skin-to-skin contact by father for 1 hour at a time for 3 days. Then in that, I have assisted father to perform skin-to-skin contact by placing the newborn on father's chest in frog-like position for 1 hour at a time for 3 days, and assess the level of physiological parameters among newborn by assessing the temperature, heart rate, respiratory rate, weight, skin color, crying, and sleep. Next, results. Next slide. So plan for data analysis in that. Okay, so results. So here first we will see demographic variable before previous slide, madam. So in that, mostly as regard to age, 20 newborn belongs to age of 1 to 3 days, 8 newborn belongs to age of 3 to 6 days, and 2 newborn belongs to age group of 6 to 9 days. Then as regard to birth weight, most of the child, so 13 newborn belongs to birth weight of less than 1.5, 11 belongs to 1.5 to 2.5, and 4, it is between 2.5 to 3. Then as regard to mode of feeding, so mostly they have like a pedal-eye feeding. So in that, 6 newborn is on pedal-eye, then 7 newborn is on mainly nasogastric tube, then 10 newborn is on breastfeeding, and 7 they are on spoon feeding. Then hospital stay, if you will see, so 19 newborn is hospitalized since 1 to 3 days. Then 10 newborn is in hospital since 4 to 6 days, and 1 newborn is in hospital since 6 to 10 days. As regard to type of delivery, most of the newborn they are delivered by means of cesarean section. Like 17 newborn they have cesarean delivery, and 13 newborn they have delivered vaginally. As regard to birth order, so 10 newborn is first baby, 14 newborn is second baby, 4 newborn is third baby, and more than that it is 2 baby. Then age of father, so 8 father belongs to age like 20 to 26, 7 father belongs to age 26 to 30, 9 father belongs to age 31 to 34, and 6 father belongs to age above 35. As regard to religion, if you will see, so 20 they are Hindu and 9 they are Muslim. As regard to education, 9 father had primary education, 14 father had secondary education, 5 father had done graduation, and 2 they are illiterate. As regard to occupation, if you will see, 14 father is doing like service, 16 father is laborer, and no one is unemployed and farmer. Monthly income, if you will see, so 0 less than 3,000 per month. Then 2 father, their earning it is between 3,000 to 5,000. 16 father, their family income it is 5,000 to 10,000, and more than 10,000 income it is 12. So now next, now we will see table showing the frequency and percentage of physiological parameters. So what here I have found, so mainly I have taken this like 7 criteria I have checked parameters. So first we will see temperature. So before skin to skin contact and after skin to skin contact, what is the difference? So temperature, if you will see, as we all know, hypothermia. So normal body temperature of the newborn, it is 97.8 to 99. Fahrenheit. So here below 95, if you will consider, so they have hypothermia. So before skin to skin contact, 8 newborn, they have like hypothermia, and after skin to skin contact it comes 0. Then hyperthermia before skin to skin contact 13, and after skin to skin contact 5. Normal before skin to skin contact 9 newborn were there, and after skin to skin contact 25 newborn they have. Then heart rate, if you will see, so before skin to skin contact tachycardia, total 4 newborn have tachycardia, and normal they were 26. But after giving skin to skin contact, bradycardia 1 neonate is having, and normal 29. If we will see respiratory rate, so before skin to skin contact 5 newborn they have tachypnea, and normal they were 25, and after skin to skin contact all they came into normal. Then if you will see weight, so weight loss during these days, so 20 newborn they have weight loss and no weight gain. 10. So after skin to skin
Madam,
contact,
please conclude.
Okay.
Conclude your topic.
Okay, next slide, madam. Next, please, ma'am. Next slide, please, ma'am. Please, madam, next slide. So the present study assessed the effectiveness of skin-to-skin contact by father for 1 hour at a time for 3 consecutive days on level of physiological parameter of newborn. And the study findings prove that the skin-to-skin contact by father for 1 hour at a time for 3 consecutive days was effective in improving the physiological parameter of the newborn. So the healthcare provider in their practice while caring for the newborn in the NICU, postnatal ward and home settings can utilize skin-to-skin contact. Hence, it can be used as a simple, cost-effective care to maintain the physiological parameters of the newborn, and it can use as a routine care of the newborn. Next slide, ma'am. So recommendation. A study can be replicated with larger sample. A similar study can be conducted for longer duration, and study can be conducted with control group. Thank you so much. Here I have completed my topic.
Yes, good, Sonal. Very good. Sonal, how much duration this skin-to-skin contact was given?
Sir, at a time, 1 hour for 3 days. So maximum 3 times a day father has given, sir.
3 times a day?
Yes, sir.
For a duration of continuous 1 hour?
Yes, sir. 1 hour.
Okay. And then the samples, what was the sample dropout? If you find it out any dropout?
No,
in the
sir.
samples?
No, sir.
You have not found it out any dropouts?
No, sir.
So 3, you were expecting the baby will be 3 days will be there in the hospital stay.
Sir, I have selected that sample only. First, I have contacted with pediatrician. Those baby they will keep in an ICU, sir. So that baby only I have selected, sir.
My question is that there was no any dropouts, or that only the sample size you have taken?
Sir, no dropouts.
Okay, good. And how you have done this validation of the stool? What
Sir,
was
validation, I met pediatrician, and along with sir only I have done, sir.
Very good. You have taken one more compound, parenthood. I'm very happy you have taken
Yes,
father
sir.
also.
Yes, sir.
Really,
Nowadays
mother
it's
is
important,
involved.
sir. Every time, like it is, father has to earn and mother has to take care. So for that only I have selected father, sir.
Yes, very good. Essence of parenthood is when both father and mother combines
Yes.
for the care of childhood. So
Yes,
I'm
sir.
very appreciate that essence you have brought out, and you involved father to
Yes,
give
sir.
importance to the father for the care
Yes, sir.
of child.
Yes, sir.
Good, good, very good.
Okay, sir.
Madam, can you explain me that is there any criteria for like disease condition like preterm, low birth weight, or any other condition you specify for this? You are using that.
No, madam, in demographic only I have mentioned ki like birth weight I have taken, and second gestational age also I have taken, but those I got during my data collection I have selected, madam. So in that mainly type of delivery also mostly 17 they have cesarean delivery, so mother cannot able to give this skin to skin contact, so that's why I have selected father. And second mainly birth weight. So if you will see in birth weight in my demographic variable, low birth weight baby they were 13, so they are below 1.5 kg. So this is the reason I have taken, ma'am.
Okay. And did you selected the only 3 days for conducting this?
Yes,
time
yes,
duration?
ma'am.
Why,
Yes,
ma'am?
madam.
Why are taking?
Because, madam, if I will means long duration, if means it was my assumption that chances of dropout it will maybe baby will die, baby will discharge. Otherwise, father will also not available after 3 days. Maximum 3 days, so father will stay with the newborn if mother is in hospital. So maybe then father will go for job, and also that's why I have selected 3 days, ma'am.
Yeah. After that kangaroo mother care, you added a new research in the study, madam. Good.
Thank you, ma'am. Thank you so much, ma'am.
Thank you, Sonal madam, for this presentation. Now, our next presenter is Mrs. Keelam Patel, madam. Yes.
Yes, ma'am.
Keelam Patel, madam. Hi. You can start your presentation now.
Okay, thank you, ma'am. Okay, myself Patel Kilam from Vibrant Nursing College. So title of the study, to assess the effectiveness of the training program on knowledge and beginning skill regarding cardiopulmonary resuscitation among staff nurses working in intensive care units at selected hospitals of Surat, Gujarat. Next slide, please. Next slide, please. Ma'am, please next slide.
Yes, ma'am, because of some network issue.
Yeah, okay, no problem, ma'am. Introduction. Cardiopulmonary resuscitation dramatically increase the survival for a victim suffering from the sudden cardiac arrest. CPR is a combination of the chest compression and breaths and provides a critical blood flow and oxygen to the heart and brain. If CPR is started within 3 to 5 minutes of the collapse, it increases a victim's chances of survival and reduces the chance of permanent damage. Next slide, please. Need for the study, sudden cardiac death from coronary heart disease occurs over 900 times per day in the United States. The risk of adults is estimated to be about 1 per 1,000 adults 35 years of age and older per year. Sudden cardiac death in the young is much less common than in adults, occurring in only 0.5 to 1 child per 1 lakh per year. CPR may not save the victim even when performed properly, but if started within 4 minutes of cardiac arrest and defibrillator is provided within 10 minutes, a person has a 40% chances of survival. Objective. To assess the knowledge regarding cardiopulmonary resuscitation among staff nurses working in intensive care units before and after training programs, to assess the beginning skill regarding cardiopulmonary resuscitation among staff nurses working in intensive care units before and after training programs, to compare the pre-test and post-test knowledge and beginning skill regarding cardiopulmonary resuscitation among staff nurses working in intensive care unit, to associate effectiveness of training programs with selected socio-demographic variable such as age, gender, professional education status, etc. Methodology, research approach, quantitative research approach, research design, pre-experimental, one group, pre-test, post-test design, variables, independent variables, training program regarding CPR, dependent variables, knowledge and beginning skill regarding CPR. Research population, the study population consists of the participants who are working at Venus intensive care units of Venus Hospital, Surat. Research setting, Venus Hospital, Surat, Gujarat. Sample, the study sample included selected participants working in Venus Hospital, Surat, who fulfill the criteria. Sample size 30 participants. Sampling technique, convenient sampling technique, criteria for sample selection, inclusion and the exclusion criteria. So in that first inclusive criteria, participants who are willingly to participate in study, nurses who are working in selected hospital, registered nurse after completion of GNM, BSc and MSc nursing, participants working in intensive care unit. Exclusive criteria, nurses who are not available at the time of data collection, nurses with managerial responsibility like floor supervisor, nursing superintendent of selected hospital Surat, those who have already undergone training on CPR. Result of the study. In pre-test knowledge score of participants, 6.7 of them had poor knowledge score. In post-test, 0 of them had poor knowledge score. In pre-test beginning skill score of participants, 33.3% of them had poor
score during the pre-test, and during post-test, 0 of them had beginning score in poor. Therefore, knowledge and beginning skill score was increased after the training program. There is a significant difference between the pre-test and post-test mean, and it is statistically significant at 0.05 level. The knowledge score shows this statistically significant associated with the professional educational status and work experience in the hospital of the staff nurses. Conclusion: in pre-test, there was a lack of adequate knowledge and beginning skill of participants regarding CPR, but after the training program, there was a significant improvement in knowledge and beginning skill of participants. So it can be concluded that training program is found to be an effective and feasible method of teaching strategy to improve knowledge and beginning skill of the participants. Keywords: training program, CPR, knowledge and beginning skills. Thank you.
Good, Kiran Patel, good, very good. Okay, I have some of the clarification. What was the need to go for a CPR-based study, knowledge? What was the need for that? What you thought
Sir,
of doing this study?
Yes, some of the staff nurses have less knowledge of the CPR and how they are performing in because of they have routine there in their ICU or the intensive care unit. So that's why I thought that there is a more improvement in their knowledge, and with that
Why the practice skill was not added? What is the need of only going for a knowledge-based studies and your practice is neglected? Because the training, why you did not thought of practice?
Sir, I had added the beginning skill. So in that I had performed first of all, then after I checked that they are performing well or not. For that I had taken the certificate from the AHA for BLS certificate.
Good, very good. You have undergone training. Why to have nurses only training? Whether emergency situation, all can learn. A layman can also should know the CPR, the housekeeping faculties, hospitals, everyone should know. So CPR is anytime you can have any abnormalities, and people like you have trained that knowledge and practice, but you have trained. If it was given to the lay peoples or housekeeping staffs, not even. Why there was a need to do a staff nurses? You want to say that staff nurses are not good? Are you proud to be a nurse?
Yes, sir. But there was more improvement in their skill or practice. So that's why.
Okay. And how you have taught, whether you have taught it or you just assess the knowledge?
Assess the knowledge and beginning skills, both are. For that, I made the structured knowledge questionnaires and observation checklist.
You made observational checklist also?
Yes, sir.
So how many questions were there in that?
Sorry, sir?
How many questionnaires were there in that?
Sir, 25 questionnaire.
And how much was the time duration of this? How the tool, what was the time duration to collect data?
Okay, so for that, I had taken 1 hour to taught and to assess their beginning skill also. And after 7 days, I had taken the post-test skill. And I had divided the sample, like 14 samples in a particular time and 14 sample particular time. I had divided the samples according to
So
that.
staff nurses you have assessed in the clinical area or somewhere you have called?
Nice, in clinical area.
Okay, thank you.
You have only question on the basis of the questions, you're just taking the post test, or you are showing any kind of demonstration to them?
Yes, sorry. Yes, ma'am. I had demonstrate first. Then after I had taken the post test for that.
Okay. You had given 1 hour for all. Right?
Yes, ma'am. Yes, ma'am.
What is the difference of the time duration between your pre-test and post-test?
Ma'am, firstly, when I was started, so that time I was just difficulty to that means showing them particular like practice the skill, but after that somewhat like 50 to 20 minutes I saved before and after that post test.
Okay.
Yes. Thank you, ma'am. Thank you, sir.
Thank you, Kilam madam. Then our next presenter, Sonu Khandare madam. Sonu Khandare madam.
Yes, ma'am.
You can continue your presentation.
Okay, okay. My voice was audible, ma'am.
Yes, yes, your voice is audible. You can continue.
Myself, Miss Sonu Khandare. I am from Amravati. My problem statement is the effect of structured teaching program on knowledge regarding stroke rehabilitation among staff nurses serving in tertiary care hospitals of Maharashtra state. Next slide. Introduction. Developing countries like India are facing a double burden of the communicable and non-communicable disease like a stroke. Stroke is one of the leading cause of the death and disability in India. Stroke rehabilitation, it means, is the process by which patient is disabling strokes and undergoing treatment to help them return to normal life as much as possible by regaining and relearning the skills of everyday life. Aims of this stroke rehabilitation is to help the survival understanding and adapt the difficulties, prevent secondary complication, and educate the family members to play and support the role. Next slide. Next slide, please. Need for the study, a majority 70% population in India in rural, high risks of morbidity and mortality from the stroke because of lack of knowledge about the risk factor and access to preventive and curative care. And according to the Global Burden of Disease GBD study in 1990, stroke was the second leading cause of the death in world. Subsequent efforts to update the GBD study report nearly 5.87 million stroke deaths globally in 2010 as compared to 4.66 million in 1990. This indicates a 26% increase in global stroke death during the past 2 decades. With the rising population of morbidity, stroke still remain the second leading.
Sonu ma'am, can you go for objectives of your study?
Yes, sir. Yes, sir. Objective of my study, primary objective is to assess the effectiveness of structured teaching program on knowledge regarding stroke rehabilitation among the staff nurses serving in tertiary care hospital. And secondary objectives are, first, to assess the knowledge on stroke rehabilitation among the staff nurses in serving tertiary care hospital. Second objective, to find out the effectiveness of STP on knowledge regarding the stroke rehabilitation among staff nurses serving in tertiary care hospital. And third objective is to associate between the post-stage knowledge score on stroke rehabilitation with selected demographic variables. Next slide. Hypothesis of my study is, first one, there is a significant difference between the pre-test and post-test knowledge score on stroke rehabilitation among the staff nurses. And second hypothesis is, there is a significant difference between the post-test knowledge score on stroke rehabilitation with selected demographic variables. Next slide. Research methodology. Research approach was quantitative research approach was used. Then research design is pre-experimental research design, one group pre-test, post-test research design. And setting of the study is the tertiary care hospitals of Maharashtra state. Then population is staff nurse. Next slide. Next slide, please. Sample of the study is a staff nurse serving in tertiary care hospitals. Then next, data collection process. In that we have to, first step is pre-test, then we have to provide intervention, and then after post-test. In that pre-test, administer the 30 questions to the staff nurses, and after that we have provided intervention like a structured teaching program on the stroke rehabilitation. Then after the 7 days, give the same questionnaire to the staff and collect the questionnaire and calculate for the data analysis. Next slide. In discussion, in the present study, the overall knowledge of the staff nurse before intervention was 48.5%. It means pre-test knowledge of the staff nurses is 48.5%. And after administration of the structured teaching program, knowledge was increased in 79.4%. Hence, it is interpreted that the structured teaching program is influenced the knowledge of the staff nurses. With the student prepare, a t-test appeared in 5% level of significance. T value was found to be 17.37. Conclusion is that around 80 staff nurses were selected by convenient sampling technique. By the convenient sampling, we have I'm selecting the 80 staff nurses working in the tertiary care hospital for assessing their knowledge regarding the stroke rehabilitation. The SAQ was used before and after the teaching. The results show that significant difference between the T value. T value is 17.37. The study findings reveal that the instruction method like a structured teaching program was useful study among staff nurses. Therefore, the structured teaching program as an instructional method is on stroke rehabilitation among staff nurses serving in tertiary care hospital. Thus, it was concluded that structured teaching knowledge stroke rehabilitation effective among the staff nurses in selected tertiary care hospitals. Next slide. Nursing implication in nursing services is that nurses are the key person for the healthcare team who play a major role in providing the service to the stroke patient. Second one is nurse may play a key role in changing the attitude of staff nurses towards the treatment of disease for improved treatment success. And third one is the finding of the study can be incorporated in nursing service, especially in the stroke unit. Then second one is a nursing education related to first, the study emphasized significance of short-term in-service education program for nurses related to the stroke rehabilitation, and it's important to staff nurses. Second, as a specialist stroke nurse counselor, nurse can conduct individual counseling, group counseling, and organize self-help group, which will improve the quality of life among the stroke patient. And third one is a structured teaching program on stroke rehabilitation can be used among peer group teaching and teaching nursing student in small group allotted. Next slide.
And please explain briefly.
In nursing administration, first is the nursing administrator can mobilize the available resources personnel towards the education of the stroke patient regarding the stroke.
Your time is finished now. Please explain shortly.
Okay. And last point is the nurse administrator should plan and organize the continuing education program for the staff nurses. And in research, this the study will serve as a valuable reference material for the future investigator for a nurse consumers. And nurse can the findings for further research study as a role of research producer. The study will serve as a valuable references material for the future.
Please try to finish your presentation because your time is over now.
Okay, ma'am. 1 minute. The findings can be useful for publication and recommendation for the study is this study can be used for the large scale also, and similar study can be conducted in the caregiver and recommended to conduct the true experimental study also, and similar study can be conducted among the employees patient with the stroke, and we also take the control group, add one control group also, and same VATM video assisted teaching program also conducted. Next slide.
Ma'am, please try to finish your presentation because your time is already.
Okay. Next slide, please, ma'am. Next slide. Now conclude my research. Conclusion is that the STP regarding the stroke rehabilitation among the staff nurses was effective, and pre-test knowledge score was a 48.5%, and after the intervention provided, knowledge was gained. Thank you.
Good. So, ma'am, good. Whether it was your PG study or what? Have you done it in post-graduation study, or when was this study done?
Yes, sir. Yes, sir. PG study.
This was done. So, which year it was done?
2020. 20.
Okay. And the hospital was only one setting, or any more settings were used?
Multiple, 3 hospitals I have selected tertiary care in Amravati.
Can we see you, ma'am? It will be good. See.
Yes, sir.
Can on your video.
Yes, sir. Yes, sir. Sure.
Okay, so. Okay, good. Madam Sudha, ma'am.
Yes, sir. Yeah, Sonu, madam, why did you choose this topic in your PG?
Because sometimes stroke rehabilitation knowledge not having the staff nurses, some patient are came into the hospital, but as a nurse don't have a sufficient knowledge provided to the patient relative as well as the patient how to rehabilitate or cope with the stroke.
Okay. Which kind of contents you are added in your that STP, madam?
Which sorry, ma'am?
Which content, like any other educative and any kind of demonstration for prevention of that your this thing rehabilitation
For
stroke?
example, exercise, advise the patient how to do exercise after the paralysis or stroke.
Okay. Any other thing, madam?
No, ma'am.
Okay. How many hospitals you covered, madam?
Three hospitals.
3 hospitals. What is your sample sizes, madam?
80 sample, 80 staff nurses.
80 staff nurses in various hospitals.
Yes, ma'am. 3 hospitals.
Okay. Thank you.
Thank you, ma'am.
Thank you, madam. Our next presenter is Kaveri Patole, madam. Kaveri, madam, are you ready for presentation? Kaveri, madam, are you there? Kaveri, madam.
Yes, ma'am.
Yes, ma'am, you can start your presentation. Yes, you can start your presentation.
Yes, ma'am.
Okay.
Thank you, ma'am. Thank you. Good afternoon. Good afternoon, Sudha Singh, ma'am, Dr. Sudha Singh, ma'am, and Binu, sir. I'm so thankful for giving the wonderful opportunity to present the scientific presentation in the international conference. So thank you so much. So start with my presentation. Myself, Kaveri Patole, from Kalpana Institute of Medical Sciences. Hello. Hello.
Yeah, proceed, madam.
Can you hear, ma'am? Hello.
Yes, you are
I'm audible, ma'am.
Yeah, continue.
Yes, ma'am, you're audible.
Good afternoon, ma'am. Myself Kaveri Patole from Pravara Institute of Medical Sciences. I'm working as an assistant professor over here. So start with my paper presentation. So first, introductions. So breastfeeding is a choice. It's a responsibility. So breastfeeding is also known as a nursing, the feeding of the babies and newborn baby with the milk from the mother's breast. So lactation productions and the secretions of the breast milk by the mammary gland is called as a lactation. So breast milk is the most ideal and the valuable food for growing infant, and it will fulfill the nutritional requirement if it is given in an adequate and appropriate manner. So in developed country, the infant mortality rate was 6 to 10 times higher in non-breastfed infant in the first month of the life in 2015. In Millennium Development Goal, that is MDG targeted, aims to having the neonatal mortality and improving the newborn health along with the reductions of under 5 mortality rate by 2/3 between 1990 and 2015. This will be achieved by adopting optimal breastfeeding practices as recommended by WHO. For example, the breastfeeding to be initiated within half an hour of the birth and exclusive breastfeeding to be continued for the 6 months. Hence, continuous support with counseling is mandatory to mothers during the antenatal period as well as in postnatal period. So next slide, please, ma'am. So problem statement, a study to assess the lactation initiation practices among the intranatal mother admitted at labor room in PRH Loni and its effects on maternal and fetal outcome. So objectives of my study: assess the maternal and fetal outcome in lactation initiation practices. Second objective is to find out correlation between lactation initiation and its effects on maternal fetal outcome, and assess the lactation initiation practices on intranatal mother and find out the association between lactation initiation practices on selected socio-demographic and clinical variable with maternal and fetal outcome. Next slide, please, ma'am. So material and method, the study design, a descriptive cross-sectional observational research design was used in my study. Setting of the study, the site for the present study was Pravara Rural Hospital, Loni, in labor room. The samples intranatal mother who have fulfilled the inclusive criteria, and the sample size were used, that is 60 sample I have used in the labor room in Pravara Rural Hospital, Loni. The sampling technique, the simple random sampling technique was used for the present study, and the theoretical framework as well I have used in my study. Next slide, ma'am. So in inclusive criteria, the intranatal mothers who has admitted in labor room, the single pregnancy, those who have completed 37 weeks of gestation, mother and newborn available during the data collection period. Exclusive criteria: high risk postnatal mother, high risk newborn, mother having history of irregular antenatal visits. So validity, the content validity was done from the 10 experts, and reliability test retest method was used. The R value is 0.74, and the pilot study was conducted on the 10 intranatal mother. Next slide, please, ma'am. So descriptions of the tools and the technique. So there are 7, 8 sections I have divided. So in first section, assessment of socio-demographic characteristics of the mother. In second section, assessment of the newborn characteristics. In third section, assessment of essential newborn care. In fourth section, descriptions of maternal outcome. In fifth section, description of neonatal outcome. In seventh section, comparison of breastfeeding practices with latch score, and comparison of mean score with maternal characteristic with latch score. Next slide, please, ma'am. So data collection procedure. So permission from the concerned authority of the hospital have taken. Explanation regarding the study and its objective was given to the study participant. Obtained written consent was taken. Data was collected by interviewing the mother. Maternal characteristics of the intranatal mother was obtained with the help of patient's records and the files. And selected maternal factor was assessed by performing maternal antenatal factor, maternal intranatal factor, and maternal postnatal factor. Lastly, the evaluation of newborn characteristics was done by Apgar scoring, anthropometric measurement, and the latch score. Next, we'll come to the results finding in section. Next slide, please, ma'am. So descriptions of the result. In that description of the demographic data of the intranatal mother. So in that the criteria, the age in years. So as I have found the 60% women under the age of 19 to 22, and in educational status, in 10% women having primary educations, and their resident, in 55% they are residing in rural area.
Please continue.
Next is the description of maternal characteristics of the intranatal mother. I have assessed in parity of the mother. So in that 60% who were 145, means 80% women and weight of the those who are having the weight of 61 to 70 gram. Next is the neonatal physiological parameter. In that gender of the mother, so 81% who have male child. In weight of the baby, the 10% babies having the 1000 to 1500 gram of weight, and comorbid illnesses. There was 63% who were having in the data collection procedure. There will be no any comorbid illnesses found. Next is the major finding. So assessment of essential newborn care. In that breast crawl means immediately after the birth, within 30 minutes, and after the 30 to 60 minutes. So in that 41% they have given the breast crawl immediately after the birth, 56% within the 30 minutes, and 15% after 30 to 16 minutes. Next, the description of maternal outcome. In that full-term normal delivery, 50% women who have full-term normal delivery. In 33% intranatal mothers delivery who have having the forceps and vacuum delivery, and only the 60% those who are having the cesarean sections delivery. The major finding, descriptions of maternal outcome. In that progress of the mother in first stage means.
Please conclude your topic, because
60% 6 hours will be there, 10% 18 hours. In second stage means spontaneous, the 40% who have taken 2 minutes, in 50% 30 minutes, and the 10% 5 to 10 minutes. Next is the description of the maternal outcome. In that also first, next slide please, madam. Third stage, 50% mother having the 30 minutes, in 30% 10 to 15 minutes, and 20% 5 to 10 minutes. And next parameter is the weight of the placenta. So 80% who have having the more than 500 grams of the placental weight. Ma'am, next slide please. Comparison of the.
Can you proceed to the
next slide please, ma'am.
Kaveri madam, can you proceed to the conclusion, please?
Hello. Yes. Comparison of the breastfeeding practices with Apgar score.
So in major findings, score of the breastfeeding practices with selected maternal characteristics, that is latch. So comparison of mean score latch with regards to the age of 60 mother had score 6.78 per SD 1.17. It interprets that the moderate score of the latch and the high score of 8.55 standard deviation 0.78. The comparison of mean score latch with regards to parity of 60 mothers had score 6.40 to 0.85. It interprets that the moderate score of latch and in high score of latch 8.52 to 0.67. So comparison of mean score with latch with regards to NC visit of 60 mothers had score 8 standard deviation from 2.80. It interprets that the moderate score of the latch and in high score latch 8.33 standard deviation 0.80. So comparison of mean score latch with regards to weeks of pregnancy among the 60 mothers had score more than 40 weeks 0.28 standard deviation 1.69. It interprets that week of pregnancy does not have any influence. So finding related to comparison of mean score of breastfeeding practices with selected newborn characteristics. Comparison of mean scores of Apgar score with regards to the weight of the baby depicted that the among the 60 newborn had mean score to 0.30 have high influence of the Apgar score. So yes, ma'am.
Please conclude your topic.
Yes, ma'am. So some recommendations I have to tell you. So similar study can be conducted with larger population to validate the generalize the findings. A similar study can be conducted to assess the awareness, attitude and lactation practices, and the similar study can be conducted to assess the breast tenderness among the NC mothers, and a comparative study can be done to assess the vital acceptance of the NC mother on birthing process. So as I have concluded that the major conclusion drawn from my study that there is a positive correlation between the selected maternal factors and newborn characteristics. It emphasizes that the selected factors are thereby the future risks for complications, morbidity and mortality rate of the mother and newborn can be minimized with planned regular health checkup among with awareness regarding the MCH services or policies, and improvement in the baby friendly hospital initiative must be practiced by mother to improve and maintain the health status
your
of
presentation because already your time is over now.
Yes, ma'am. Thank you.
Good, Kaveri. Very good afternoon. Kaveri, who was your samples? Who were the samples of the study?
Yes.
Who were the samples
Yes,
of the study? Who were the samples of the study?
60 samples, sir.
Who?
Intranatal mothers, sir.
Okay, so whether there was any exclusion criteria or inclusion criteria you practiced? Can you tell about inclusion and exclusion criteria of the study?
Inclusion and exclusive criteria. Okay. So, in inclusion criteria, the 36 weeks of the gestation during the data collection procedure in labor room. And in exclusive criteria, the high-risk postnatal mothers and high-risk newborns and mother having the history of irregular
I think she's lost. I think she's having technical issues.
antenatal visits.
Okay, nothing.
Kaveri, in
Sir, in inclusive criteria.
Yes, Kaveri,
Yes,
you want
sir.
to add something? She's having technical issues, I think.
Yes, ma'am.
Kaveri, for this implementation of your practices of the lactation, what kind of implementation, like demonstration or any kind of pamphlet or questionnaire you had given to the natal mothers? How could you implement this thing, the mothers, for the mothers?
Madam, I have assessed the
question. I'm
latch
just
score process. Latching score I have assessed.
okay. You are just implementing the latch score, and the basis of that you are taking your post test, right?
Post test was not done.
Yes,
no?
ma'am.
It's
Yes,
only
ma'am.
descriptive study, no?
Yes, this is the descriptive study. I have never means post test and pre test. I don't assess.
Pre-test also not done. Assessment you did at least.
Yes, sir. Yes, sir. It's
Okay.
a yes, sir. Yes, sir.
Yes.
What do you do? Okay. Thank you, Kaveri.
Thank you.
Thank you, Kaveri madam. Then our next presenter is
Thank you
Deepika
so much,
Tank
sir.
madam.
Thank you, ma'am.
Thank you, madam. Our next presenter is Deepika Tank madam.
Yes, please. I'm just
Yes,
connecting.
you can stand. Yes, ma'am. You can start your presentation.
Is my screen visible?
Yes, Maima, you can continue, Maima.
Is my screen visible, sir?
Yes, Deepika, of course.
Slide. So sorry for the technical problem. Just give me 1 minute.
Yes, no problem.
Hello, good afternoon, respected judges and all the delegates who have participated in the webinar. Myself, Mrs. Deepika Nilesh Tang, lecturer, OBG department at Geetanjali College of Nursing, here to do a presentation. The problem statement is an exploratory study to assess the factors contributing to maternal childbirth satisfaction with delivery services among postnatal mothers at selected hospitals in Mohali, Punjab. Patient satisfaction is considered as one of the desired outcomes of...
Deepika, very sorry to disturb you.
Yes,
You can next slide also you can do, and you can make it full screen mode.
Sir, I have done it in full screen mode only, sir.
Okay, then we are not able to see it like that.
No, I have done it full screen only, sir. Is it now okay, sir? Hello? Hello?
Yes, it's okay. Down right side, there is a cup-shaped icon. You just click on that.
I have done it in full screen only, sir, but I don't know why it is not being shown.
No problem. You continue. No
problem. Okay. Sorry, sir, for the disturbance. Okay. Patients, again, I'll read the problem statement. The problem statement is an exploratory study to assess the factors contributing to maternal childbirth satisfaction with delivery services among postnatal mothers at hospitals in Mohali, Punjab. Patient satisfaction is considered as one of the desired outcomes of the healthcare and is directly related with utilization of health services. Satisfaction with childbirth is considered as important qualitative outcome in assessing the experience. As childbirth is one of the most important events and it is highly individualized. The mother's childbirth perception is always influenced by the knowledge and expectations. Hence, the childbirth experience should be always a joyous occasion in a mother's life, and we should make her feel valued, respected, and appreciated to bring a new life into this world. Aim of the study was to identify the factors contributing to maternal childbirth satisfaction. The objectives to assess maternal childbirth satisfaction with delivery services, to assess the factors which are contributing to maternal childbirth satisfaction, to determine the association between the findings and selected socio-demographic variables, and to conduct an instructional program for the staff nurses based on the findings. Assumption: women may not be fully satisfied with the intrapartum care they receive at healthcare centers. There may be certain factors that contribute to maternal childbirth satisfaction with delivery services.
Sorry, whether in my screen only I am having this fault or all other participants are also having this same problem?
Sir, that slide is not appear on the screen, sir. Yeah.
Yes, no? I thought only I am having that issue.
Okay, sir, I'm trying one more time.
You just put nest, enter, put.
Sir, I'm
You're
trying.
Talking from some other person's ID?
Yes, sir, because I had a last moment glitch with my laptop and I could not connect with that. That's why, sir. Now is it visible, sir?
Yes, it is.
Yes, now very good. Good, continue.
Okay. Methodology. The study was a quantitative approach with a non-experimental exploratory design. The sampling technique was non-probability purposive sampling and the size was 180 postnatal mothers. The tool used for data collection was a 7-point positive presence index rating scale and the reliability was a 0.91 to assess the maternal childbirth satisfaction. And the second tool used was a 5-point rating scale to assess the factors which contribute to maternal childbirth satisfaction and the reliability was 0.90. The technique I used was interviewing method and I had taken almost 15 to 20 minutes to interview a postnatal mother. The results of my study were 35.6% mothers were of age group of 22 to 25, 38.3% mothers had no formal education, 46.1% postnatal mothers had an income of less than 10,000 rupees, then 62.8% postnatal mothers were multipara, 81.1% mothers had natural onset of the present labor, 53.9% mothers were in approximately length of labor of 6 to 12 hours. 62.8% postnatal mothers had delivered a male baby child. Now, the next aspect of the study was the level of maternal childbirth satisfaction. 65.6% postnatal mothers had a neutral satisfaction level and only 34.4% mothers were satisfied with the delivery services given to them. The third aspect were the factors. The factors identified were admission process, environment, supply and human resource, skill of the healthcare provider, attitude of the healthcare provider, communication, support, consent and autonomy, privacy and post-delivery care, of which the most satisfying factor was competency and skill of the healthcare provider, which was 87.2%, and the most dissatisfying factor that was identified was communication, that is 0% mothers, where nobody was satisfied with the communication level of the healthcare provider. Then the fourth aspect was to find the association. So the parity of the postnatal mother and the onset of present labor had a significant association with the satisfaction level. Now the implication of the implication on nursing practice, we should sensitize the staff nurses, all the healthcare providers on the importance of patient satisfaction level to better the services and the quality of care we give to them. In nursing education, we should definitely inculcate the importance of patient satisfaction in our nursing curriculum. In nursing administration, all the healthcare officials should take into consideration patient satisfaction as an important aspect while developing their protocols and policies. And in nursing research, more and more studies should be done to give an evidence-based practice on patient satisfaction level. In my study, to make it more fruitful, I had conducted an instructional program for the staff nurses at 6-phase Civil Hospital, Mohali, and I have educated them on the importance of patient satisfaction and what are the factors that contribute to patient satisfaction. I had also distributed an informational booklet which I had made, in which all the 10 factors which I have identified, I have mentioned in that which all factors are important in giving patient satisfaction level. I don't know what happened.
Mahima, is it over?
No, sorry, sir, just.
Okay. Yes.
Recommendations. The study can be replicated on a larger sample to generalize the finding. The study can be conducted to explore more factors that contribute to maternal childbirth satisfactions. The study can be conducted to compare the level of maternal childbirth satisfaction with delivery services at public and private hospitals. The study can be conducted to compare the level of maternal childbirth satisfaction among primary para and multi-para mothers. Conclusion of the study concludes that only 34.4% postnatal mothers were satisfied with the delivery services. The most satisfying factor that was identified was competence and skill of the healthcare provider, that is 87.2%, and the most dissatisfying factor was communication. Hence, the study itself speaks volumes, that is, we have the skill, competency and quality to provide, but our communication level with our patients or at the healthcare setting is very poor. So so I am definitely want to emphasize the fact that we need to improve our communication skills for better and quality healthcare services. Thank you. Thank you all of you for your patient listening.
Thank you very much. Actually, may I know you? Acha, Deepika, yes, you have shown that slide. Okay, Deepika, your name. Sorry to calling you Mahima because that name was coming.
No, sir. I'm really sorry. From my part
no
also,
problem.
I had some technical issues.
No problem, Deepika, very good. I appreciate your part that after finishing your study, you did an instructional training to the staff nurses, and you just concluded that really the communication gap is the major of the issues.
Thank you so
much. It
happens.
So this really, you have pointed out a very good part of that.
Yes, sir. Yes, sir. Our staff nurses definitely have the skills and competency, and the patients who are availing the healthcare services are definitely satisfied with there. But somewhere there is a communication gap between the healthcare provider and the recipient from what I have identified from the study.
Okay. Now, very good. What was the factors? What was the tool used? Can you something tell about the tool of
yes, sir. Sir, I have used 2 rating scales. One was a 7-point rating scale, in which there were almost 40 statements 30 statements, of which 22 were positive and 8 were negative statements. Then for identifying the factors, I have taken a 5-point rating scale in which there were 10 points like admission process. So in admission process, again, I had sub points like what was the time
for a rating scale. You want to come
yes,
to both
yes,
the
sir.
rating.
Yes, sir. Both
Whether
were the rating
standardized or what was the thing?
No, sir. It was not standardized. I have self-structured tool I have used. I have modified it with the help of a theory that was Donobian framework model, in which they assess the patient satisfaction level in 3 categories, that is structure, process, and outcome. So in the structure, I have taken the hospital environment, the cleanliness, the infrastructure, the HR. In the process, I have taken the intrapartum care, and in the outcome, I have taken.
You have done this study in which hospital and what you were doing there that time?
Sir, I was a PG student back then in 2018. I have done my study from Mohali. So I have conducted the study setting was at 6-phase Civil Hospital in Mohali.
You have done in a civil hospital, and
yes,
your
sir,
college did not have hospital?
No, sir. Our college did not have a hospital. So we were posted in civil hospitals in Mohali.
So parent hospital, you don't want to do study?
It's a parent hospital only. 6-phase Mohali, the civil hospital was their parent hospital only, sir.
Ajay, you were in a government college or you were in private?
No, sir, I was in a private college, but they did not had a tie-up with any private hospital. So we were posted in civil hospitals only, sir.
Okay, good. And which year it was done?
Sir, I have done the study in 2018, sir.
Okay. So can you have you presenting today? So why you did not thought to present it? The gaps in 2018. Why you took a gap of 4 years, a long gap?
So 4 years.
And presenting a long gap.
Sir, I just completed my PG and then I got married, then I conceived, and after that COVID had happened. So I did not get an opportunity to present it anywhere, sir. So
whether that data of 2018 and how year now in 2022.
So definitely now I really want to replicate this study in more and in a larger sample also. So I'm also planning, currently I'm working in Udaipur. So I'm planning to do a study or a comparative study among private and public hospital like that. I'm planning to do a study on that.
Good, Deepika. Good. Okay, good. Thank you to Maima also. She helped you.
Yes, sir, definitely.
Deepika, madam, how
Yes,
many
sir.
samples you had taken for the study?
Ma'am, I had taken 180 postnatal mothers, ma'am, who had normal maternal and childbirth outcome, ma'am, who did not have any complications.
Okay, how much time you had given for one sample for sampling?
Ma'am, for one mother, at least 15 to 20 minutes. I had made the rating scale in Hindi also, and I've did an interview method for illiterate mothers. I used to give them a number. I used to tell them to rate from a scale of 1 to 7. You can give in numbers also. Like that, I have collected the sample. I've read the statement and they have told me the number, what number they want to give, like that.
Did they cooperate with you at that, because that time is very difficult time for the mothers, madam?
No, ma'am. I have taken this data during the postnatal period about their intrapartum. Yes, sir.
Data was in postnatal period, no?
Yes, sir. Data was in postnatal period. That too within 2 days, sir. Immediate. Most of the samples I've taken were within 24 hours, and some of them were within 2 days.
Okay, very good.
Thank you so much, sir. Thank you so much, ma'am. And thank you all the delegates for your patient listening. Thank you.
Thank you, Deepika madam, for this presentation. Then our next presenter is Deji Sharma madam.
Yes, ma'am.
Yes, ma'am, you can start your presentation.
So myself, Daisy Sharma, Assistant Professor from the Department of Obstetric and Gynecological Nursing, Vibrant Nursing College. My problem statement is effectiveness of preconception counseling and explore the concept regarding preconceptual counseling among eligible couple in the selected areas of Vadodara, a mixed method approach. An introduction. Preconception counseling is a process in which the couple consult about the pregnancy, its course and outcome well before the time of actual conception. That is known as preconception counseling. Objective of my study was to assess and compare the pre-test and post-test level of knowledge regarding preconception care among eligible couple. Then to evaluate the effectiveness of preconception counseling and to associate the selected demographic variable with the mean difference of the pre-test level of the knowledge score regarding the preconception counseling among eligible couple, and to explore the concept regarding preconception counseling among eligible couple. Next, please. And the research methodology in my study was research approach. A convergent parallel approach was used in my study, and the research design, pre-test, post-test research design was used. And the setting of the study was selected areas of Vadodara like Bapod, Baili, and the Bill areas of Vadodara. And the target population was my study is the eligible couple in the selected areas of Vadodara. Then sample of the study, eligible couple who satisfy the inclusion criteria were the sample for the study by using the purposive sampling technique. And the sample size, that is 30 eligible couple, that is done through the power analysis in the RAWSoft software. And the sampling technique is purposive sampling technique. And the result of my study was the result from the quantitative study with the regard to pre-test assessment. The 76.66 eligible couple was having poor level of knowledge, and 23.34 having average knowledge, while the post-test 56.34 eligible couple having the average knowledge and 46.66 having the good knowledge. Nobody was found poor knowledge after in the post-test. The obtained pre-test mean score was 8.24. After providing the preconception counseling, it increases up to 20.13. And the mean difference between the pre-test and post-test is 11.85. And the pre-test standard deviation was 2.581. And the post-test standard deviation is 1.953. The obtained Z value was minus 6.693. And the p-value is less than 0.001. So when the test rate 5% of level of significance. Therefore, we can conclude that the difference in the pre-test and post-test knowledge is highly satisfied. So the preconception counseling was effective. So that the hypothesis 1, there will be a significant difference between the pre-test and post-test knowledge regarding the preconception counseling among eligible couple is selected area of Vadodara was accepted. Next slide, please. And for the pre-test knowledge score with the socio-demographic variable not associated. Hence, the hypothesis 2 is failure to accept. For the qualitative study, the study relevant that the out of 10 questions, the 2 questions were not clearly answered. The rest of the 8 questions, majority participant has respond positively. Then after that, gave the individual counseling to couple to clear their doubt, improve the concept regarding preconception care. And conclusion of my studies, from the above finding, it was considered that the eligible couple had average knowledge regarding preconception counseling. The midwives have a vital role to work with the eligible couple to build their knowledge, understanding, and the decision making in relation toward the preconception care. Keywords of my studies to effectiveness, knowledge, explore the concept, preconception counseling, and the eligible couple. And the recommendation of my study is the same study may be concluded in the large population, and the investigation can be used the comparative study between the rural and urban area. And this similar type of the study can be concluded at the by using various research method. Thank you.
Thank you. Thank you, Deji Sharma. Am I correct?
Yeah, yes, sir.
Thank you, Deji. Okay. Can you tell what was the, what was the methodology used? Design of the research study?
Approach of my study is convergent parallel design, sir. In that, the both data like qualitative and quantitative, they are assessed in the same phases of research process.
What is the difference between convergent research and mixed method research?
Convergent method, in that the mixed method means qualitative and quantitative. But in that, there are types like comparative and the convergent parallel. So I had chosen the convergent parallel. In that, I had analyzed both data in same way.
Good, very good. Because many of the participants, they may not know. It's sometimes a new word, now you use in mixed method, a type of that convergent. Very good. Okay. So first, initially, which study you have done? Qualitative or which was that?
First, I had taken a pre-test. After that, I had assessed the explored the concept regarding preconception counseling. For that, I had taken an interview of eligible couple.
Okay, interview you have done one by one participants, or it was how? Interview?
No, sir. It has done by individualized.
Individualized.
Yes.
So what was the period of data collection?
Period of data collection. I had taken the data from 13 November to the 5 December.
13 November to
5 December.
This much fast. 5 days data collection is over.
Yes, sir.
Interview method and a mixed method type of research, 5 days you are telling data collection was enough. Okay. And what, any ethical issues, anything you want to share in your research study?
Sir, there is a problem to get permission from Jilla Panchayat because that time there is a COVID situation. So that is the problem that is occurred that time.
Okay, good. And it's your PG study or you have done from your interest?
No, sir, it is my PG study.
Okay, thank you.
Thank you, sir.
Daisy, how much time you are taking for one sample?
So, ma'am, 30 minutes for each sample.
What kind of questions you would ask in your tools?
So, ma'am, in the interview question, for the quantitative data, I had selected a topics, criterias. In that the like underweight, overweight, what's the effect of folic acid, what is the importance of folic acid in pregnancy, then alcohol, then medication, then about exercise. That type of data I had included in my questionnaire.
Okay. Nice topic you had taken because in the current scenario, we can say that kind of problems having most of the couples.
Yeah, thank you, ma'am.
Thank you, Daisy madam, for this presentation. Now, our next presenter is Shabnam Sheikh madam. Madam, you can start your presentation. Shabnam madam, are you there?
Next is ready. Any next?
Shabnam madam, are you ready for the presentation? Shabnam madam, your PPT is shared from our side. You start your presentation.
Yes, ma'am. Hello.
Yes, Shabnam ma'am, you can start.
Hello?
Just make full screen and start it.
Good afternoon, respected sir. Good afternoon, respected ma'am, and one and all present here. My name is Ms. Shabnam Sheikh, nursing tutor from Apprenticeship. My problem statement is to assess the effectiveness of positive parenting teaching on development of self-esteem among primary caregivers of pre-adolescents. So next is the objective is, first objective is to assess the existing self-esteem among primary caregivers of pre-adolescents on development of self-esteem in experimental group and control group. Second objective is to evaluate the effectiveness of positive parenting teaching on development of self-esteem among primary caregivers of pre-adolescents in experimental group before and after intervention. Third objective is to correlate the effectiveness of positive parenting teaching on development of self-esteem among primary caregivers of pre-adolescent between experimental and control group. Fourth objective is to associate post-test score of positive parenting teaching and development of self-esteem among primary caregivers of pre-adolescents in experimental group and control group. Fifth objective is to associate post-test score of positive parenting teaching on development of self-esteem among primary caregivers of pre-adolescents with their selected demographic variables in experimental and control group. Next is the assumption. In assumption, primary caregivers may be giving some kind of positive parenting towards their pre-adolescents. The second assumption is primary caregivers may be interested to learn further about some kind of positive parenting, thus enhancing the self-esteem toward their pre-adolescents. Third assumption is primary caregivers may have some knowledge about positive parenting and self-esteem. Next, in my study, I taken 33 review of literature related self-esteem and the positive parenting teaching. In research methodology, in research approach and experimental study approach and research insight, there is the experimental research design. In sampling technique, non-probability convenient sampling technique are used, and sample is primary caregivers of pre-adolescents. Sample size, total size of the sample is 100, in which the 50 is the primary caregivers of pre-adolescents in experimental group and 50 primary caregivers of pre-adolescents in control group. Setting of the study, rural and setting of the study is rural and urban area of Wardha. Then there is two sections in for data collection. Section 1 it comprises of the demographic variables of the primary caregivers who participate in the study. That is the age, gender, marital status.
Shabnam, sorry Shabnam, actually it's a very low quality. I am only feeling, or
Voice is not audible, sir. Hello? Hello, ma'am?
yes, now it is audible. You start with section 2 for data collection. Yes, go.
Yes, ma'am. Yes, sir. Section 2 comprises the modified self-esteem scale regarding assessing the self-esteem among primary caregivers of pre-adolescents. Then criteria for sample selection is there is the inclusion criteria. Those who are primary caregivers of pre-adolescents who can write and read Marathi as well as who can understand Marathi. In exclusion criteria, those who are previously exposed to the positive parenting teaching. Then in my result, hello. Hello? Hello, sir? Can you audible?
Madam, voice is not properly audible, madam.
Hello, madam. Now audible? Hello?
There is so much echo, madam.
Hello?
Yeah, now it is audible, madam.
Ma'am, then result self-esteem score in experimental group before teaching there is 40.02% and after teaching 73.94% after teaching. In control group before teaching 32.04% and after teaching 33.18%. Association was found with demographic variables, that is age, gender and locality in experimental group and gender and locality control group. Result shows statistically significant difference was found in self-esteem scores in experimental group of primary caregivers of pre-adolescents. Experimental group. P-value is 14.64 and P-value is 0.00 system development score among primary recommendations, a study should be conducted to determine how the positive parenting teaching affects on developing of self-esteem among children, and similar study can be done to assess the knowledge regarding the effect of positive parenting in adults' aggressiveness. Next, I conclude my topic.
Madam, your voice is not audible, madam.
Hello. Hello, ma'am. Now it is audible.
Yes, madam. Now it is audible.
Okay, ma'am. In my conclusion, H1 is accepted. It is interpreted that experimental group developed high self-esteem, had more knowledge about positive parenting than control group, and statistically, it is significant difference was found in experimental group. In my study, I added 84 references, and I add here only 3 positive discipline, Wikipedia, parent, and self-esteem, stages, definition. Thank you, ma'am. Thank you, sir.
Thank you, Shabnam, ma'am. It was very difficult to hear because of technical glitches. Anyway, no problem. I was going through your content which was shared to us. So I have only a few queries only. What is positive parenting? What was positive parenting?
Sir, positive parenting, it develops a fully solid committed relationship between the parents and the child.
How it was taught? How you have taught it?
Sir, primary caregivers. They can, if positive parenting teaching given to the parents, primary caregivers, then they can understand the emotions of their.
So how you have given that teaching? How you have given that teaching?
Sir, I use the model for the positive parenting teaching in their Marathi language. They can understand and they can read.
Okay, so you gave teaching.
Yes,
right? You want to say that you gave teaching, whether any PPT, flashcards or anything was prepared? What was?
Sir, I prepared module and I distribute that module in that area in Nalwadi and Ramnagar also.
So did you distributed module or you taught? Again, it's contradicting.
Sir, I distributed that module and also given the information about that module. Whatever content I added that module, I given the information also.
Okay, Shabnam, thank you.
Thank you, sir. Thank you, ma'am.
Thank you, madam. Then our next presenter is Poonam Alwat, madam. Are you there, ma'am?
Yes, ma'am. Yes, ma'am.
Ma'am, you can start your presentation.
Ma'am, can you please share my PPTs?
Yes, yes, ma'am.
A very good afternoon to the mentors, judges, and the organizers for giving me an opportunity to share my presentation in such an esteemed conference. So the presentation is, some PPTs are not visible.
You can continue, madam. No, madam, continue.
Sir, actually, I'm not able to see my PPTs on this.
Okay, it's visible.
Yes. Sir, the statement, ma'am, can you please make the previous slide visible? Yes, ma'am. So sorry for the glitch. As the problem statement of my presentation is a study to assess the level of knowledge among elderly people regarding the early signs of heart attack and its emergency management in Budeda village, Gurugram, Haryana. So the introduction for the study was As we all know, heart attack and stroke are the leading cause of death globally. By 2030, almost 23.6 million people.
Poonam,
Yes,
I'm very sorry. Can you go for this direct objective slide? So it will be good.
yes, sir.
We can
Yes, sir. Yes, sir. So the objective of study were to assess the level of knowledge among elderly people regarding early signs of heart attack and its emergency management. And the second objective was to find the association of level of knowledge with selected demographic variables. Next one. The methodology used for the present study was it was quantitative approach by using descriptive design. The setting of the study was Budeda village in Gurugram itself. I have selected 200 elderly people who were residing in Budeda village through convenient sampling technique. So the inclusion criteria, the person who were willing to participate and who were available at the time of data collection. Next, ma'am. The tools were, it was divided into two parts. First one is a demographic variable. It includes the age, gender, family income, education, qualification, religion, number of family members in the family, type of family, dietary pattern in the family, previous history of any illness, previous history of heart attack, and any previous knowledge related to the heart attack. The second questionnaire was related to the structured questionnaire that was to assess the knowledge related to this. Next one. So the content and validity of the tool was done by taking suggestion from the experts related to this area. Next one. So procedure was after taking administrative permission from the authorities and after taking consent from the informant from the participants, it was being conducted. Next one. The result of the study was divided into three subsections. First section includes the frequency and percentage distribution of the selected demographic variables. Second includes assessment of knowledge score regarding the previous prevention of heart attack. And the third one is the association between the knowledge score with the selected demographic variables. So the result showed that out of 200 elderly people, 110 study subjects belongs to 60 to 69 year of age group, and 102 study subjects were male. 183 students, the participants belongs to Hindu religion, and 121 elderly people lived in joint families. 41 elderly people were having history of hypertension, and the second and 61 study subjects had a previous history of heart attack. 70 elderly people were having a previous history of illness. Next one. So this is the second table which shows the knowledge, which shows the, ma'am, last slide, please. Ma'am, last slide, please. Ma'am, can we go to the previous slide, please? Yes. Ma'am, next one. Yes. So this is a pie chart showing the knowledge related to the early signs of heart attack. So out of this, out of 200 people, 66 elderly people were having a good knowledge, and 98 people were having average knowledge, and 36 people were having poor knowledge related to the signs of heart attack and its emergency management. Next, ma'am. So talking about the association, all the important demographic variables were found to be associated with the selected demographic variable except the gender one. Ma'am, next. So this is that the chi-square table which shows the most significant, which I felt is the previous history of illness, previous history of heart attack, and any previous knowledge related to heart attack. These all three were found to be associated with the socio-demographic variables. Ma'am, next. So it was being concluded that from this particular study, I tried to make the people to have an education related to the early signs of heart attack and its emergency management till the medical assistance arrives for the person. So the key words we used in this particular study was elderly people, heart attack, knowledge, and structured questionnaire, which I used at the time of data collection. Thank you so much, sir. Thank you, ma'am.
Thank you. Thank you.
Thank you.
Thank you. Ma'am, you want to ask? I have no questions. Good.
Okay,
no,
sir.
madam.
Thank you, sir. Thank you, ma'am.
Okay.
Thank you, madam. Now our next presenter is Krinal Patel, madam. Krinal, madam, you can start your presentation. Madam, are you ready for presentation? Yes, Krinal, madam, you can start your presentation, ma'am.
Hello.
Yes, ma'am, you can start your presentation.
Okay, ma'am. Okay. Today my problem statement is a study to assess the effectiveness of structured teaching program on the knowledge of women regarding breast self-examination in the selected rural area of the Surat. And in introduction, the women's reproductive and sexual health has a distinct difference compared to the men's health due to the unique biological, social, and behavioral condition. Women are the most vulnerable population in the world, suffering the most frequent.
Proceed to the objectives. Please proceed to the objectives.
Okay, ma'am. Okay. The first objective is to assess the knowledge of women regarding breast self-examination among before and after the structured teaching program. Then to assess the effectiveness of structured teaching program on knowledge regarding the breast self-examination among the women. Then next, in methodology, the research approach is the quantitative research approach. Research design is the pre-experimental design. The research method is the one group pre-test post-test method. In the variables, the independent variables are the structured teaching program on the knowledge regarding breast self-examination. The dependent variable is the knowledge regarding breast self-examination. And the setting of the study is the selected rural area of the Sachin, Surat district, Gujarat. The sample, the selected women of age group that is 15 to 49 years who fulfill the inclusion criteria. And then sample size is 30 women aged between 15 to 49 years who fulfill the inclusion criteria. And the sampling technique is non-probability convenience sampling technique. And the result, the knowledge mean score of the pre-test was 11.36% and the standard deviation was 5.05%, and the post-test mean knowledge score was 18% and the standard deviation was 3.38%. Thus, the structured teaching program was effective in improving the knowledge statistically at 0.05 level significance. Next slide. In conclusion, overall, the pre-test knowledge score was less, which suggests that the need for the structured teaching program for the women regarding breast self-examination. The post-test results show that there was a significant improvement in the level of knowledge. Hence, it was concluded that the structured teaching program was an effective method for teaching the women regarding breast self-examination. Next slide, please. In the keywords, the knowledge, effectiveness, women, breast self-examination, structured teaching program, and selected rural area. Okay, thank you, ma'am. Thank you, sir.
Krinal, madam, thank you. I want to ask, what was the age group of women in the present study?
Yes, sir. 15 to 49 years. That is the reproductive age group.
15 to
49.
49 years age group.
Yes.
Means in the reproductive age group you have used, what was the inclusion and exclusion criteria then?
In that I have include the age group that is 15 to 49 years.
Any inclusion and exclusion criteria was followed in this?
Who are available at the time of data collection, that sample I have selected.
Okay. So 15 years also samples you have got, age group. What was the samples you have, women have got in your study? Which age group was highest?
15 to 49 years.
You have not further classified in that? In
No, sir.
demographic?
In demographic data, I have classified in the 4 groups.
Okay. In that, which group was the highest?
In that, the adult age group was highest.
You have done this study or you have taken help of someone?
Yes, sir. This is the UG study and this is the group study.
Okay, it's a group study. That's why I think you are having some difficulties to get exactly the data. Fine, you are not able to tell.
Yes, sir.
Okay, so in you are now UG or you are now PG you are doing?
Now I am PG, sir.
Okay. So whether permission was taken from the group of researchers before presenting?
Yes, sir.
So you have taken permission from all your classmates that I am going to present here this study?
Yes, sir. I have taken the permission.
From all your friends? Now you remember all your friends who have done?
Yes, sir.
Okay, Krinal.
Yes,
Thank
sir.
you. Sudha ma'am, if you have any questions?
No, sir.
Okay then. Thank you then.
Thank you, sir. Thank you, ma'am.
Thank you, Prinal madam. Now we move to our last presentation of this session. Then our last presenter is Liji Jiju madam. Madam, you can start your presentation. Liji madam, are you there?
Yes, ma'am. I'm here. I'm just sharing my screen.
Yes, ma'am. You can start your presentation. Yes, ma'am. You start your presentation.
Ma'am, the screen is visible, ma'am.
Yes, your screen is visible, madam.
Okay. Good evening, everyone. Good evening, all respective dignitaries and judges present here. Well-being is a concept. Well-being is a concept that encompasses a well-rounded, balanced, and comprehensive experience of life. Psychological well-being refers to how people evaluate their lives. According to Diner 1997, these evaluations may be in the form of cognitions or in the form of affect. The statement is a study to assess psychological well-being among staff nurses from selected hospitals. Objectives were to assess the level of psychological well-being among staff nurses. Second, to associate psychological well-being with demographic variables. The methodology includes as follows: research approach, quantitative research. Research design was descriptive research design. Research setting were selected hospitals from Pune. Sampling technique was non-probability purposive sampling technique. Sample size were 210. Inclusion criteria utilized was all staff nurses who have 1 year of working experience, staff nurses who understand English and Marathi. Exclusion criteria were staff nurses with any form of disabilities. The tools used for data collection were as follows. The demographic data, it was developed to collect the baseline information, which consists of age, religion, gender, education, type of family, marital status, years of experience, department, and designation. Psychological well-being, that was a section 2, which was assessed by a standardized tool. Psychological General Well-being Index by Olivier Chesney. It was developed by the evaluation of perceived well-being and distress. It includes 6 dimensions: anxiety, depressed mood, positive well-being, self-control, general health. And it is a reliable and valid tool to measure positive well-being, positive mental health. It is simple to use and the reliability is 0.87. I have found the results as this. The maximum participants, they fall in the category of 21 to 30 age group and they were females. Maximum participants were unmarried.
Maximum participants were BSc Nursing and were of Hindu religion. Maximum participants were of nuclear family and also from urban area. Maximum participants, which were my samples, were from private hospitals. They were working for 0 to 5 years and they were maximum area of department of work was ICU, OT and CCU. Maximum participants utilized personal transportation as their media of transportation from home to office area, work area. The second section, which includes the assessment of level of psychological well-being, it was divided into 3 areas, that is poor, average and good psychological well-being. Only 4 were having poor psychological well-being and 55.7% were having average psychological well-being. 42.3% were having good psychological well-being. When the subtools were measured, it was found that anxiety was into the highest mean. Later that vitality was found to be highest, and then positive well-being. Consequently, depression and self-control were found in all the nurses, and at last general health was the source of psychological well-being among all the nurses. Association of psychological well-being with demographic variables were done. It was found that among all the 11 demographic variables, only age and area of work showed a significant association. Findings of the study mentioned that nurses have average level of psychological well-being. Stress and burnout are the concepts that have sustained the interest of nurses and researchers for several decades. These concepts are highly relevant to the workforce in general and nursing in particular. That was all about my study. Thank you.
Thank you. What's your name, madam?
My name is Mrs. Liji Jiju.
Thank you, Liji. Thank you. Good, very good. What was your statement? I mean, what was the tool used? Can you again tell me the statement of your study?
The statement of my study was a study to assess the psychological well-being among nurses from selected hospitals.
Okay. So when was this study done?
So it was actually, this is my PhD study. So study was started in the year of 2016, but data collection was done in the year of 2020.
Data collection was done in 2020.
Yes, sir.
Okay. And what was the tool used?
So psychological general well-being index.
Is it a standardized?
It is a standardized tool.
Have you taken permission?
Yes, sir.
Then why was the reliability of the tool assessed? You have mentioned somewhere reliability in the presentation. That's why I got
confused. Yes, sir. 0.87. That was what it was mentioned. 87. 0.87.
You did the reliability.
No, sir. No, sir.
It was mentioned in that tool.
Yes, sir.
Okay. And what are the areas or domains in that psychological well-being assessed?
Sir, anxiety, depression, positive mental health, vitality, depressed mood.
Okay. And which mode, which domain was you have found out? You have done item-wise analysis also?
Yes, sir.
Not mentioned here, right? As it a PhD study, that's why I'm going a little more depth.
Sir, anxiety was among all the staff nurses, in the tools, anxiety was into the highest thing, which was decreasing their psychological well-being. And then later it was positive well-being and vitality.
Item-wise analysis was done of the questionnaire?
Yes, sir. Item-wise analysis was not done, sir, because a standardized tool it was used. So after understanding the patient's response, the tools were again subdivided into all these areas.
No, you had the tools. In that tools, there were so many domains. So that domains, each domain, you should have done the item-wise analysis. You had got a ready-made tool. And the domains were very clear. So why the item-wise not done?
Yes, because the tool has already that item analysis previously done.
So I didn't do that again.
Okay. And where you have completed, is this studies over and you have means?
No, sir, this is just a part of my PhD study. So one variable, I am just presenting it here in this.
Is it a pilot study of that?
No, sir, it is just a one variable, second objective of the PhD study.
Second objective
Yes.
PhD study. Okay, Vijay. And who was the samples?
The staff nurses who were working in any private and government hospitals from Pune.
And how many hospitals was selected?
Sir, 4 hospitals were selected for the main study.
Any criteria was followed in the selection of hospitals?
Sir, it was convenient sampling technique I have used because areas was very wide in Pune, and whichever hospitals was convenient to me and also accessible to me, and I was getting easily permission, I selected those hospitals. So it was including like 2 government hospitals and private hospitals also, 2 private hospitals.
So all the staff nurses were taken, or whether any exclusion, any was there?
It was again a purposive sampling technique. So the staff nurses who were fulfilling the criteria, like minimum 1 year of job experience they should have, and that also in that particular area wherever they are working. So, and also whoever is giving the consent, they were being selected for my study.
What is it? You have mentioned convenient and now you are contradicting with purposive. What was the sampling technique?
Non-probability purposive sampling technique to select the samples, sir.
You have mentioned convenient, no?
No, sir. Purposive. Purposive, I have mentioned.
Okay, purposive you have mentioned. Okay. Okay, Sudhaman.
Lija madam, how many samples you had choose for the research work?
Ma'am, I have utilized 210 samples.
210. How much time you are taking for one sample?
It was a self-report questionnaire, ma'am. So they took almost 20 minutes to complete their questionnaire, ma'am. The staff nurses.
Okay. And part of the demographic data, how much your demographic? What are the things you are including in your demographic data?
Ma'am, in the demographic data, age, gender, marital status, education, religion, type of family, place of residence, type of hospital administration, working experience, and mode of transportation were included.
Okay, in part of that, the tools, how many questions you had prepared for the nurses?
Ma'am, 22 questions were there for assessing the psychological well-being. Only 22 for psychological well-being only.
Okay, for the psychological well-being.
Yes, ma'am.
Okay. How much time you had taken for the total overall this research work study?
Ma'am, it took almost like 1.5 months for me because I have to go to the hospitals and get those samples also because they're staff nurses and they were having their shift duties. So likewise, I have to adjust my data collection plan also. So it didn't happen into 10 or 15 days. It took me 1.5 months.
Because in the hospital area, we see that there is a rotation of the duty over there.
Yes,
and did they match to your time? Because majority of the nurses having their night duty, day duty, and all the shifts.
Yes. Yes,
ma'am.
ma'am.
Same samples?
Yes, ma'am.
Did you get all the same samples in the posters also?
Yes, ma'am, because I have taken their contacts and I have like my main study is like an intervention study where I was putting one emotional intelligence enhancement intervention package. So I had convinced them that if I find some psychological distress or there is some occupational stress, I'll be helping you to give some intervention also. So in that way, they were convinced and they gave their consent for the study. And also their numbers were shared with me.
For the implementation of your knowledge and all the things, what kind of things you had prepared?
Ma'am, I have prepared a emotional intelligence enhancement intervention package where the emotional intelligence techniques were utilized by the nurses and then their emotional psychological distress, whatever they are having, the effect on that was assessed, and also occupational stress were assessed.
Okay, very good. Thank you.
Thank you.
Thank you, Lizzie madam, for this presentation.
Thank you, ma'am. Thank you.
Thank you. So now we are concluding with our scientific presentation of today's session. So thank you
Binu sir, thank you Sudha madam for being with us since continue for the 3 hours. Thank you sir, thank you ma'am, and also the all presenter who are continue with us, and thank you the all participants since morning you are with us, so thank you. And tomorrow morning again we are going to start our tomorrow session sharp at 9 a.m. so all are requested to join with us. Thank you. Binu sir, Sudha ma'am, can we leave now?
Yes, yes.
Thank you, sir. Thank you, ma'am. Please join. Now we are ending the session. Tomorrow morning 9 a.m. sharply all are requested to join. Thank you all.